a necrosum in the pancreatic area or also in the left paracolic gutter. So now unfortunately I lost the video where I did video assisted drainage. So we have one of the drain sites. We have entered through the one of the drain sites, approached the necrosum, and once you know that how deep the necrosum is and you have found an access to the necrosum, you can make a little bigger incision and try and see and maneuver yourself and do the necrosectomy. Now, in this case, you can see that the entire cast of the pancreas has come out in a single cast. So this is completely necrosed pancreas. And being a retroviral positive patient, we thought this would be better outcome for him. It will give a better outcome for him because of his immunodeficiency status. So you can see that the entire pancreas has come out as a complete necrosum. So this is 1 to 2 days after the procedure. You can see how patient is really without much trouble. Now, there is coming to the second case scenario where a 30-year male had a gallstone pancreatitis, and again he has progressed to have acute necrotizing pancreatitis with a persistent fever and pain in the abdomen. Now we had waited for adequately for him to respond, but once he is not responding, we thought it would be easier for us to do a laparoscopic necrosectomy, because as you can see in this picture, the stomach is well adherent to the collection, and this is much earlier picture. We did this procedure much later on after 6 weeks of the initial presentation. So an anterior gastrostomy is done, a posterior opening is done in the posterior wall of the stomach. You can see the fluid gushing out from that place. As we aspirate all the fluid and make a bigger window in the posterior wall by removing a disc of the posterior wall, you will be able to approach the necrosum there. You can see the pus and the collections there inside. And again, doing these procedures laparoscopically can be tricky because it can cause a lot of bleeding sometimes. And you should be very, very careful in removing this necrosum. You should not force your way into. You should be very gentle in removing the necrosum. At times, you should flush a lot of fluid inside and take out the necrosum from the peripheries and gently remove the entire thing, as you can see this in this video. Always, I think it's better idea to put this necrosum into a bag, endo bag, and then take it out later on. So this would be little time-consuming process also, but it will be very rewarding for the patient because it's a very minimally invasive procedure, and the outcomes are really very good. Coming to another case scenario where a 28-year male, an alcoholic who underwent a lap appendectomy, unfortunately for pain abdomen, was later on found to have a severe acute necrotizing pancreatitis. And he was also not responding to conservative treatment. So initially a percutaneous drainage has been done, as you can see in this video. You can see that pigtail inside. And the patient, in spite of all that, he was not still recovering. And then definitely we had waited enough, more than 6-7 weeks for him to recover. And unfortunately, since he was not recovering well, we thought it would be a better idea to do a necrosectomy. In this particular case, because there was not good access to do a laparoscopic procedure, already patient had a procedure before laparoscopically, we thought it would be a better idea to do a open necrosectomy. So in this particular case, we had to do a necrosectomy openly and then remove the necrosum. And there were also many more collections inside the abdomen. So we had given a thorough wash, kept again multiple drains, and then patient had a very successful recovery after this. So this is again the specimen of the same patient and the drains which were there in the abdomen. This is one more scenario where similar patient had again an open necrosectomy. This patient had a necrosum which was pointing more towards the infracolic compartment. So after doing the necrosectomy, I thought, instead of just putting a drain there, we would at least cover it and do a something like cystogestomy. So in this particular patient, we covered that area with a jejunal loop, and then fortunately that loop has very well taken up, and then really, patient had a very good outcome. Similar to these scenarios, we have we can do endoscopic drainages also, and this again endoscopic drainages have revolutionized the outcomes further even more better, because the incisions are not there. The patients have very good smooth recovery after that. There are certain limitations in endoscopic drainages also, because if the necrosum is too much, it will be difficult for necrosum to get evacuated, or for an for a interventional endoscopist to remove all that. Again, the one important thing about the endoscopic drainages is the SEMS has revolutionized the drainage process. We can have a self-expanding metallic stent inside the stomach into the cavity of the necrosum, and then it can be repeatedly aspirated, and then we can even put an endoscope into the necrosum and then keep giving regular washes. So there are ways to deal with all these problems, and this is again the same patient who underwent an endoscopic necrosectomy and drainage. This is after a few weeks after the initial procedures. All the fluid is gone, and then patient had a very smooth recovery. So with that, I would thank you all for giving me this opportunity. Thank you.
Thank you, sir, for a beautiful case-based demonstration of the step-up approach. For the next Zoom-based session by Dr. Pitambaram, sir, on management of acute necrotizing pancreatitis with complication, we'll go live on Zoom. Thank you.
Good morning, everyone. Hope you can see my screen.
Yeah.
You are audible?
Yeah, you are audible.
Yeah, thank you, sir. I am Dr. Pitambaran from Hyatt Hospital, Palakkad. Today, my topic is complication of necrotizing pancreatitis with special focus on fistula and hemorrhage. And thanks, Vimalakar, for giving me this opportunity. So, yeah, as we all know, severe acute pancreatitis, which causes necrosis, usually associated with pancreatic and peripancreatic necrosis, with severe local inflammation, release of digestive enzymes, especially elastase and trypsin. So these enzymes get reactivated, causing damage to adjacent structures. Causes bowel wall ischemia, weakening, abscess formation, pressure necrosis, causing fistula formation. Sometimes iatrogenic injury during intervention, which also can cause bowel fistula. So there may be ductal dispersion, which causes secretion of the remaining viable pancreas, which causing a pseudocyst or walled-off pancreatic necrosis. Then it later forms fistulous communication to adjacent structures, more commonly to the colon. So this is a video of pancreatic necrosectomy. We can see that there is a necrotic collection. There's retrogastric area. The collection has been opened. The walled-off is relatively walled-off, and you can see the necrotic fluid coming out. So once the necrotic fluid is taken out, then the solid necrotic tissue, which has to be taken up by gentle kneading. Don't pull too much. We have to be very patient here. And combining with suction of the adjacent collection fluids. And this has to be put into an endo bag, which has to be pre-placed. And don't keep it on the peritoneum. And after that, give a thorough wash and give drainage, usually with the irrigation also. One thing we have to make sure is that before necrosectomy, we have to do a CCT abdomen with angiography, because sometimes there may be an underlying pseudoaneurysm, which is controlled by the pressure of the necrosis, which can rupture once you open the necrotic cavity, which can cause torrential hemorrhage and very difficult to control. Fistulous communication can occur to the stomach, duodenum, small bowel, and colon. And stomach, duodenum, small bowel are not much concerned because sometimes it may be therapeutic also. It is concerned when it is draining externally significant contents. Colon is always a concern. This is a CT picture of a patient with pancreatic necrosis. Patient had a distal cholangiocarcinoma with tumor-induced pancreatitis. You can see the necrosis all over. And this patient underwent a percutaneous drainage. This is after the percutaneous drainage, almost the necrotic cavity has been resolved. But however, this patient continued to have didn't improve, and then what happened was that there was patient was complaining of passing food particles to the motion. Hence, patient was further evaluated by oral positive contrast. We can see that the oral positive contrast has gone into the colon, suggestive of a duodenocolic fistula. So this patient was kept on nasojejunal feeding tube, and patient after 4 to 6 months, after 4 months, patient was taken up for surgery. The patient underwent a Whipple's procedure. We can see that this is the connection of the duodenum with the colon, which has been gently divided. This section is done very closely, and the fistula tract is open. You can see the fluid coming out, and you can even see the food particles which has been taken out. And once it is dismantled, the duodenum opening is closed temporarily with the sutures. Then the segment of the colon has been divided. Finally, the Whipple's procedure has been completed. Then did a pancreatogegenostomy, hepatogegenostomy, and a colocolic anastomosis. Chronic fistula causes sepsis, and it is suggested by the air in the necrotic cavity and fecal and maternal blood drain. Rectal contrast, if positive contrast if given, can delineate the site of the fistula. The septic complications are very high, especially in colonic fistula. The treatment hence depends upon the diversion, whether proximal diversion colostomy or ileostomy, with the drainage of the collections. This is another case history of a 56-year-old male with presented with pancreatic necrosis, developed a distal transverse colonic fistula. Laparotomy was done, found a necrotic colon. Drainage with defunctioning proximal transverse end colostomy was done. Patient improved. 4 months later, laparotomy was done, and proximal transverse colon to the sigmoid anastomosis was done. Because that intervening area was not visualized properly, which was the area was hostile. So this necrotic area was not touched, and the dense adhesions was not present, and hence the healthy colon anastomosis was done. This patient presented around 8 months later with huge abdominal pain and a huge collection in the upper abdomen. This is the CT picture of the same patient. What has happened was that the residual colon, which was present in that patient, continued to secrete mucus and developed a collection. The condition was explained, and it just managed by percutaneous drainage. So this is a drainage tube, and the patient improved symptomatically after that. The patient was explained the options whether to go for in surgery and remove the remaining colon, but patient was happy that he improved with percutaneous drainage, and he underwent almost 3 or 4 percutaneous drainage in past 5 years. And patient is okay with that. He occasionally comes after 1 year with the same complaints. He know what to do now. So bleeding is mainly due to the elastase enzyme, which is activated, which erode the elastic lamina of the vascular serosa, which causes pseudoaneurysm, later endothelial injury and hemorrhage. Pseudoaneurysm is very dangerous thing, and especially when we have to be very cautious, and all sentinel bleed signs has to be taken care of. And when there is a sentinel bleed, or when there is a fall in the hemoglobin, and each one episode we have to intervene and go for either for a CT angiography or a digital subtraction angiography. This is another patient with who underwent endoscopic cystogastrostomy with there is some residual collection. The patient presented with GI bleeding, and you can see the necrotic collection in the CT, and there is some hyperdense area suggestive of a pseudoaneurysm on the splenic artery. You can see that area, and this is the pictorial situ. So this patient underwent digital subtraction angiography. We can see that the pseudoaneurysm pseudoaneurysm can be seen with bleeding. So this patient, we can have many treatment. In this patient, the treatment was that endoscopic stenting, stenting with the interventional radiologist. So this is after the post-stent, there is no bleeding. Another method of controlling of bleeding is the endoscopic ultrasound guidance. This is the endoscopic ultrasound. We can see that the pseudoaneurysm in the pancreatic head, which is localized by the endoscopic ultrasound, which is confirmed by the Doppler. Once the Doppler is confirmed and you can localize the pseudoaneurysm, we can control it by endoscopic coil and glue injection. This is the injection of the coil and glue into the cavity. Once the cavity is obliterated, this acoustic shadow can be seen, which is suggestive of glue cast. And splenic artery is patent. You can see this is the pre-coil embolization CT, and this is the post-coil embolization. Another episode of bleeding is from the inferior pancreatic duodenal artery. You can see there is a bleeding from the inferior pancreatic duodenal artery. So this selective cannulation was done by the microcatheter, and we can see the small pseudoaneurysm from the branch of inferior pancreatic duodenal artery. This was managed by coil embolization. After coil embolization, there is no further bleeding. Surgery is usually not indicated in bleeding, usually rescue therapy. Indications are in severe hemodynamic instability, refractory to resuscitation, and failure of intervention treatment, and abdominal compartment syndrome. And usually it is very hostile abdomen with the frozen planes, which is very difficult to control the bleeding. The management option of intracystic ligation, that is open the cyst cavity and ligate the bleeding point. Another technique described as proximal control, but mostly if it is not able to control, then we have to do a damage control surgery, pack the area and stabilize the patient, and then go in again after 24 to 48 hours, or go for an interventional radiology treatment later. Another cause of bleeding is from the venous thrombosis, usually occurs from the splenic vein thrombosis, which causes left-sided portal hypertension, which in turn causes isolated gastric varices. Anticoagulation role is controversial, and especially done if it is the clot is extended into superior mesenteric vein portal vein. And gastric varices bleeding can be controlled by endoscopic glue injection or even endoscopic ultrasound guided glue injection. Rarely indicated, splenectomy is rarely indicated in bleeding gastric varices. Thank you, and I acknowledge Dr. Arun Kumar ML for giving me the virtual video, my teachers, my team. Thank you.
Sir, thank you so much for your talk on the spectrum of management of bleeding in acute necrotizing pancreatitis, sir. Now I would like to call the remaining faculty on the dais for a brief discussion followed by felicitation. Harish sir, Bharat sir, Prasad sir, and Dr. Raju.
I want to start the discussion by asking a question to the biliary pancreatitis presenter. Okay. Suppose you have a biliary pancreatitis patient who settles on conservative treatment. Normal recommendation is you do a lab call in the same hospital admission. Suppose you have a severe pancreatitis with necrosis as a complication, you don't want to do lab call in the same admission, which is the recommendation. In the intervening period, are you a believer of doing endoscopic sphincterotomy to prevent recurrent biliary pancreatitis?
For recurrent biliary pancreatitis, endoscopic sphincterotomy is especially done for those patients who are not fit for cholecystectomy, especially in the early stages. Otherwise, we in our institute don't follow this protocol, sir. Whenever he settles, okay. If it tell indication for ERCP is there, we'll go with ERCP, sir.
I have another case which I've seen recently. One more cause of biliary pancreatitis is coledochal cyst. uh, pancreatitis secondary to colorectal cyst. I came across a patient, 3-year-old girl with fusiform colorectal cyst, mild pancreatitis. What is your plan of management?
In biliary pancreatitis associated with colorectal cyst, the thing is pancreatitis will recur again and again. We should plan a definitive procedure by doing colorectal cyst excision in that case whenever she settles.
It's a mild pancreatitis, settled in 3 days. He is a 3-year-old girl. Even I didn't know the answer, so I'm asking all of you.
Then we'll take the opinion of seniors.
I mean, going in acute, one of the main problems would be most of the time in colorectal, in addition to the pancreatic inflammation, there's a pericolorectal inflammation also. The bleeding intra-op would be more. So it's better to wait for a couple of weeks before you do the surgery. Even if it's a mild pancreatitis, because
I'm asking especially because if such a patient goes to medical gastroenterology, there is a version that in fusiform colorectal cyst, you do a sphincterotomy, wait till the child grows up. Do you believe in that, or you believe in urgent colorectal cyst excision even in a child 3-year-old?
I'm not sure the incidence of recurrent pancreatitis in a colorectal cyst in a 3-year-old child with a mild acute pancreatitis, but I would rather wait, because extending the same argument of biliary pancreatitis after a cholecystectomy, 5 to 6% of them have a recurrent pancreatitis in spite of tackling the gallbladder. What happens, we are not very definite, because the definition of biliary pancreatitis itself can be questioned there. When you have an asymptomatic gallstones and an acute pancreatitis, should you attribute the acute pancreatitis to gallstones or not? Particularly if he is also an alcoholic. Should our guidelines be different in such a situation? But the standard advice is when you have both, I'm deviating, treat biliary as the primary, and alcoholic, definitely will advise him from withdrawal. They treat them as biliary pancreatitis. The recurrent pancreatitis is another entity altogether. I'm not sure, because considering the 3-year-old child, maybe I would wait till the inflammation completely subsides before you do a definitive colorectal cyst excision.
I think your advice is once the inflammation settles, definitive surgery for colorectal cyst.
Oh yes,
Sir.
definitely. Colorectal cyst itself requires surgery, irrespective of whether there is a pancreatitis or not.
Sir, I think we should look into the MRI. In MRCP, if we have ABPDJ, if you have ABPDJ with mild acute pancreatitis with the colorectal cyst, I think after 4 weeks, better to address, because the chance of recurrent acute pancreatitis will be very high.
There's
So,
no anomaly.
if there is no ABPDJ, I think we can wait till the child grows.
sir, I mean, this dilemma of in a fusiform, is it a form of frustrated colorectal cyst? It's more in the elderly, where it's age-related dilatation,
Correct,
due to a
correct.
sphincterotomy. But in a child, I think we should be more towards a permanent solution.
Okay. The other question.
So when you said dilated CBD, so what is the size for a girl like that when you consider really colorectal cyst?
It's anything above 4 to 6 millimeters is considered dilated.
But since there is
In that case, I'm telling you the MRCP report.
Yeah.
That it's reported as a fusiform dilatation of the common bile duct with mild pancreatitis.
Yeah.
Patient clinically settled. I was not sure whether to advise immediate, means she settled from the pancreatitis, whether to advise such a small child to undergo such a major procedure now or wait for the child to grow up.
Is there an entity of microlithiasis which you would consider in this patient?
We can never be sure if there is an element of microlithiasis.
Sir, if this child had come with the diagnosed colorectal cyst without any symptom at 3 years of age, we would operate. If she comes with pancreatitis, that will only call for a temporary delaying of the operation. And I don't think we should.
Yeah, that's why I'm asking. Immediate surgery versus whether you wait for the child.
That I think we have to decide based on the severity of pancreatitis, like adults. I think.
The other thing was Harish Gautam, you said in acute mild pancreatitis, CT you would want to delay. My take on that is, unless you are 100% sure, it is better to do a CECT to confirm the diagnosis so that you will be in a much better position to counsel the relatives of the patient and as to what kind of treatment, what is the likely outcome. So there is nothing wrong in doing a CECT abdomen, even if you think it's a mild acute pancreatitis.
No, sir, timing of the thing only. So we are doing a CECT scan, but the timing is like better to do after 48 hours. That's the only thing. If there is a diagnostic dilemma, we'll consider an early CT when the biochemical markers are not.
Any other questions?
Basically, if you do in CT scan in less than 48 hours, the chance of contrast-induced nephropathy will be very high, and the necrosis might have not evolved completely. If you have any diagnostic dilemma after 40 hours, because if the amylase lipase is raised, with the PCV is high, that is the only clue, that is an important clue that the patient is having acute pancreatitis. So most of the times, if the lipase is raised, 99% of the times it must be a. If you have any diagnostic dilemma, definitely you can go, but better to delay minimum 48 to 72 hours.
Yeah, another thing is in the first 48 to 72 hours, the pancreas enhancement and necrosis enhancement will be almost similar. So if at all necrosis has liquefied over the period of time, then only the enhancement changes. Then we can diagnose necrosis. That is the very basic thing of delaying 48 to 72 hours.
Micah.
Step-up approach now we have accepted as a standard. Now, has the step-up approach made the intervention a little earlier than before? Here's my question. Because certain times, in fact, quite a lot of times, you get a call from ICUs and from medical gastroenterologists. It's less than 4 weeks. The patient is not settling, high fever, a lot of antibiotics. And under normal circumstances, we would say wait, 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 and wait. Now, with this step-up approach and a minimal invasive intervention, would you consider early intervention? Here's my question.
I would still wait.
And if it is early, what kind of intervention? Is it endoscopic or percutaneous or hybrid or open or just medical management?
Sir, I would say that early approach again surgically is a challenge again, sir.
No, minimally invasive.
Minimal invasive also. If the necrosome is not well organized and well demarcated, and you enter into an abdomen where you have a chance of probably having a second surgery also, requiring a second surgery also. Exactly. So I think still it is valid to wait at least 4 weeks and beyond to do an intervention before, even I think, Prani, you can talk on that.
I think trying to now again go back to we'll intervene before 4 weeks will be like reinventing the wheel. So because the old data shows that just non-improvement is not an indication. But I think in the PCD scenario, just purely before 4 weeks, the only intervention you can do is a PCD, which is now an accepted this one. I mean, in which not well delineated. It'll just buy you some time. So I don't think minimally invasive other interventions are valid before 4 weeks.
If it is not an infected collection, I don't think we should even intervene in even with
before 4 weeks, it will not be a localized collection. It will be sort of generalized.
Generalized.
Percutaneous, you are really tempted to do. And sometimes when you do a percutaneous intervention and do a culture, they're all sterile.
Yes.
Then you would wonder whether you have intervened a little earlier than what you should have.
So the indication for percutaneous drainage should not be finding a collection on the CT. It should be that patient has some symptoms,
has-
fever, some infection.
Yeah. All those symptoms are there. You do not intervene just because there is
Collection.
fluid. Yes.
Sir, in Meenakshi, we have noticed one important finding. So the dilemma is between 2 to 4 weeks. After 4 weeks, if the patient is worsening, if the necrosis is there, if it is infected, there's no question, we'll go with the step-up approach. But between 2 to 4 weeks, usually, if the patient is worsening, if the acute pancreatic fluid collections are there, if the patient is worsening, in that at least 70% of fluid ratio versus 20 to 30% of necrosis ratio, we have done in around 20 cases endoscopic guided drainages. They have improved very well. So we have presented in one IHPBA also. So I think, it needs validation with the larger number, but still that I think endoscopy, if you have to do with some intervention, endoscopic is the
It all
only.
depends on where the collection is and who the approach is. If it is amenable to do percutaneous, then it's percutaneous is better.
We tried with endoscopy.
If you don't have an access for a percutaneous, if there is bowel covering all the collections, then probably if you find an intervention, find a way through endoscope, then probably endoscope would be better choice. Yeah.
In 2 to 4 weeks, I'll be very cautious, to convert it. If you do an endoscopy, you're converting a sterile into an infective. I would rather do a percutaneous rather than endoscopy.
Regarding management of the complications, one situation which you come across is you post pancreatitis, you have done a necrosectomy, put a drain, sentinel bleed is there. We generally say you do a CT angio and then see what is happening. We had a situation where sentinel bleed was there. We did a CT angio. We didn't find any bleed. What do you do next? Do we wait,
I think
you wait for the next bleed or do a conventional angio and do something?
The first thing we should remember is even the drains can cause some irritation, cause some bleeding. So always, I think it's a good idea to withdraw a drain by 2 inches, 2 centimeters, or probably 3 centimeters.
Pitambaran is online, sir.
And see if that helps. If you didn't find any source for bleeding, I think that is a good idea.
Question is for you.
Yeah. See, I would go for a conventional angiography because sometimes these patients are maybe in shock. So we may not be able to delineate the small bleeding sites. So this may be distinguished when you give an angiography under pressure, this bleeding site will open up. So even if the CT angiography is negative, I would prefer to go for a digital subtraction angiography in all these cases if there is sentinel bleed, because taking a slight risk is better rather than when the patient is collapsing.
So we did conventional angio. Even conventional angio didn't show a bleeder. What next?
Then we can wait, sir. See, if the convention, if suppose we make sure that there is no venous oozing or something like that, but I think we can wait in those cases. If you make sure that there is no arterial bleeding, we can wait.
I would wait. I would evaluate the intensity of bleed, intensity of necrosis and inflammation around before I decide on a conventional angio under these circumstances. If there is enough necrosis and there is there is likely to be a bleed which is going to be recurrent, well, that will be a subjective assessment at that stage. But I do not think I would do a conventional angio in all the cases because of the result, as Dr. Pratap Reddy is saying, that current CT angio not showing a pseudoaneurysm or an active bleed, conventional angio showing when a patient is not bleeding is not that high. On the other hand, when there is an active bleed, yes.
In an active bleed situation, suppose you are not sure which is the bleeding site, what next?
Then you have no option. If there is a significant bleed and CT angio is not demonstrating, definitely you would do a conventional angio while preparing for a surgery.
Any other questions regarding management of pancreatitis from the audience? It's on. It's on.
Sir, coming back to collections, like 2 to 4 weeks. So if the collections are significant with fevers, you don't want to drain it. It is very early to do a transgastric endoscopy. Some people started using anteriorly percutaneous transgastric drainages, which we can later use as couple of weeks. You can use it as, if the patient doesn't subside, probably we can use that as endoscopically, you can drain that.
Yeah. Both are options, percutaneous versus endoscopic. It's availability of local. Good morning, sir. Welcome. Both endoscopic, percutaneous are options. Whichever facility you are tuned to use and comfortable to use, it's acceptable.
Collections where don't have a significant wall, where transgastric can have, just endoscopic can have leaks, or we are very worried. So we can have an external transgastric drainage.
Generally, most
the anterior
collections
stomach.
post-pancreatitis are close to stomach. Then you go by the endoscopic approach. If not, you do the percutaneous. Even
Once
if
more-
it's early and is not improving on antibiotics and conservative management.
Regarding the DSA, one more advantage is, even if the patient is not in shock and stable, because of the bleed, there can be local spasm of the bleeding vessel. So that may not fill with the CT angio. That is where DSA might have an advantage with pressure injection. Just adding to Dr. Pitavaram's point.
Thank you, sir. Thank you for this elaborate discussion. I would request Vimlakar sir to please come on to dais for a brief introduction of our chief guest and the felicitation when we prepare for the next session. Thank you.
So, you all know, good morning, everyone. Good morning, everyone. There is no need for any introduction for Palnivelu sir. He's a mentor of mentors, teacher of teachers, legend. He's an inspiration for country. So we are so blessed to have you, him today in our GICS Pancreas second series. Sir, we are Team Vimlakar. We are working in Kim Sunshine Hospital for last 10 years. And this is our 10 decennial year. In that, we are doing every quarterly one series, GICS series. First, we have done liver, then this is a second pancreas, next biliary, next is a full session, sir. So thank you so much for taking your time and coming, sir. Thank you. Next.
A small felicitation ceremony. I request Pratap Reddy sir to please come on the stage. And remaining faculties as well. For a group photo, please. Harish sir, Raju Musham, and Prasad sir, Bharat sir. I would also request the speakers for the next session, Dr. Rohan Reddy sir, CH Naveen sir, So we start the next session on chronic pancreatitis. The session will have talks by Dr. Rohan sir, Dr. Naveen sir, and Dr. H. Ramesh sir will be presenting through a Zoom link, followed by a session by Vimlakar Reddy sir and myself. Thank you. So I'll call upon Dr. Rohan sir on the stage to start his talk on chronic pancreatitis, medical gastro perspective. Thank you. I request Dr. Fani sir to please grace the dais for moderating the session. Thank you.
Good morning, everyone. My name is Dr. Rohan Reddy. I'm a medical gastroenterologist. I work at Kim Sunshine Hospitals along with Dr. Bimlakar and his team. So I'm going to give a brief presentation on chronic pancreatitis, medical gastroenterology perspective, limiting myself to endoscopic therapies. So the first case I present is about a 35-year-old male who's presented with recurrent epigastric pain, diarrhea, and significant history of alcohol intake. Imaging revealed severe pancreatic atrophy, parenchymal calcifications, but however, there's no ductal dilatation. And his fecal elastase levels were very notably low. So this patient clearly had features of chronic pancreatitis, both on imaging as well as clinical symptoms. So he was just managed medically with counseling about alcohol and smoking cessation, dietary modifications, and pancreatic enzyme replacement therapy. Neuropathic pain was also speculated, and he was started on amitriptyline and pregabalin as well. So this patient clearly represents a set of patients who just require medical therapy. No intervention was necessary in this patient. Going on to the second case, I present a 42-year-old male patient with severe recurrent pain. Imaging demonstrated MPD dilatation to 9 millimeters and showed a large calculi in the head of the pancreas. So this patient clearly had pain secondary to ductal hypertension because of the pain, the stone impacting the flow of the pancreatic secretions. So this patient was subjected to an extracorporeal shockwave lithotripsy followed by ERCP and stone extraction. So as you see in the fluoroscopic image, the first image shows the pancreatogram, which clearly shows a large calculi in the head of the pancreas. ESWL was done where the stone was fragmented. Then later on an ERCP pancreatic sphincterotomy was done, and a basket retrieval of the fragmented stones were taken, and a stent was placed post ESWL. So post ESWL, the pancreatogram clearly shows that the amount of dilatation was significantly decreased over the earlier pancreaticogram. So there's another patient which had a similar calculi in the head and body region where ESWL was underwent and the fragmented were cleared with ERCP, and then a pancreatic stent was placed into the pancreatic duct. So there is pain relief achieved in about 60 to 70% of the patients post endoscopic therapy, both with ESWL and followed by an ERCP stone extraction. Surgical intervention was reserved for those patients where there was a noted endoscopic failure, where patients complained of recurrent pain post-procedure. There was a lower morbidity compared to operative approaches. So how do we manage pancreatic ductal stones? So there are different types of stones. There's calculi in the head of the pancreas, calculi in the head and body, as well as head, body. So the algorithm that we follow is any symptomatic pancreatic ductal calculi. If it is a small calculi, we go ahead and do a traditional ERCP with the extraction with a balloon or a basket. Larger calculi remitted to head or body without any stricture goes to ESWL followed by an ERCP stone extraction. Pancreatoscopy and lithotripsy are available, but we do not usually amend these procedures in these patients. Any failed endotherapy after one session of ESWL and ERCP goes to surgery. And when there are extensive calculi with multiple strictures and a suspicious inflammatory mass in the head, then the patient goes straight to surgery. So the next patient is a 38-year-old female with persistent pain with a main pancreatic duct dilatation of 8 millimeters. MRCP revealed a tight stricture in the head region, causing significant upstream ductal hypertension. So in this patient, ERCP was done, a pancreatic PD sphincterotomy was done, and a balloon dilatation was done across the stricture, and a plastic stent was placed. So this is a ERCP pancreatogram showed a pancreatogram which showed a stricture, a dominant stricture in the head region of the pancreas. This stricture was dilated by a CRE balloon, and later a stent was placed. Any recurrence of symptoms in these set of patients, the patients are usually subjected to surgical options. There's another hypothesis of a multiple stent strategy where the mechanism is proposed as a gradual ductal remodeling through sustained radial force application because of the multiple stent. So the protocol was to do a frequent stent exchanges every 3 to 6 months for about 1 year duration, and many strictures resolved without requiring any surgical outcomes. And there's another case scenario where a 50-year-old male patient who has come with a severe intractable pain, but a non-dilated pancreatic ducts on imaging. There was no evidence of any intraductal stones or strictures. So this patient clearly has a pain predominant pancreatitis without any pancreatic ductal dilatation. So this patient underwent a EUS-guided celiac plexus block. So this was mainly facilitated as a bridge to surgical drainage. So this is a video representing a US guided celiac plexus block. This is a CT image which showed a atrophied pancreas with normal pancreatic duct. US findings were similar where an atrophied pancreas was shown with normal appearing PD. So US guided celiac plexus was done. So once the celiac takeoff is visualized on the endoscopic ultrasound image, a US FNA needle is passed into this area, and block is given both with a triamcinolone and a bupivacaine injection. Next, I present a patient, a 45-year-old male patient with a significant pain and early satiety. Cross-sectional imaging and endoscopy revealed an 8 centimeters symptomatic pancreatic pseudocyst. So indication for drainage in this patient was particularly because this patient was having effects of the pressure effects because of the pseudocyst. US-guided cystogastrostomy was done in this patient where a lumen opposing metal stent was placed from the anterior wall of the stomach into the cystic cavity. So this is an image. This is an endoscopic video showing a significant pseudocyst, which is causing pressure symptoms on the stomach wall. So once the cyst cavity is got under position, the Doppler signal is seen to check if there's any opposing vessels across the drainage site. Then a lamps is placed into the pseudocyst where a direct cautery system is used and the needle is introduced into the pseudocyst. Once the needle is introduced into the pseudocyst, a proximal flange of the lamp stent is opened up, and then the distal flange is opened up inside the scope and then pushed into the stomach. So once the lamps is placed, endoscopy is done to see the correct positioning of the lamp stent. And later on in this patient, if there is a significant necrosis in this area, then endoscopy is passed through the lamp stent into the cavity, and then an endoscopic necrosectomy can also be done in these patients. So guidelines say ESG recommendations recommends treating chronic pancreatic related pseudosis if they are symptomatic, especially with abdominal pain, gastric outlet obstruction, any pressure symptoms with early satiety, weight loss, or jaundice, or presents with other complications which include infection, bleeding, rupture, or fistulization. So there are also recommendations that endoscopic drainage should be preferred over the percutaneous or surgical treatment for uncomplicated pseudocyst, and for those cysts which are within the endoscopic reach. And transpapillary drainage for smaller pseudocysts which are less than 5 centimeters, which have clear-cut communication with the main pancreatic duct. The next case, I present a 48-year-old male who developed jaundice secondary to a terminal CVD stricture because of chronic pancreatitis. The management strategy in this was ERCP with the biliary stenting, which provided a temporary decompression and jaundice resolution while definitive management was planned. So distal CVD strictures are also quite commonly seen in patients with chronic pancreatitis. The prevalence extends anywhere between 3 to 46%. These are usually reversible because most of the cases there's distal CVD stricture because of inflammation or a pressure symptom because of pseudocyst. And irreversible strictures happen because of chronic fibrosis in that area. So any calcification in the head means there is a negative factor for success of endotherapy, and these patients are straight away sent for surgical drainage. And single plastic stent is usually not preferred in these patients. There's a upcoming guideline saying that a self-expanding covered metal stent is the way forwards in these patients. So indication for endotherapy. So we do not treat all patients with distal CVD stricture. Indications are only in those patients who are symptomatic, where patient has cholangitis, the secondary biliary cirrhosis, or biliary stones complicating the stricture, or any asymptomatic elevation of the liver enzymes or bilirubin persisting for more than 1 month. In case of failed ERCP, where we could not access the pancreatic duct because of either a post-Whipple's altered anatomy or a tight inaccessible stricture around the papilla, or Despite multiple attempts, there was a failure in cannulation. EUS guided pancreatic drainage can also be attempted in these patients. So the big question is whether endoscopy versus surgery. I would say it's not either or nor. So I would always say endoscopy is a bridge while we wait for the patient to go into surgery. So surgery is better because it has long-term pain relief compared to endoscopic approaches. There's complete removal of inflammatory mass and reduces the disease burden. And it addresses both the ductal obstruction and parenchymal inflammation. And it is a definitive treatment rather than a temporizing intervention. So our algorithm says that so any patient with no significant ductal disease, so first has to undergo medical management. If there's any ductal disease, say there are pancreatic ductal stones limited to head and body and without any strictures, then the patient goes to ESWL followed by ERCP. Pancreatic stricture, single stricture, if initial endoscopic endotherapy is successful, then that's good. In the same case, in case of biliary ductal stricture, where multiple plastic stents and a fully covered self-expanding metal stent is working out, if the treatment is effective, then the patient follows up, or otherwise the patient goes for surgery. Pseudocyst, I would say if there is an endoscopic approach, then the first line therapy will be endoscopic guided stent placement, either with the plastic stent in case of pseudocyst and without any infection, or a self-expanding metal or a lamp stent in case of pseudocyst with infection or with significant amount of necrosum in it. And celiac plexus block in cases in those patients where we act as a bridge as the patient waits for surgery. Thank you.
Thank you so much, sir. Now I call upon Dr. Naveen, sir, to proceed the discussion on pseudocyst surgical management. Thank you. మనకి ఇక్కడ ఇలా వస్తుంది అక్కడ మనం వీడియో ప్లేట్ సెకండ్ ఉండండి
Good morning, everyone. I would like to thank Vimalakar sir team for the opportunity. I would be presenting on pseudocyst of pancreas. So I'm a practicing consultant surgical gastroenterologist at KIMS Kondapur. So as we know, it's a pseudocyst is a fluid collection adjacent to the pancreas or within the pancreas, encapsulated with a mature non-epithelial fibrous inflammatory wall. And the most common etiologies are alcoholic and biliary. 50% of pancreatic fluid collections resolve spontaneously. Other things end up in forming a pseudocyst. So why to drain a pseudocyst? The risks involved are rupture, abscess formation, hemorrhage, and symptomatic. And some patients will cause venous thrombosis resulting in portal hypertension. So checklist being, is it a pseudocyst? It is communicating with the main pancreatic duct. Will it spontaneously resolve? When to intervene or delaying the intervention, how to intervene, whether by endoscopic route, laparoscopic route, or an open approach, or whether to drain internally into the stomach or into the jejunum. So when to drain, this is a rough criteria of Warsha and Ratner, larger than, although it's not an absolute criteria, and when to operate. Cysts generally greater than 6 centimeters, persisting more than 6 weeks, associated with chronic pancreatitis are unlikely to resolve spontaneously. Coming to the differential diagnosis, always there has to be a differential diagnosis. In some cases with abnormal presentation, some cystic lesions may present without classical symptoms of pain, or some patients present with cystic lesions with pain secondary to pancreatitis. So pancreatic cystic neoplasm, hydatid cystic tumors, or extra pancreatic cystic lesions can be there, which can present as pseudocysts. So they have to be kept in mind. In case of differential diagnosis with a cystic neoplasm, endoscopic ultrasound without fluid analysis can be helpful. Coming to the locations, there can be in very close proximity to the stomach or within the transverse mesocolon, away from the stomach or in the left paracolic gutters or elsewhere. Some abnormal locations can be. In this cyst, we can see that there is a large pseudocyst with anterior scalloping of the liver with a communication into the main pancreatic duct with a small collection within the lesser sac. So I'll be presenting a case scenario where it's a 30-year male with history of idiopathic acute pancreatitis 3 months back. He underwent an endoscopic cyst drainage and stent placement. Now presented with fevers and pain abdomen. So we can see that there's significant inflammation of inflammation. So this is the gastrotomy being carried out. In this patient, because of previous stent placement, partial drainage of collection happened. So we could not see a significant lump which can be felt with an instrument. So according to the radiology, we had to open up the area of collection. And we could see that there is a lot of infected material. So a prior endoscopic drainage with significant solid component can make our treatment challenging, because the more the collection, it is very easy to do a laparoscopic or open approach. So this is the necrotic material which was retrieved. So most important part of laparoscopic drainage or drainage in a pancreas is either a leak or a bleed. So the walls of the cavity are being sutured such that the bleed from end of the walls can be prevented, because troublesome bleed from the cyst wall can be a problem in the post-operative period. So followed by anterior gastrotomy closure. This is another case scenario of a 80-year female patient with history of large pseudocyst. So this case was an ideal case for endoscopic management. However, she was denied endoscopic treatment in view of portal hypertension and collates within the gastric wall. So we had to do an laparoscopic treatment. As this patient also had, this is a case of biliary pancreatitis. So probably an open method would have been easy, because if there is a large anterior swelling, a very small incision would be easy, and surgery can be easily carried out using an open approach. And also a large pseudocyst will cause a significant space compromise in cases to operate laparoscopically. As this patient also required cholecystectomy in addition to cyst drainage, we have chosen open approach. Whereas very small gastrotomy, because there was a bulging cyst from the lesser sac which can be easily visible. So we did a limited, very small gastrotomy and a cyst puncture, followed by a stapler usage, followed by securing hemostasis of the gastric wall posteriorly, followed by gastrotomy closure. In cases of pseudocysts with which are away from always the transgastric group is generally preferred, but in cases where the cyst is away from the gastric wall within the transverse mesocolon, wherever feasible, so we do a cysto-jejunum drainage such that an external pancreatic fistula can be prevented. So a roux limb is created. So jejunojejunostomy is fashioned. This is followed by drainage of pseudocyst with an infected material in the transverse mesocolon. and a stapled jejunostomy with the closure of open edges was carried out. Take-home message, with pseudocysts, persistent pseudocysts with large collections, endoscopic with very less solid component, endoscopic and with the gastric access, endoscopic methods are preferred choice. And laparoscopic or open transgastric methods will be useful for significant solid components, or in need of cholecystectomy, generally laparoscopic approach would be a better approach. Laparoscopic cystojejunostomy when the cyst is not in close proximity to the gastric wall. Thank you.
Thank you so much, sir. Due to some unknown reasons, H. Ramesh sir has sent a pre-recorded video. We'll be playing this, followed by a session by Vimlaka Reddy sir, before we proceed to inaugural. Thank you.
Hi, good morning, ladies and gentlemen. I apologize for not being online because I'm in another meeting in Ahmedabad, as I told Dr. Vimlaka. Task is to summarize the video approach to dilated or undilated ducts in painful chronic pancreatitis being treated by a Frey procedure. And I'd like to emphasize the 10 commandments, which essentially means good preoperative assessment, good mobilization, good delineation of vascular structures, ligation of gastroepiploic artery, and to start with the body and neck when the ducts are dilated. And if the duct is not, then you can always start with the head and do little bits of the pancreas at a time and not in one fell swoop. And keep hemostasis meticulous with fine proline or bipolar electric cautery. And a 2-layer anastomosis that allows the scaffolding, which allows the second layer to really fall in place. I do a feeding jejunostomy if the pancreas was unhealthy or the patient was, and octreotide in select cases. This is a fresh areca nut where you can see that the principle of serial coring, not just taking it all in one group. You just take little bits, so you expose side branches, and you can lay open those side branches and create a spidery, process of head clearance. And in the end, you'll be left with only the posterior capsule of the pancreas. And this also allows you to have good hemostasis and not to occlude ducts, side branch ducts by indiscriminate suture placement. And at the end of the procedure, you'll find that all of the pancreas has been taken out. To start, again, stop. Even in undilated ducts, as you can see in this 3 millimeter duct, you can do an excellent head coring with ductal drainage and have good results. If the way to do it is to start at the head, you can place some sutures to mark the area where you want to start. Again, start with small cores and go on to deeper and deeper processes. Start by coring towards the duodenum first and then go towards the superior mesenteric vein. The anatomy must be delineated and keep the field dry so that when you find the telltale emergence of clear pancreatic juice, you can then gently probe it and open that duct out. So you need to be bloodless if you want to have a good approach. This can be done in any case where you find the pancreas is woody and the duct is difficult to delineate. You don't have to struggle to get the body and neck duct in the body or neck duct. Beg your pardon. So if you observe the process, then you can see that the duodenal side is being deepened first. Hemostasis is being achieved with bipolar electrocautery. And analysis is being used to retract and show us the area where you are coring. At the end of the coring, you can see that there is an area of clear juice emerging where a fine mosquito instrument can delineate it, and then you can lay open the rest of the gland. There you go. Epiploic artery expansion, we also find it difficult to dissect outside the pancreas, especially the neck of the pancreas. And it is important to mobilize the pancreas well, the upper and lower borders, get rid of the mesocolon of the pancreas, ligate the gastroepiploic artery, expose the superior mesenteric vein, and all of that is going to make your operation better. So if you start with the body and open the duct in the body and go all the way to the tail and then turn your instrument back and then you go to the head, then you can actually commence the head coring, as you can see here, all the way up to the duodenum. Take the first saucer. And when you take the first saucer, you expose some side branches, or you may have to do further coring. And the educated, sensitive hand behind the duodenum is the one which controls bleeding, which guides the coring. And again, the medial portion done first, and then you go towards the superior mesenteric vein side. And once you've done that, you take further saucers and guide it with your left hand. And that's why I still prefer to do this operation by open technique rather than by laparoscopy or by robotic surgery, because controlling of the duodenum is not easy. And you can see here that we are taking, every time we're feeling where the stones are, we are feeling where the indurations are, and then taking extra sources of the pancreas. This is an inflammatory head mass, so there's not the side branch duct openings which you can expose. You can use ICG to identify the bile duct and avoid it, or if you open it, that's not an issue. So the 10 commandments, once again, in the importance of meticulous technique and slow, unhurried process. And in some cases where you have serious additions, again, the importance of mobilization, the importance of cutting through cirrhosis or draining them separately, in abscess formations to drain and live to fight another day. And in portal hypertension, sometimes it's very difficult to do thorough mobilization. But you can get there by careful dissection. And what's more important, if you get many collaterals, you may actually drive the portal pressure up. So you need to monitor that. I want to thank you for your attention and apologize once again for my non-presence during this meeting.
I thank Ramesh sir for his presentation. Now I request Vimlakar sir to give his talk on robotic phrase, which will be followed by inaugural ceremony. Thank you.
Yeah. Good morning, everyone. As H. Ramesh sir said, I was also very much skeptical about doing minimal invasive phrase procedure. Though we were doing regularly laparoscopic Whipple's laparoscopic hepatectomies, but I was very skeptical to do laparoscopic phrase because the main hitch is that counter traction of the left hand while doing the head coring. Head coring is the utmost important thing in phrase procedure. Without doing head coring, just doing LPJ, I think it can be done with the laparoscopy or robotic. But head coring is the most important thing. For that matter, I never ventured into the laparoscopic phrase. But once the robo has come, we have started doing phrase. I think this is giving very satisfactory results. By looking at, as you all know, most of the patients are young patients. By looking at the scar of the open surgery versus robotic scars, absolutely anybody can opt with the less pain, less blood loss, and the less wound infections because the wound, there are no wounds in principle, and the faster recovery will be there. So what will be the ideal case? So basically, initially, we have to choose big ducts with multiple intraductal stones than the parenchymal stones, and with the mild to moderate atrophic pancreas with the favorable body habitus. Luckily, most of the pancreatitis patients will be thin only. So imaging is must to see how is the pancreas, how is the duct, what is the duct size, what are the stones, where are the stones, is it the tail disease or the body disease or the head and uncinate disease? And how is the anatomy of the SMV and portal vein and the CBD? And any abnormal anatomy is there, any splenomegaly is there, any collaterals are there. Usually the patient cart will come from the head end, and the position will be, the ports will be the 4-1-2-3 method we follow. 2 will be the camera, 1 is the left hand, 3 is the right hand, and 4 will be the Kedier forceps. The distance between 2 ports will be usually 8 centimeters based on the habitus of the patients. More than that, up to 12 centimeters also you can go. It will be like a smiley. Then while doing the supracolic compartment dissection, that is head coring, pancreaductal, cauterization, lesser sac entering, head coring, and even PJ, the patient will be in a head up and left up position usually. But when you are doing infracolic, that is jejunal limb preparation, jejunal for the Royenvy limb preparation, the patient position will be Trendelenburg position. So the instruments usually, the R4 will be the Kedier forceps, and the left hand will be the Maryland bipolar forceps. Camera will be in the center, and the monopolar curved scissors or mega suture while doing anastomose will be in the right hand. Additionally, we may place one port in between for the suctioning and helping. And the important thing is, the basic advantage of robotics is you will avoid a lot of assistance. So for that, to add on for that, retract the gallbladder with the suture. Anyway, in almost all Fraisse procedures, we remove the gallbladder. So that's why retract the gallbladder for the liver retraction and put 2 to 3 sutures for the stomach also. So no need for any assistance. Then entering into the lesser sac, left hand will be usually bipolar, right hand will be the monopolar scissors, and the adhesions between the pancreas and the posterior wall of the stomach is the most important thing. Up to the tail level, you have to clear, and in the head region, while doing, you should be careful about the loop of Henle, and up to uncinate process, you have to delineate. As sir said, upper border, lower border, and the SMV delineation is the most important thing in Fraisse procedure. And then we will proceed to the extended cauterization. This is with the bipolar or monopolar, and most of the times we use ligature of the robotic ligature. And while doing cauterization, previously for the Whipples also, people were, when they were converting from open to laparoscopy, they used to say cauterization is not possible. But after starting laparoscopic Whipples, we can do extensive cauterization beautifully with the laparoscopy. In the same principle, with the robotics also, the cauterization will be done better. But one more beautiful thing, if you observe, the Kedier is working like a human hand. So it is retracting duodenum. It is helping in every step. Then, as I said, the hitch for venturing into the minimal access Fraisse procedure is head coring. For head coring, the important thing is you need to have something from the posterior. For that, we have devised one technique called mop roll technique. We cut the mop into 2 pieces, we roll, we suture it. We will take such type of things into 3 to 4 that mops we will take, and we will stack behind after cauterization, behind the duodenum. You can see how it is lifting. While doing cauterization and after lifting, after pushing inside, we'll put the Kedier forceps to keep it constantly. So with that, we are able to do head coring properly. And the danger zones are portal vein, SMV, CBD area, and if any collaterals are there in the vicinity. Depth control is most important than the speed. So as sir said, bit by bit, you have to go very slowly. With this mop roll technique, it makes pancreatic head coring safer, provides effective counter traction, and ensures adequate and uniform head coring up to the uncinate process, and it protects the major vessels. So how to identify the MPD? It's like open technique only. If you want to use some spinal needle, you can use. Otherwise, one more thing, apart from the imaging. In imaging, you will know where are the stones, duct stones, and the predominant duct stones, which is the big stone, whether to start in the body, neck, or tail, or in the head region. You will come to know with the imaging. Apart from that, you can use the needle technique. If that is also not working, you can go for with the. I think seniors will accept that my statement. After doing few surgeries, in robotics also, you will develop the concept called visual haptics. Definitely, you will develop that visual haptics. So while doing only, you will understand this must be the hard, this must be the soft area, this must be the duct. this must be the stone. So with that visual haptics, you can open the duct most of the times. So it may not be the problem. If nothing is there, as usual, you start from the head coring, you will get into one duct, then you start doing that. So this is the head coring. So bit by bit, you have to do slowly opening one duct. Anyway, you've opened the main duct. So you come down from that. And if you see, the instruments are 7 degrees of free motion, and the dexterity, with the dexterity, so you can use whatever the way you want. Slowly, if you go with the bipolar, if you see in one video, I'm showing you left hand with the bipolar, right hand with the monopolar. But in one video, both are bipolars. One is a Maryland bipolar, one is a straight bipolar. With that technique, I think we can do slowly. If you want, if you're afraid, I mean, few people do that. Prophylactic ligation of the GDA also can be done. And in between, you can use the ICG to look at your CBD, and safely you can core completely down up to the uncinate. I think you are appreciating that, completely going down, laying opening of all the ducts, laying opening of all the ducts, especially in the uncinate. And if the tail disease is prominent in the tail, these are the most important things. A number of studies have proven leftover ductal stones are the cause for the pain, especially in the head region and the tail region. So then infracolic dissection, again, you take out that cardiac from there. You use that cardiac for the retraction of your colon. Then go for the DJJ, identify the first arcade, prepare the jejunal loop, and make a rent in the transverse mesocolon and pull that jejunum loop up. So what to use for the transection of the jejunum? You can use, if you put one more extra 12 mm laparoscopic port, you can use laparoscopic stapler. Otherwise, Sureform is also. Sureform is a robotic stapler. So Sureform also you can use comfortably. And after taking the jejunal loop into the supracolic compartment, now the pancreaticojejunostomy has started. If you do once, you will fall in love with the robo, and especially while doing anastomosis. See how beautiful the cardiac is helping you like anything. So after taking the bite, use that cardiac for the traction and then continue. No need for any help. The stomach is retracted with your sutures, and here the following of your suture is done by the cardiac forceps. So coming towards the head and uncinate region, whatever the way you want, you can use your hand. So that is a pancreaticojejunostomy proceeding. So wherever you want, you can use interrupted sutures also, because the cardiac forceps will hold that suture. It will come very beautifully. And it will be fast also. To my surprise, I've seen it is fast also. And then a routine jejunostomy with the stapler technique. So this is the thing. I think the important our Achilles heel of phrase is head coring. For that head coring, I think this MAP roll technique will help. And we will have a discussion of this inaugural session and after Palnavelu sir class. Apart from that, we thought of many things, hand assisted, all those things. But I think this will give you very good result, because if you put hand assisted also, you have to put big port. And I don't know. I mean, I've never tried, but with this, we could do proper head coring and the results are good. The patients are discharging in fourth or fifth POD. And this is about robotic phrase. We'll have a discussion after the inaugural. Thank you so much. I bring greetings on behalf of Kim Sunshine Hospitals and Team Vimlakar.
Thank you so much, sir. Now to take over the proceedings of the inaugural ceremony, I request please Manisha Bandari to come onto the stage. Thank you.
Okay. Check. Thank you, sir. So it is very delightful to see a huge crowd and the hall full. So now let us move ahead with the brief inauguration session to formally set the tone of the event and this beautifully going academic feast. So I request everyone to please stand up for invocation song to invoke the positivity and grace as we begin the session. Let us please have the invocation song. Please begin the invocation song, which states the pride of our state, Telangana.
Jaya Jaya He Gangana Janani Jaya He जीवन चावड़ी चावल विधायक विधायक जीवन
Thank you. You can all be seated. And this is a beautiful song which shows our state's history and sacrifices. So let us begin the inauguration session. So respected teachers, dear friends, Kim Sunshine Hospital and Team Vimlakar welcomes you to the second series of GICS, that is the case-based series, that is GICS Pancreas. GICS was initiated as a part of decennial celebrations of Team Vimlakar and conceived as a quaternary event the whole year. It is a platform where science meets the teamwork and learning blends with experience of all you dignitaries. And GICS proudly reflects the values of Team Vimlakar. Following the successful GICS Liver, which we have organized in October, we are delighted to see the overwhelming response from you all, crossing 600 registrations for today's event. Thank you all for the immense support you have given us, and this will continue further. Today marks a very special moment for Team Vimlakar, GICS, Telangana Association Surgical Gastroenterology, and Kim Sunshine Hospital. We are deeply honored to have with us the mentor of mentors, teacher of teachers, whose vision revolutionized the minimally accessed surgery and placed India firmly on the global map of GI surgery. He is pioneer and who has inspired our entire nation and the generation of surgeons who is none other than our beloved Dr. Palnivelu sir, who is a founder of GEM Hospitals and needs no other introduction. Sir, it is our very privilege to have you today, and thank you for making time and coming here, sir. We welcome you very heartfully. Thanks. Let us proceed further with traditional lamp lighting, which marks the beginning of every auspicious occasion, seeking the Almighty's blessings. May I now invite our chairman, Dr. R. Shastri sir, chief guest Dr. Palnivelu sir, Dr. Pratap Reddy sir, the brainchild of GICS, Dr. Vimlakar Reddy sir, TASG President, Dr. Harish sir, please proceed forward with the lamp lighting, sir. I request all the dignitaries of the dais to please stay back to felicitate the chief guest of our occasion today, Dr. Palnivelu sir. So please, we'll proceed forward with the felicitation of our chief guest today. We are very delighted to have you here, sir. Thank you for making time for us and sharing your thoughts today.
I will request our chairman, Shastri sir, to give a small vote. Thank you.
Distinguished guests, colleagues, standing here today feels like a kind of homecoming for me. 2 decades ago, during my tenure, while heading the GICS at NIMS, we went through the same series of organ-based CMEs lasting over 2 years. In fact, 2 series. So Lakshmikant is here. And many of the other colleagues still remember the series we had. Today happens to be an important celestial event. I do not know how many of you know that the sun god starts his northbound journey today in his 7-horse driven golden chariot. It's called Ratha Saptami, dispelling all the winter shadows and darkness to summer brightness. I think the start of this augurs well to the same kind of situation of dispelling the ignorance to knowledge and wisdom. We are honored by the presence of stalwarts here, some of whom have redefined pancreatic surgery in the country and in the world. We are privileged to have them here. And I see our friend Vimlakar following the same tradition of a series of organ-based themes, celebrating his successful 10 years in sunshine. Let sun, as he shines today, shine on the progress of his work. And not only that, let those who are attending, I urge you to gain the wisdom from your seniors and the precision of surgery from the younger surgeons who are demonstrating their laparoscopic and robotic skills, which is the future of surgery. I think it's important to cultivate this gradual change in the perspective of pancreatic surgery, the nuances of not only the surgical precision and skills, but the principles behind them, how they are consolidating themselves into definitive guidelines from the earlier vague principles. I think it's a great occasion, and I welcome you all. Thank you.
Now I request our chief guest, Dr. Palnavelu sir, to please come over and address the gathering and also proceed with his talk. Thank you.
Good morning, friends. Appreciate this audio is going on. Amlakar working me to come all the way. I was yesterday at Karimnagar, and after the course on safe lab quality, I'm here today sharing my own experience. And going to be next week again, going to be in Hyderabad for MMAS program and HPP, same related subject. I think it is all of you are aware that Association of Medical Surgeons of India has taken up initiative to a next level. When I was MS postgraduate, there was no MCH, no surgical gastroenterology. Later, surgical gastroenterology came up without a degree at Chennai, Pune, Delhi, and many places as an individual experience base. Later on, MCH was introduced in surgical gastroenterology. And even Sastri, I think when he started GI surgery, there was no MCH. All of you by experience were promoting it. That way, it is very happy to see that youngsters are sitting. And MRC has got its own commitment to promote minimal surgery It is not basic laparoscopic surgery. It has all been there last almost 35 years more. My more alone 36 years, my experience laparoscopy all went through. Now it is like those days, no specialization, but later specialization comes. Now individual organ has become a specialty if you go Japan, Korea, and other countries. So MMAS program is the initiative of MMAS for upper GI, colorectal, HBB, bariatric, areas like a different way being. And anyone wanted to get update your own surgical skill, both operative technique, protocols, and next level you want to move, and kindly participate from our next week MMAS program, going to be at your own place. And it's not only that, you also can convey your all friends in Andhra and the nearby states to join in this program. Then you can appreciate how much this technical evolution has happened. Because in the beginning, not technically proper evaluation, we improved over these years. Now today we have a consensus for people, and we have everything is made a protocols going through. And today is this program, and congratulations to Kim's Sunshine making it GICS program, a series of program. Last it was October liver, now it is pancreas, next going to biliary. Yes, this is very important. Similarly in Bangalore also, Bangalore Medical College also doing it last almost more than 20 years. Same series, organ-based specific, because it is a broader subject. You cannot go on everything in 1 day or 2 days, 3 days. It is not possible. And organ we have to do. And youngsters, you have to update yourself up to date. Otherwise, after some time, you all have to be keep quiet from away from your clinical practice. The way technology is taking over you. Initially, laparoscopy people said, oh, no more surgeons have a role. Laparoscopy thought it is not a surgery. People also took it, it is like a, sir, don't want a surgery, I want a laparoscopy. That's why they took it different because it's minimal invasive, new concept. Later robotic came, people said laparoscopy is going to be away. It is only robotic. Now AI is coming, already started coming. So hereafter, even Elon Musk already last week said after a few years, there is no role for surgeons. No? So that means you have to keep open your eyes, mind, and keep learning up to date yourself. Otherwise, very difficult to thrive here. And if you don't know the guidelines, common people easy to go into Google now itself confusing us. And AI is going to give much more information to them. They will be, if you don't update yourself, they will question you. Dr. Saab, you have to learn, no, before practicing it. That way the people, even the one robo which I have in Chennai, yesterday I was mentioning Karimnagar also, if I hold the instrument slightly tight, it says doctor holding tight, relax. Machine teaching now. Those days, Sastri, you all remember our teachers who hit with the instrument teaching, yeah, properly hold, retract, this was the, remember many of the postgraduate going assisting professors afraid, no? By the time coming, there are a lot of pain also there, it has happened. Now change machines. Sometimes if Indian movie, I don't know how many you've seen Indian movie, no? Indian movie, that if you give feedback to it, it will behave differently. It can be hero, it can be villain, it can be either way. So surgery, if you don't properly do it, in between message, you come, doctor, you are not to mark better. Can you ask senior to come take over? Or at the end of surgery, it gives you mark up to are you passed or not. So later on, legally, if you go, legal also will ask, what is your standard level, no? We have to tell them that AI will be giving you mark 60, 70. The court legally goes against what is your mark by AI, no? So this is going to be a problem future. All of you keep proper, then only we can thrive successfully. Otherwise, one enough, and everything building may be too high, but base, if it is not proper, collapse will be there. That's why I'm just a small as a senior giving a tips and starting it. So this is a CME program, gives you updating. This is a very tight. So I appreciate you. Now, my talk is going to be in pancreas, Whipple's, troubleshooting, how to manage during the surgery. I'm not going to talk post, but everything is preventive. If you make a complication like bleeding or duct leak, you're hell of it. That's why you have to prevent and doing a technique. Since there are looking at young, I could see young faces. So before that, going troubleshooting itself, I'll show what is a standard Whipple few minutes video. Then I will go the troubleshooting. I will talk about. Hey, I don't know why we went through that. Okay. See, this is a video. I'm going to. Is it full screen? Yeah. Off the light, please. like this also. See now, as Vimalakar also shown retraction, that liver has been retracted with a simple retracting suture. And we are opening the gastrocolic omentum. And exposure, you can see, it is full. No? Subaptic exposure is low. Third part of the duodenum also exposed. Now we are doing coccus maneuver after taking down the colon down. You can see IVC now, so complete. And more medially, you have the aorta, and you can see SMA artery pulsating and the celiac axis. Even IPDA, you can control. It is called artery first approach. It is post artery first approach. There are various types. One is like this. See, I put a clip at the IPDA controlling it. This Whipple was done in a 13 years old girl for Whipple, imagine. It was rarely, Whipples, young people, very rarely. So tunnel has been created and this vessels has been clipped. I'm preparing the duodenum and the antrum, where what you planned already. I planned already gastrojejunostomy and duodenostomy, so I divided it. Now you can see the ligament. This is a gastroduodenal GDA I'm looking for and taking down. GDA initially used to put a titanium clip sutures, intimal tear, pseudoaneurysm, bleeding more. Nowadays we use only first clip is a hemolog, and hemolog is not a tear, it just occludes. Now you can see I'm dividing it. Now duct is undilated duct also can make a prominent or distended by taking a stitch like this with a cotton tape. Now I'm making two hemostatic sutures. It's not hemostatic truly, it is a handling suture. Now you're preparing the jejunum, taking this to the other side. When you're doing it, then by the time the duct distended, so I'm making a pancreas division. During this time, identifying the undilated duct is the most important. Now you can see distended. I'm cold cutting. No energy, harmonic or cartridge or anything to that side. Then another innovation, I made it traction of the head of pancreas, you can see. And anterior to the head, uncinate, posterior to the uncinate, you have a space work on. If you put a saline of blood, it goes down, it will not. So I started taking uncinate vein, then going slowly. It is SMA margin clearance, you can appreciate. This is superior pancreatic vein clipped and dividing it. Now you can see that vein has been posteriorly dissected. Now a tape is lifted up the SMV and portal vein. So SMA is pulled to the right side. Normally, it is always posterior left side, and it is on the right side because my rubber band and it is pulling the artery. And as also see, no instrument coming. The head is being retracted anterior and laterally. Now I go to the gallbladder. So now look at cystic artery, duct is clipped and divided, bulldog clamp to cystic BCBD. CBD also not dilated, very thin, fragile. Non-suprapubic incision, this is where incision used for every specimen extraction, gastrectomy, Whipple, liver or anything, because suprapubic is. Now you can see clearance done, hemostasis perfect. Then we go, then I'm making a reconstruction. And first anastomosis is epidojejunostomy, end to side. And you can appreciate undilated duct also because of magnification 10 to 15 times, you are able to make it a suturing continuous or interrupted. Undilated, we use interrupted, continuous for dilated ducts. Now I made my own technique anastomosis, modified Blumcut 2 sutures, and remaining is dunking. You can see posteriorly I use 40 PDS and making an enterotomy according to the size of the PD, pancreatic duct. And initially, you all know interrupted suturing we used to do. I learned from my Chinese friend, Chendu. He is described as continuous suturing ductal mucosa, and I'm taking continuous suture. Stent always we place it. Now you can look at 40 PDS, then L50 PDS, then anastomosis. Subsequently, the 40 which I'm using it for dunking, same suture continues back again and graft it. And finally, that 20 or 30 from again anterior doing it. It is modified Blumcut and dunking together. And this technique I found leak rate is almost zero. If at all leak occurs in a less than 1%, it is a grade A and B. C, I don't see it. See, again also we put a momentum wrapping the anastomosis, it gives a vascularity. Now, finally, again, delayed gastric emptying is one of the problem everybody is looking at. Now, I have an anastomosis called end-to-end functionally, end to side actually, making a function anastomosis with two cartridges and feeding jejunostomy goes from the different side. We start giving the feeding through nasojejunal from 12 hours onwards. And with second, third day, fluid cutting it. I think Sastri will agree with me. He has seen me live the different technique, by over these years, we could improve it. Now we go back to my own topic, which they are given to me. And one more, I think this postgraduate is there. I will show that also before going in. Suppose you're not able to identify duct at all, very thin, what to do? Anastomosis. Yeah, pardon? I will do it. Yeah. Now I am going to show a small video clipping. Here, see, I tried my best to identify. This I had done only less than 10 cases totally, because magnification allows me to do duct to mucous anastomosis. Now you can see posterior. This starts with the completely coming back. You can appreciate. There is the first Blumhardt suture, transpancreatic, finishing it. Then finally, what we take it posteriorly. This 30-degree angle scope, nicely giving it. And robo laparoscope, from my angle, it's the same. How surgeon learns and doing it. I do robotic laparoscopic. We did a comparative study also. Currently, I cannot say superior, which is superior or bad. No, cost only is making a difference. Now, see, posteriorly, I finished it, one layer. Now, I am going, after this suture, I'm leaving it behind and opening the jejunum, enterotomy, according to the size of the parenchyma, but little less than that. That is better than only it will. Now, you can see lower edge and the seromuscular starts with coming down like here. I will faster. I don't know this jump now. Okay. See now, and again, it is coming back. There is 30 PDS and turning back, going anteriorly again. So this is a dunking suture also we should know. Otherwise, you cannot do duct mucosa, you can't leave back. And no need for conversion, one can do very well. What you are going to do? Open, the same thing we do it here. Yeah. And always keep the suture compressed for a little while. By the time the space between taken over, then see, I am putting my instrument, pressing it gently, then going. But not too much, the parenchymal tire laceration will be their problem. Okay. This type of two anastomosis is there for reconstruction, is fine. Now, I'll go to top few slides, I will make it up. So, troubleshooting and tacking. Yes, I will make it there. Okay. Here, this is my GEM Hospital, New Cancer Center, and Elite. Anybody comes to Coimbatore, you can see. Because why I'm telling, no, look at Sunshine or look at Hyderabad hospitals like giants. I'm from cottage in a small house coming up. This is bigger for me, na? Lifetime achievement here. But all facilities, everything, complete cancer. Now we went through this. So now we look at, one should not meet a complication and try to manage it during surgery. That is always going to be a problem. So predict complication, which patient is going to develop. So pre-operatively, it said we all experts, team HBB group, can sit down, discuss what problem this patient is going to be. Each one will have its own. Under duct system or chronic pancreatitis or ERCP done pancreatitis. And if it is recurrent stenting done for periampular carcinoma, biliary pancreatitis, the biliary cirrhosis liver, all things you have to discuss and go to surgery, then you can make it up. And here you can work out, you can have a, and where we have to go. These are the most important things is avoiding bleeding, going correct plane dissection it, and you reconstruct proper way, come out. What type of reconstruction you can plan. But the important thing is recognize, respond to decisively, and recover safely from that. Even if you need to convert, don't hesitate to convert. Safety is more important of the life of patient than your ego of being minimally invasive. It is not that. And what are the favorable factors beginners can do without troubleshooting? One can choose a low BMI, normal BMI. One can dilate the duct system. Imaging-wise, clean, no pancreatitis features, and normal vascular anatomy. One can choose. But what will be the problem if you trouble expiating it? Pancreatitis, borderline cases advanced, and already patient underwent chemo radiation, and history of pancreatitis, ERCP done, severe pain following it, and obese patients. And these are the things one should anticipate troubleshooting during surgery. And now we look at what are these things one have to know beforehand. More important is biliary anatomy and SMB portal vein variation or normal, and GD artery where it takes origin from, SMA abutment, how much it is there or not, and replace hepatic artery. These are the things one should know beforehand. And so very important here. And you can choose what kind of energy sources you need, what kind of instruments, where to force the place, trocar, everything preoperatively you have a plan to go. And it is not that surgeon who are doing it, team, including the staff nurse, anesthetist, has to jointly discuss what should be, because Whipple operation is not that simple laparoscopic robotic going into doing it. If a patient develops, that patient is a particular patient, it is 100% problem for him. No, that means we have to be more safer. Me? Look at, okay. So conversion is always and should have, when happens, what problem, when to convert, that is also depending on the surgeon's caliber and everything. And bleeding is one of the most important troubleshooting during surgery. And bleeding can be from vein, can be from artery, can be from mesentery, or various ways. Everywhere, wherever it dissect, it can be a source of bleeding. And you should know how to control bleeding. And if a bleeding, suddenly don't become panic, start controlling, put a clip or emergency sources of plucking. No, don't do it. You should always, you are going to have a gas piece will be inside. Take a gas piece, press at the site of the bleeding. And if it no further bleeding there, keep quiet for some time. By the time you discuss with your staff nurse and assistants what it is going to be, how to manage this one, that discussion should be there. And then finally, and decide and go ahead. Use suction, take out, suck out all the bile, then blood, then finally slowly leave the gas piece. You can see the bleeding point where happens, and look at the bleeding point, how to manage. You can do it very well, and that is way. If anesthetists know, they will be helpful. Everybody will doing it. But if a bleeding further, how it can become worse if you are not proper. If you use energy source, no, thinking that ligature is so good, bipolar you can use it bleeding. That way, try to energy control bleeding will make you worse than the problem, unless until you identify the bleeding point. And blind clipping, don't do it. That is very dangerous. Will make it a even reconstruction, you can't do it. So after pressing it, chase where exactly is bleeding, it is there or not, go. And if you are not able to decide that, comfortably as a staff nurse, always open table must be there in the beginning. Convert to open and do manage it, or keep press and call your senior surgeons, whoever can manage and open, let them manage it. That means you preoperatively all instruction to given your own colleagues, very important. And okay, after you identify pressing it, what we'll do, skeletonize the area, dissection proximal distal. That's why I always say prevention is, before even abutment or infiltrating vein, don't go dissect at that site, tumor site. Dissect proximally, distally. You have a clampable vessels where you can put a clamp. That amount of dissection, do it, then go to the tumor. Even if it bleeds, you can put a bulldog clamp and make it easier to control. And always control bleeding doubly. Don't depend on one clip. I will show a video later, you can appreciate. And GDA, those days GDA on table also will be problem. And post-operatively GDA pseudoaneurysm was the most important problem. Everybody used to say about it. Nowadays, initially I had, post-operatively also have to do laparoscope or open for GDA bleeding. Nowadays I don't see, because we know how to control GDA, managing it. That is very important. And here, repair, you can do laparoscopy, you can, or not possible, you can convert. It depends on individual surgeon, the team, everybody. Starting a Whipple operation, evening 6 o'clock, by the time you are tired, everything, then you want to do laparoscopy repair, that patient will have the brand, you will at the end. So if you are must be comfortable, fresh, your mind should work well, then you can attempt, even if you are skilled. If you are tired, if you are after all this, then better to convert or give it to other team of people to take over. And convert, when to convert. If you are not able to see the bleeder proper and anatomy lost, and tear is a little wider, lacerated tear or energy source used harmonic, it cut part of the vein gone, then it is difficult to reconstruct, then one must be. And the last point, which I already mentioned, not only surgeon, all the people are tired after doing so many cases, not possible. Repair is essential, and I had a lot of patients. I managed it. It was all in the beginning. Nowadays, we don't see. So if you want to reconstruct simple layer, use 5060. And nice, gentle bites more important. And there should not be bleeding at the site of, that means should have a bulldog clamp on either side, control bulldog, vascular clamp, then you go ahead doing it. And see, this is one I was demonstrating live at Ahmedabad, and I was mentioning this is 1 point superior pancreatic duodenal vein can bleed. That's why I mentioned I was working at the lower down. Suddenly there was a bleeding I could see. Immediately went, I know where it is coming from. So you look at, and I can't jump faster. Okay. See now, the clip, titanium clip is a bad. I applied it, it got a crush. Now you can, I'm making a little more bleeding. And it was live surgery demonstration in front of American faculty and other senior surgeons from different places. Then I able to suture, control it, came back. Because it is a small and it is a site of the spirit vein, I'm without a bulldog control vascular clamp, I could do suturing it. Okay, this patient, as usual, went back and home, no problem. Next one. See now, so you can see, no. See here, okay, now look at portal vein, SMB here, this is a portal vein, this is a GDA here, this is a hepatic artery, common hepatic here. Now, I don't know why it is some problem in the vein, no? Long time. Here, there was one tributary coming from portal vein and harmonic scalpel, which you all 10 mm know, you those days straight tip. It was done in the year 2003 or 4. It was bleeding. Then I put a clamp on that side and sutured it and finally went through. I don't know whether there is so. This is another case. GDA, I put a clip. Again, titanium clip. This all they happen in the first long series. Now, I put a bulldog here, then, and left hand using it, and remove that clip, putting it, double clips, checking it, then came back. I should not put a clip over the hepatic artery and making a problem. Those days, no ICG, no? Nowadays, we can do ICG, whether flow is there or not, or everything can. So now, this is another case. That is unlike, this is, we thought this can go through well. There is no infiltration in the SMB. But there, during surgery, I'm not able to get it out. So what, okay, we have to go through resecting the vein. So you can see clamp, vascular clamp on either side, and the tumor mobilized and resected. And we can appreciate reconstruction of the portal vein here. This also must be not troubleshooting actually. It is identified, you can't leave it back. You can't leave a residual tissue come back, one wanted safety laparoscope. No, if you can't do, you have to open and doing it. And by doing a venous resection, and it does not add morbidity, it does not compromise the oncological safety. Okay, this way you can then take it out the bulla clamp and the vascular clamp, then you can appreciate and be here. Now, this is replay hepatic artery again. Those days, nowadays, your imaging system so perfect, you know exactly whatever. Sometimes will come. If it is replaced artery suddenly injured, then it is a problem. The right liver is going to be a trouble. That's why it is also more important. And now this is adding and this on. See now, I was thinking that going through very well everything clearance surgery finally happened to be right hepatic artery was cut from the common hepatic artery. And 2 cases we had over the 1,500 whipples. One was beginning, and that was tumor is bigger, reconstructed. Now this is again. Now reconstructed, after reconstruction, and they take it down. You can appreciate pulsation also. You can see pulsation. Again, you can use ICG and check it up, flow, everything is fine. So mistake can happen. One should not be adamant, oh, I'm an excellent surgeon, I'm doing it. No, anybody can do mistakes, trouble can come. This a time, if you can't do reconstruct, open and convert reconstruct by yourself or a vascular surgeon of your team, you should do it. So, and this is where there are some problems will come. The another thing is, and and sometimes when you use energy source, when the duct is not dilated, and there it will be sealed, and you don't know. See, this is a video. See, I don't identify the duct, pressing it coming. Then I can't do anastomosis at this level, so I have to trim and identify it. See, you can see. Now you can see the duct, such a nice duct has been sealed by the harmonic. So it is also trouble. No, you can't do reconstruct. Sometimes you may not be able to identify, you have to take a trim of these tissues. Then that is very important to here look at this. Then I can go for reconstruction. And the second, fragile pancreas, here want to reconstruct. This is a loop, a diverted loop technique I introduced. And pancreas and the gastric outside, biliary second. Pancreatic juice and biliary is together make the worse, no? That's why I made it this. And it is published also in American Atlas. I wrote the chapter also this regarding this. Okay, I'll finally do couple of slides. I'm finishing it. See, this is another, this is actually post-operatively and bleeding. Yeah, and this is next day. See, everything looks nice, patient comfortable, pulse rate normal, everything, but drainage tube taking about 300 ml of bile. Then what to do? Then I knew my anastomotic technique was there bad. And see, I went inside and posteriorly it was leaking. Anterior sutures are removed and taking it out and reconstructed. Second day you can do it. Second, third day, it is, we can see posteriorly there was one stitch when we cut together, it cut close together, that knot has got slipped. That's why I could do it again, reconstruct. This patient went through normal course, went up, no problem. So posteriorly I put a few interrupted, then reconstructed. So it also can be done. Re-laparoscopy is another, if you do robotic Whipple problem, you do laparoscope, you can do it. And if you do a laparoscopic also problem, you can manage. Most of the companies can manage laparoscopic. There are sometimes smaller bleed only. Sometimes collection will be there. Patient may have that come back, don't do anything. Patient will be recovered. So this is yeah.
I remember like things.
Again, okay, yeah. So what else more important is after DDA suspect replace hepatic artery, everything carefully go. ICG very helpful, and this is already shown. And this is SMB when you dissect, you go in a proper plane, then you will not have problem. This dissection is called spine of dissection. That means very important, and spine must be protected. SMA plane, don't use energy source to the vessels, particularly to vein, and no shortcut. Carefully go, you can do make it up safe. And how it helps? So early unresectability you detect, clear oncological plane, and slight oozing also give importance to doing it. So you can reduce your surprise during the surgeries. And high risk, you all already mentioned, is when working with SMA, bile duct, hepatic artery, you must be very careful, stump, and use cold energy source, which I already mentioned. Reconstruction technique, I already told, pass through. And a soft gland, a small duct, and this also you can use it. If you are going to have a less leak rate, you should no tension, no ischemia, and posterior. That's why during surgery you carefully. Strackling tragedy is you can reconstruct very well because of magnification, clarity, then open surgery you have. And these are the things, risk factors you keep in mind. I will pass through. Suppose you are doing Whipple and you have to do doubtful, and whole pancreas may be chronic pancreatitis like. We don't know whether it is a tumor or it is a chronic pancreatitis. You cannot cut, reconstruct, come back by the time they report margin pancreas negative and positive. That means you doubt is there, do frozen biopsy, wait for half an hour. After the biopsy, you can extend your dissection, making little more, taking the neck and the part of the body. No harm, 2 centimeter, 3 centimeter, you can take it. Sometimes it also can become positive. Or you do an ICG, or you can do end ultrasound, shows tumor extending in the body, then you have to go for total pancreatectomy. We have done 10 cases, more than 10 cases, 10 or 12. We have done total pancreatectomy no other way. If you can have an RO resection, go at left. Only the risk is monitoring of the blood sugar and everything you can do well. That is why you can do it. And troubleshooting, I think this is mentioned, interrupted. I don't want to go here. And judgment is finally causes. So it is signals always, if you know what, you can have all the problems to face it and also reconstruct. I think these slides, my PGs have done it, I will pass through. And finally, predefine your And during surgery, keep it careful. And all the vessels, you look at your own, then no problem. So discipline, restraint, respect the anatomy more important, and have particularly chronic pancreatitis, be careful in taking complete clearance. And at this junction, I've taken a little more time. I'm sorry. Thank you very much for patient listening. And any questions allowed, I can take it up. Otherwise, I will proceed. Thank you very much, Mark, for everybody.
Thank you so much, sir, for a beautiful talk, sir. It was a very elaborate and informative. Thank you so much, sir. We'll close.
Yeah. Okay. Thank you. Thank you very much. Wish you all the best. Happy New Year. Enjoy and keep moving always like a Kaizen word. Keep learning, move upward. That's all. Thank you very much.
Sorry for this mild deviation in the session that we had because Palamelu sir had to catch a flight. I would just request Fani sir to please come over the stage and conclude the session on chronic pancreatitis before we proceed to the next session. Thank you. Any discussion or any? We'll keep it crisp, sir, maybe around 5 minutes, and then we'll have a small felicitation and we'll proceed to the next. Thank you, sir.
One question for each speaker, at least, like to in the spirit of discussion.
So I would request Rohan sir, Naveen sir,
Rohan,
to be
Naveen,
available. Vimlakar sir will join soon.
And Vimlakar, yeah. Firstly, congratulations. The quality of the lectures was excellent. So, Rohan, in your, I think the case 3, you showed that even for strictures, when there's dominant strictures in the head, you can manage them endoscopically rather than surgically. Is there any clear-cut criteria based on literature? How do you select? Is it like length of the stricture and the time, how much time you can attend endoscopic therapy before you refer them for surgery?
Sir, if it is a one dominant stricture restricted to anywhere between head and the body, and if the wire is going across easily, and if we usually give, there's no clear-cut guidelines on this, but we usually give one attempt at it where we do a balloon dilatation. Put single plastic stent. There is a hypothesis on multiple plastic stents as well, where there is a ductal reformation with multiple plastic stents too. They've tried putting a fully covered metal, removable metal stent also. But ideally, I would say balloon dilatation, plastic stent. But if the patient is still symptomatic after an attempt at endotherapy, then I think surgery is the way to go forward. Because anyways, long-term outcomes, quality of life of patients is much better after surgery.
You also mentioned lamps for the chronic pseudocyst. Yes, I thought like in lamps, it has to be removed within 2 weeks or 4 weeks.
So lamps is usually indicated in cases of pseudocysts where the solid component of the cyst exceeds more than 30%. So what happens if even Naveen's one of the videos where he had to reattempt, he had to go in surgically after placement of after endoscopic cystogastrostomy because there was significant solid component and there was a plastic stent in situ. So even with multiple plastic stents, we at the most put a 10 French plastic stent inside. So to drain the solid component will be very difficult. So more than 30%, it's better to.
No, but would you remove it? You have to mandatorily remove it, or
after 2 weeks for sure.
Otherwise, but if it may not, communication may not close so early, right? In this chronic pseudocyst.
So if the pseudocyst, so chronicity, I don't think is an indication for drainage, sir. The indication for drainage is whether it is causing any pain, if there's any infection, or it's causing compression on the biliary system or the.
No, I mean in the setting of chronic pancreatitis, I meant in the setting of chronic.
Right. Any pseudocyst, 2 weeks, I think will most of the, if it is a plain pseudocyst, it will drain out, sir, 2 weeks.
Naveen, we had this discussion some time back also. In this WPNs, what cases would you prefer internal drainage versus external drainage? How do you make the decision? All WPNs should be drained internally, or there are some cases in which you would avoid internal drainage and do an external drainage?
suspicious colonic communication long-standing with significant air foci where we suspect colonic, so we try not to do a internal drainage, fearing a gastrocolic fistulas. Otherwise, most of the times, we feel more comfortable to do an internal drainage because the access is more, most of the pancreas is right below the stomach. And rest of the reinterventions following transgastric significant necrosectomies are lesser, unlike ward necrosectomy, where there is a risk of probably pancreatic fistulas and more morbid rather than a transgastric. Whenever possible, we'll try to do a transgastric or transluminal drainages.
Vimlakar, I mean, that was an excellent video you showed of the robotic. I mean, you could exactly replicate the open surgery in this thing. One thing I wanted is, I mean, in the robotic technique, we don't ligate the GDA, right? Do we ligate the GDA?
No, routine also I never ligate GDA, because there is a theory that if you ligate a GDA, there is a chance of lower end of CBD stricture. Because anyway, there is a chronic pancreatitis, the pancreatitis will keep on going. So the chance of stricture is there. If you ligate GDA, the chance of strictures will be furthermore. So that's why usually I never. But if you have doubt, few people will have prophylactically, they'll ligate first and they'll start doing head coring. So that's why I told, if you have fear of bleeding, you can do that.
You know, one problem I was thinking, when you're doing the coring, normally in the regular coring, when you do an necrosis, there'll be a lot of spurters, which all of them may not get controlled by bipolar. In robotic, did you have a problem of like immediately de-docking the instrument, getting a needle holder in?
Before starting head coring, usually you have to put 4-O-proline inside.
Okay.
4-O-proline inside. Only just changing your instrument from the monopolar scissors to the needle driver. That's it. So wherever the bleeders are, usually at the uncinate level to the SMV, 2-3 bleeders will come. That we have to ligate, whatever we do in open. And the duodenum side, in the groove, one vessel will come at 9 o'clock to 8 o'clock to 9 o'clock position. That is 8 o'clock to 9 o'clock position 1, 7 o'clock around 6 o'clock position 1, around 4 to 5 o'clock. These three are standard.
So you need to butcher.
Yeah. And one more will come at the 11, 12 o'clock. So these are all the routine anatomy. Yeah, these are all the routine anatomy. So if you, what I believe, if you ligate GDA also, it will tackle that 11 and 12 o'clock, not much of this lower. These are all venous tributaries. So that's why always you have to keep your proline inside ready.
Any questions from the audience?
Vimlakar.
Sir.
Do you routinely do phrase for all chronic pancreatitis patients needing surgery, or only in patients who have dominant head disease?
Sir, if the patient is having chronic pancreatitis, unrelenting pain, not responding for medical therapy, with the ductal hypertension, usually will go, sir.
No. Compared to lateral pancreatic osteogenestomy versus phrase.
So phrase in every case, sir. In every case, no doubt. There's no LPG. I have never ever done.
Yeah, because some old timers like us, we believe that if not much stone disease, not much head dominant disease is there, lateral pancreatic osteogenestomy gives equally good results. But that's why I asked.
Yes, sir. But still, studies have shown that head is a pacemaker. If you core whatever, how much you removed is not the important. How much you left is the important. That's why that was the limitation for the minimal access phrase. So you can't have that feel. But after doing few cases, you will have that visual haptics. That's what I was telling. And traction anyway with the MOP roll technique.
I have a question for Rohan. You said that stricture will be dilated within a balloon.
Yes.
And you'll be able to put a stents, 2 stents. I mean, in what percentage of the patients where you'll be able to really dilate the stricture? Because we, the surgeons, if there's a stricture on the table, if you're doing a pancreatic osteogenestomy, we suspect a malignancy. Right. And send that part for a nephrogen and confirm that there's no malignancy. So is there any chance that you'll be missing malignancy, number one? Number two, how much dilatation is possible by endoscopic dilatation? And how long, once you remove the stents, how long that dilatation will persist? I just want.
So that is why the concept of multiple plastic stents and reattempts at ERCP was a possible hypothesis. But we do not do it like more than one time, because failure of endotherapy once, we straight away send that patient to surgery. Any suspicion of malignancy, if there's an inflammatory mass in the head, suspicion of malignancy, those patients go straight away to surgery. If it is only a stricture without any significant stone disease, just a dominant stricture closer to the head, then only then we dilate those strictures, but not very regularly though.
When one more thing, phrase for all cases, the reason is in the head, the pancreatic duct becomes very posterior. And unless you core out the head and saucerize that, you won't get adequate drainage of the head.
Drainage of the head. And so my question to the senior, sir, this is a frequent problem what we see. So in a CCP patient, if just ALP raised, there is no IHBRD, what to do? On MRCP, if a demonstrable stricture is there, there is no other go. We have to go for the same loop hepaticojejunostomy. But there is no biliary stricture on imaging, but ALP is very high. There is no IHBRD. If the brush cytology, there is no malignancy. If you ruled out malignancy, what to do?
No,
Anyway, we are going for phrase.
If you are doing a good phrase,
Sir,
with
it may open up.
demonstrable stricture, there is no reason why you should interfere with the CBT. Many of the good phrase would relieve that ALP rise.
Yes.
I think those patients would require only observation. My other question again, because the debate goes on. I heard you using the word bridge, in the treatment of chronic pancreatitis. Is it still accepted as a step-up approach like you do for in acute pancreatitis? Is it acceptable in chronic pancreatitis, particularly with the current evidence showing a shift towards increasing benefit with early surgery? Second question is, how many of your patients with endoscopic treatment would ultimately land up in surgery? Because we have evidence that those segment of patients who land up in surgery will have a poor pain relief because of the delay in intervention, not necessarily because of the natural history.
Sir, yesterday only, sorry, you answer first.
Sir, regarding the first question, there's no debate whether is it an endoscopic therapy versus a surgical therapy. I think careful selection of patients is what is more important. If the pain is pain predominant disease with a PD stone limited to the head of the pancreas where the stone could have been completely removed, those are the patients we select for ERCP drainage in the first place. If there's stone in the body and the tail of the pancreas, we do not even attempt ERCP in those patients.
Perfectly acceptable. Yes. I'm talking of the bridge.
Sir,
bridge means, say, you're doing an endoscopic followed by a surgery.
Yes.
As a preliminary palliation.
Right.
That is not indicated in a chronic disease. That may be true in an acute condition where a patient is not absolutely fit for a surgical intervention. You would opt for a less invasive procedure. That may be applicable to that kind of situation.
Right.
But in a chronic situation with a patient where a patient is fit for surgery, is the word bridge applicable?
Sir, I limit it to just one attempt at endotherapies.
Only one attempt?
Just one attempt. If the patient, there is a stent in the pancreatic duct, patient continues to have pain, then the patient goes straight to surgery.
So do you not do frequent exchanges of stents?
No, sir. We do not advocate that.
And as sir said, so yesterday only we did one case in a young boy, 18 years old boy, after ERCP, multiple stentings. So there was no relief, and despite of that, whatever the beyond the stent area has become big mass-like thing, and we had to go for distal pancreatectomy with the phrase. But I mean, we have a publication also. Last year we have published with 85 cases, I think. In that, around 30 to 35 cases are post-stented patients. And I think one thing, if you have a single duct in the head or neck, which is obstructing, or a single stricture in the neck or head, if you go for endoscopic stenting, probably the relief will be good. With the multiple studded stones, doing ESWL, that clearance won't be there. And they land up in surgery, definitely in a worst condition. So, and not only that, in head coring, the one more benefit, you will take out the tissue for the biopsy. Or nowadays, in each and every case, we do frozen sections also. Not only the 3%, whatever we study in books, that 3% is not there. In our series, in around 60 cases, we have identified 6 cases. So I don't know that numbers from where it is coming, but the incidents are really high. It is also like oral cavity field cancerization. So the propensity is very high. And there is a new theory. If you do early surgery, if you relieve the ductal hypertension early, the pressure on the parenchyma will be less, and the chance of irritation will be less. The chance of changing into dysplasia to malignancy will be less. So I don't know, to prove that, it takes time. We are doing genetic study on the tissues also, even on CCP patients. We have started a project.
As a surgical community, I think we should put forward this point very strongly, saying that, if the patient is a chronic pancreatitis patient, repeated stenting is a big no for these patients.
Most of the cases are stented patients.
One question to Rohan. Before deciding on surgical intervention, we generally have a threshold of pain beyond which we start considering surgery. For patients of endotherapy, what is your threshold? Does the anatomy guide you to decide on early therapy or the symptom? Or if it is both, what is the way you look at it?
Primarily the symptoms. Primarily the symptoms always. Because first we try medical management in patients with pain predominant disease without any ductal disease. Because neurological pain can be a possibility in chronic pancreatitis.
So if I understand correctly, a patient who has gone through the step ladder of medical pain management,
yes,
he reaches a point of intervention and then he is equally fit for surgery / endotherapy. Is it acceptable?
If the pancreatic ductal disease is there with a stone in the head of the pancreas, endotherapy.
But that single stricture, what you're saying is the ideal condition, that's very small percentage.
Yes, that's a very small percentage.
So, but if you look at the number of endotherapies being done and the actual incidence of this ideal case,
right,
it's a very, very disproportionate thing. I'm just trying to make a point that endotherapies are being done much in much larger numbers than what this.
So we have been working together for 7 years, me and Vimlagar. So we make it a point that those patients go to surgery because we have seen firsthand that those patients have a much better quality of life post-surgery rather than going at multiple attempts at endotherapy.
Dr. Partha, I'm sure you ask a patient, do you want endoscopic therapy or surgery? He would say endoscopic therapy.
But sir, as surgeons, what are our comfort levels where we want to take help from an endoscopist? Like 1 or 2 small stones, 4 mm duct, or a head prominent stricture? Yeah, 5. Yeah. So probably like small stones, undilated duct. I think we are also very uncomfortable
because on the
primarily
contrary, these patients do very well after endotherapy. Like you select the patient properly, they like long-term follow-up, they are pain-free just on pancreatic enzyme replacement. They do really well after endotherapy.
I think we'll
Thank you so much, sir, for a beautiful discussion. We'll just end up with a group photo. We'll skip the tea break, keep it working, and move to the next session on CA head and uncinate.
Yeah, sure. Firstly, I'd like to congratulate Vimlagar and his team on this excellent program with an excellent format. The topic allotted to me is, the head mass and chronic pancreatitis. It's a never-ending dilemma. Yeah. Yeah. And just to set the context, I'll just show you a few cases. I mean, after so many years of experience and so many tools available to assess, there are several cases. These are all cases. The slides are going to come up. These are all cases we've seen in the past 2 years. In each of these cases, our judgment was not accurate. So I just want to highlight how big this dilemma is. There was one patient, he was a 76-year-old male who presented with de novo. First time he presented with pain and diabetes. So that immediately says that, he could have a malignancy just from a context. The new de novo pain, de novo diabetes. His CA99 was not significantly elevated and he had a low-grade biliary stricture, mild IHBRD. The US guided biopsy was negative. So if you look at his CT scan, you can see there's IHBRD. That's the portal vein that's going and getting completely thrombosed. That's the portal vein thrombus, and there's a big inflammatory mass in the head. So with the negative histology, the problem was he was 76. There was a portal vein resection required. I felt it was a malignancy, and we offered surgery, but for various factors, the patient refused. He said that so we went for the wait and watch policy. This is his imaging 2 months later. If you see, now the portal vein thrombus is evolved. There's now a cavernoma and all there, but the mass is almost completely regressed. 70% it is regressed and become a much more resolved and much smaller. So this is one case. This is another gentleman. You can see this is a groove pancreatitis, inflammatory mass in the pancreatic groove. And this guy underwent 3 times US guided biopsy to trying to prove malignancy. He also had a biliary stricture for which he was undergoing stenting every time he underwent in the US. All 3 times biopsy was negative. In the meanwhile, his portal vein got thrombosed and the mass actually sort of resolved partly. So when I went in to do a hepatic angiostomy, I took multiple true cuts from the pancreas and all the biopsies were negative. I did a hepatic angiostomy. 6 months later, patient came with severe postural hypertension symptoms. And we missed all these investigations, we missed the malignancy. Patient had multiple liver mets and celiac encasement. These are, again, patients in the past just 1.5 years, 2 cases have operated. Both, I didn't have a histology, but the suspicion of malignancy, the first case was, I thought it's malignant. Second, I thought it's a large IPMN. We had to do a pretty morbid surgery, Whipple's with a SMV and a portal vein resection in each of these cases. Again, the biopsy came out to be negative. Of course, the patient had a complete symptom resolution and is doing very well. But the point is, if we had some problem with the patient or we lost the patient, the dilemma is, why would you attempt such a major resection in a patient without a malignancy? So that is sort of context of this. In CA-HOP, in the setting of in CP, we all know that there's an increase, especially in the Indian context. The idiopathic tropical pancreatitis, it's associated with a much higher incidence. And majority of the time, the inflammatory mass occurs in the head. Not just in CP, even in group pancreatitis and focal autoimmune pancreatitis, we have this dilemma. So it's always going to be, in the absence of histology, US guided histology, it is only your clinical and radiological suspicion. So this is a very important decision-making tool in the setting of, in a chronic pancreatitis when you have a head mass. What are the things in the clinical and radiological image, the thing which make you suspect? One is any deviation in the natural history, de novo pain, or intermittent pain becoming continuous. Jaundice, I think for me, that's a very important factor. In the benign, you would never have, they're partial strictures, they open up, there is a lot of edema. So bilirubin never goes up below above 5-6. But when you have very high bilirubin, 15-20, strong suspicion of malignancy is there. Then rapidly worsening diabetes, elderly males, especially the first presentation, you should suspect gastric aorta obstruction. Again, CA99 data says that some centers have said more than 300, more than 127, but it's a very difficult investigation to interpret. Chronic pancreatitis leads to increase, cholangitis, obstructive jaundice, in all these situations it's increased. So, but these are the clinical parameters. Radiologically, nothing in the CT, the pancreatic protocol CT or the MRI T1, T2, diffusion weighted, none of them can absolutely surely tell you that it's a malignancy or benign. Likewise, the PET CT scan. But there are some features on the preoperative imaging. Pancreatic calcifications versus, so more of calcifications which would suggest an inflammatory, but whether the calcifications are displaced, they're all pushed to one side. That means there's a mass in that and that's displacing them. The 2 cases I showed, they had, when there are a lot of cystic lesions, benign is more likely. The double duct sign, again, it's for malignant, but in the setting of chronic pancreatitis, it's a common problem in benign disease also. This is one very important sign, the duct penetrating sign. That is, you have a pancreatic duct that is actually passing through the mass and it's still patent, that is very, very likely that's benign. That's one very useful sign, I would say. And presence of side branch dilatation makes it more likely benign, because in malignancy, they'd all get infiltrated. Again, grossly dilated duct and a lot of duct with very little parenchyma is more towards malignancy. Vascular encasement, I would not say it's either for benign or malignant, because portal vein thrombosis is very common even in chronic pancreatitis as well. But arterial encasement, in my experience, whenever you have arterial encasement, it's a strong this thing for malignancy. EUS is, of course, our main tool in this, especially when you can get a histology. It's an excellent tool. So the sensitivity of EUS it's not as high as you see in the traditional CAHOP. It's in traditional CAHOP, pre-op EUS is sensitive in almost 90 to 95% of the cases, but it's much lesser in the setting of chronic pancreatitis. It's 72% or 50 to 60%. The main problem with the EUS is the negative predictive value. When the test is positive, it's very good, but very, very specific as well. But when it's negative, what are the chances that the patient doesn't have malignancy? The negative predictive value is only 50 to 60%. So that makes it only an additional tool, but not a complete tool. There are additional things, studying the mutation analysis, KRAS mutation, the oncogene studies, they could be helpful. Other things like contrast enhanced EUS, like the contrast enhanced ultrasound we're doing, and EUS elastography, the role is not very, very, very clear. So intraoperative evaluation is, of course, the most important. I think the same point we've discussed. This was a patient of a chronic pancreatitis with a bilirubin 20 had gone in, and I sent intraop frozen sections of the stricture on table, and came out to be malignancy, and we went ahead and did a Whipple. So diagnostic laparoscopy is, of course, a very good tool. Intraoperative ultrasound and endocytoscopy, we have those available, but the role again is not really, how much they add to the decision making is not very clear. Core biopsies and the head coring biopsies, these two are very important. If you're planning a decision making, not planning a phrase, you do a core biopsy. If that is also negative, when you're doing the head coring, you get a lot of pancreatic parenchyma, the deeper tissues, you can send them for biopsy. Despite all this is one large series which shows 12% of the patients, the malignancy may be missed despite a thorough intraoperative evaluation. So I just look at the scenarios which we faced over the years. We've had CP, I mean, the proven malignancy, without malignancy, leave it. Just CP with resectable mass, in which we'll have no malignancy. We've had the scenarios. We've had patients in whom we've done phrase, frozen was positive, we entered with the Whipples. We had patients in which we did a biopsy that came out 5th, 6th day, and patient was willing, so we re-explored the patient and did a Whipples. We've had patients with missed malignancy, locally advanced mixed malignancy, which despite everything we missed, and they came with later on metastatic disease. And we've had the reverse also, patients in whom they were missed, and we didn't have a histology, and they resolved in the follow-up. So how do we can we have a protocol sort of this thing? There have been some studies. This is a study published from Stanley Medical College. They looked at, in their study, of course, it's a multivariate analysis. They looked at these 4 parameters: CA99, bilirubin, dilated MPD, and a gross dilatation of the CBD. Standalone, these factors are not effective, but when you have a combination of these 2-3 things, your suspicion should be high. So this is the sort of protocol in their article. It's head mass. If it's positive, you obviously go ahead with the Whipples, and if it's negative, you base your decision on TrueCut and frozen. But I think if the clinical indices, clinico-radiological indices are strongly suspicious of malignancy, this is the only area where our protocol would differ. We would actually go ahead with the Whipples even if the intraop biopsies are negative, or we wouldn't even take intraop biopsies, just go ahead with the Whipples resection. So reliable differentiation of head mass from benign to malignant is difficult. A lot of factors should take, have a role to play in your decision making. It should be the patient's symptomatology. Is he fit enough for your surgery? What is your mortality rate of Whipples? Is it less than 2%? And are you comfortable? Because most of these cases will have a vascular resection may be needed, because it'll be a lot of fibrous planes. Are you confident doing that aspect? Is it a high volume center with good mortality? All these should be factors when making an individualized decision in these cases. And one wrong perception we have is that chronic pancreatitis, CAHOP in the setting of chronic pancreatitis has poor prognosis. In a way, it's true because many of these patients they're undiagnosed and diagnosed late because of that, the poor prognosis. But if you look at a stage match, stage to stage, if you match them, they have equally good comparable survivals. So this thing would be in the absence of a positive histology, if it's a symptomatic fit patient with a resectable mass, no portal vein involvement and all that, and if you have a high suspicion just on the clinical radiological indices, go ahead with a pancreatic duodenectomy if you have a good experience of dealing with these cases of chronic pancreatitis and vascular surgery. And if a symptomatic patient with borderline resectable, that is portal vein and all that, make extra efforts to prove the histology. If you have a histology, go for neoadjuvant. If you're unable to prove histology, there's no answer for that. I think it has to be individual. Like that patient I showed you, discuss with the patient. If they're okay, go ahead. If not, let time show its true nature. And if there's symptomatic unresectable mass, you have to prove the histology, obviously, before you give any palliative chemotherapy. If not, we follow up temporarily and reattempt a histology. Just 2 slides before I complete of the technique in chronic pancreatitis. Chronic pancreatitis and Whipple's in chronic pancreatitis is not a joke. It's technically much more challenging. 3 aspects. I'll just say 3 points. One is mainly for the arteries. The arteries get puckered in by the fibrosis. So like Dr. Palnival was saying, go on to the vessels first, go on to the adventitia and stick to your arterial dissection close to the adventitia only. Never try to assume because the scarring and the puckering, you might actually injure art vessels. For the portal vein, the traditional blind tunneling of the tunneling of the tunnel of love, which we do, is extremely dangerous in chronic pancreatitis. Whenever we have a chronic pancreatitis and the anterior plane of the portal vein, because there are additions between the pancreas and this, we divide them bit by bit. So above, below, ideally we should loop them above and below, and then keep dividing small bits and then dissecting further. If you try to go through and create a thorough tunnel, more often than not, you'll actually poke into the portal vein and create a tear and an injury. So you keep dissecting and dividing in stages. That's how you expose it. In this patient, in fact, you can see there's dense fibrosis there, because there's a pseudocyst and a small collection in that area. And this is how you can actually do it safer. So now we've sort of exposed the entire portal vein, and you can see that there's that small pseudocyst. So that's the way you expose the portal vein. And when you have difficulty completely, especially in the chronic pancreatitis setting, you have complete control on the portal vein before you sort of dissect it. So here we've got the splenic vein, the above, below, we've got complete control. Though there was no actual infiltration, you're comfortable, you have access, you can avoid blood loss and repair all the multiple tiny rents that occur with complete vascular control. Thank you. Just one last word about our MS meeting. I think Dr. Palnivel sir has really helped us and told everything about the meeting. It's going to be a very good close group meeting. I mean, it's a very immersive, we've really set up a good program. It's going to be a very immersive program, something like let's say a lab hedge or a lab robotic. In a traditional conference, you'll see it in 8 minutes, 10 minutes. Here, it's going to be half an hour for each technique. And it's going to be a small close group. So there's going to be a lot of scope for interactions. Hope to see a lot of you there. Thank you.
Thank you, sir. We'll proceed with 2 Zoom-based online sessions by Dr. B.D. Patnaik, sir, on Whipple's procedure open master video, followed by Kalarasan, sir, on laparoscopic artery first approach. Thank you. Hello.
Hello, BD.
Hello. Hello.
Yeah, go ahead.
Am I audible?
Yeah.
My screen is visible, right?
Visible.
Yeah. So thank you so much, Bimlakar sir, my brother. He's doing a wonderful work, and thanks for the invitation. And I could see Fanny Krishna sir and Naveen in the hall as well. So I'll directly start with the work assigned to me. So in a room which is entirely filled up with minimally invasive surgeon, I'll be presenting on open approach about pancreatic duodenectomy in the next 8 minutes. I'll try to stick to the time. So amongst all the big laparoscopic and robotic surgeon, I'm a very open-minded, open surgeon, and as of now, our Da Vinci robot has reached AIMS Bhubaneswar, and we are yet to open it. This is the condition now. So by maybe next 5-6 months or so, I should be able to do all this procedure by robotic, and I'll be needing your help as well. So with this, I'll let me go through my presentations. So I'll directly go to the videos actually. The 77-year-old male diabetic hypertension. On CT, there was a mass in the uncinate process of the pancreas. It was abutting the SMA as well as the SMB. And on EUS also, there was soft tissue thickening around the SMA, but there was no obvious infiltration. The FNA, US guided FNA, was adenocarcinoma. This is the imaging. The CT was done outside. I tried hard to get the video, but I could not get it. I'm really sorry for that. But you can see the soft tissues around the SMA as well as loss of fat planes with the SMV. So the patient received 2 cycles of JAM plus nab-paclitaxel, but due to tolerance issues, he was later on shifted to 6 cycles of Folfox. And then after that, it was a stable disease with no metastasis, significant reduction of CA99. So in all the cases, all abdominal malignancies cases, be it CA ampulla, HCC, CA, all upper GI malignancies, HPV malignancies, to be very specific, we do a staging laparoscopy, and in all cases rather, and then we proceed for surgery. So I'll directly go on to the video. So we do a good cauterization in all the cases of pancreatic duodenectomy. Most of the resections are done by residents actually at this point of time. So after good cauterization, you just try to ligate the right gastroepiploic artery. And if you do a very good cauterization of D3 and part of D4, the SMB is exposed very nicely. Actually, you can see the inferior pancreatic duodenal vein edge. And after taking the station 8 lymph node, I first usually loop the GDA and then take a length of GDA and then loop the common hepatic artery. And after exposing the tissues in front of the suprapancreatic portal vein, the tunnel is complete. And then I'll just try to remove tissues and do a good hepaticoduodenal lymph node lymphadenectomy. HDL lymphadenectomy is very, very important in case of all periampullary tumors and not only see head or uncinate process of pancreas. This is the left artery and the right common artery. And we can see the segment 4 artery. We will try to loop the segment 4 artery as well. So left, middle and right hepatic arteries are looped and all the tissues surrounding these are removed. We take intraoperative bile culture in all the cases, followed by supracystic division of the common bile duct. What I personally do is a mobilization of the portal vein and followed by GDA ligation. If you see properly, I just ligated the GDA with 2 homolog and not putting any homolog towards the specimen side. I'll just forward it. Yes. If you see, just putting 2 homologs on the patient side and no homolog or clip towards the patient to the specimen side, this helps in taking a good prolin stitch while doing the uncinate dissections. And after the DJ flexor is mobilized properly, take a stitch on prolin 3 on the patient side and on vicryl or silk on the specimen side. and then mark. In this particular time, you should never try to disrupt the anterior pancreatic capsule, which is very, very important in case of small duct and soft pancreas. And there was abutment on the CT, but you can see by gently dissecting and ligating the superior pancreaticoduodenal vein, the SMB portal vein is nicely removed from the specimen site, and there was periatrial addition to the tumor. So we are going for a LV3 divestment in this particular patient. You can see clearly the SMA you can see, and this is LV3 divestment where you need to loop the artery below. This is the IPDA where I'll try to put 2 hemologs and just apply ligature and cut the IPDA. And the last part of the SMA divestment, you need to loop the SMA above and below from the point of contact to the tumor. And after that, this ligature are very, very safe actually for divestment procedures. You need not do it with the seizures anymore. And after the divestment is complete, you do the Heidelberg triangle operation. Nowadays, we are doing this even for CA ampullary cases as well. And this 8P lymph node, which I am removing now, these are very, very important lymph node, and these are usually missed during open pancreaticoduodenectomy. 8P is easy to take during laparoscopic or robotic, but open it usually gets missed. So troubleshooting in one of the cases, I think this was a case of CCP. So in this particular case, you see this was very, very fragile GDS stump. I applied it was very small, so it was not suitable for hemolog. So I applied 2 clips while ligating. Just based on the forceps pressure, the GDA got blowed out with a very flushed stump. I cannot convincingly apply a clip directly. So proximal and distal control with a bulldog clamps followed by flush repair of the GDA with Prolin 8O suture under 5x magnification. And after you take Prolin 8O, if possible, like in this case, I just retracted it towards the anterior side and I could apply a clip. Applying a clip is optional. If you are able to apply it is okay, but the suture must be Prolin 8O and not below that for hepatic arteries, especially this kind of fragile hepatic artery. So I have seen GDA bleed and arterial divestment. Now this is a case of cystic variety of pancreatic adenocarcinoma where we did type 2 venous reconstruction, SMB to SMB, type 2 repair. These are the pancreatic tributaries of the SMB, followed by looping of the colonic vessels, middle colic vein, and then splenic vein. Proximal portal and distal splenic vein is already looped distal SMB. Application of the clamps, and first I tried to do a type 1 repair. I cut it, but after division I could realize type 1 is not possible, so we are just going for a type 2 end-to-end repair of the SMB. In this type of cases, you need to very well mobilize the colon and triangular ligaments of the liver, which you will greatly scale down your apprehension in the postoperative period. We use Prolin 60 continuous sutures. You can do it with a intermittent suture as well. So after completion of the posterior layer, you can start doing it with the anterior layer, flushing with hepsaline intermittently. And then just before the final stitches, you bleed out, take out both the clamps before giving growth factor. This is very, very important. You first take out the clamp and let the vein swell and then give the growth factor, like we do it in live donor transplant for portal vein end-to-end anastomosis. So it will give you a very good portal vein anastomosis. And finally, our technique of doing PJ. At our institute, we always do pancreaticojejunostomy with Prolin 5O outside, cattle variant technique. In all the cases, no pancreaticogastrostomy, no dunking, no banding. All cases PJ under loop magnification. Of late, we have started doing it like hepaticojejunostomy. In all cases, we do not outside technique strictly with PDS 50. For pancreaticojejunostomy also of late, we have started doing not outside technique. I'll just show you. I'm sorry for the scrabbles. I don't know how it came. So first is Prolin 50 sutures, outer layer, followed by a very small opening on the jejunum, and this binding sutures on just to open up the mucosa well with PDS 50 and duct to mucosa with PDS 60. All the knots outside technique. These are corner sutures, inside out mucosa to serosa, tie the knots. Again, you see, this is inside out from pancreas, inside out from serosa. This is very, very helpful in small, very small ducts, 1 mm ducts, 2 mm ducts. We have 30% of our patients are having 1 mm, 2 mm ducts. Very helpful. What we personally feel, obviously, we are going to publish our data and then we can know about its implications on the POPF, but it gives a very good sleep after doing this not outside technique for very small ducts. Larger ducts, obviously, you can do either way, but in all cases now, you see there are not much retraction sutures, hardly 2-3 sutures are there. So the chances of entanglement of the sutures and the dependence on the first assistant is very, very less. Irrespective of the texture of the pancreas, we use PDS 60 only. In CCP cases, at times we do PDS 50. For us, it is very, very convenient, this particular technique. So just briefly, last one slide about, we have performed around 264 pancreatic duodenectomy as of now. Of late, we have done from 5 or 6 laparoscopic, pure laparoscopic pancreatic duodenectomy. If you see 1 mm and 2 mm ducts are 33.5% now. And out of these, if you see the biochemical leak is 25%, grade B is 8.5%, and grade C is 2.1%. We are analyzing our data based on the size of the duct as well as the location of the duct on POPF as well. That is under evaluation now. So once we are through the proper this thing, then we can publish it. Because of lack of time, I could not show the importance of replaced common hepatic artery, replaced right artery, replaced left artery on pancreatic duodenectomy. These two we have published. One is replaced common hepatic from SMA. One is replaced common hepatic from left gastric artery. Out of all the Whipples, we had around 50% had lymph node metastasis. And interestingly, only LVI PNI positivity on multivariate analysis, they predicted independently the lymph node involvement, but grade and size of the tumor, though they were predictive of lymph node involvement on univariate, but they could not predict independently in multivariate analysis. We are publishing this in the forthcoming IHPB, presenting this, and later on we will try to publish as well. And this is our first live donor transplant we did at AIIMS Bhubaneswar last month. And with all your blessings, my Professor Pamecha is there, my boss from ILBS, he is helping for initial few cases. Then we all need your good wishes and blessings for this. Thank you very much for your patience hearing.
Thank you, sir. We'll proceed to Kalairesan sir's talk on artery first, and we'll end the session with the discussion after some time, sir. So hope you will be online.
Sure.
Am I audible and my slides are visible?
Yes, sir. Yes, sir.
Okay. Yeah, I would like to thank Dr. Vimalaka and the team for this wonderful program. And so I'll be speaking on the various approaches to SMA during MIPD and focusing primarily on the robotic approach. And so we all know that's important predictor of survival in pancreatic cancer, and that's why we talk about the approach to SMA, and it's often involved in pancreatic cancer. If you talk about the approaches, so broadly you can classify the approaches into right, left, anterior, and posterior. So that's a simple way of classifying the various approaches to SMA. And let me just, of these approaches, commonly we use the right and the posterior. But as a pancreatic surgeon, you should be familiar with all 4 approaches, because intra, when you have difficulty with one of the approaches, you can choose alternate. But as I highlighted here, is commonly the combination of a posterior and the right approach. So what about the anterior approach? As you can see, so that traditionally what we do, we lift the vein and then approach the artery. Whereas in the anterior approach, which you can do either from below the level of transverse colon or above, depending upon the extent of tumor involvement, you actually go in between you go on the surface of the SMA, and your dissection is actually between the vein and the artery rather than lifting the vein and approaching the artery. So that's the anterior approach. So when we use that, as I mentioned, we start off with a right approach. And you can see here, this is the superior mesenteric vein, and this is the first jejunal trunk, which is joining with the superior mesenteric vein. And the tumor seems to be involved. And if you try to loop the first jejunal trunk on the right side of the SME, you can have problems. Now we decided let's change from the right approach to the anterior approach. So which means the SME is looped, and this will be retracted towards the right, and then you go between the SMV and the SMA. Now this we are doing above the level of the transverse mesocolon. If the tumor involvement is further down, we will go below the transverse mesocolon. And then you go in between the artery and the vein. And this is the safe way of ligating the first jejunal trunk. In case if it is involved, don't do it on the right side of the SMB. Go to the left side, because in case if it retracts, when you are doing from the right side, this trunk will go underneath the artery, and you find it extremely difficult to control the vein. That's why you should use the anterior approach and then safely control the first jejunal trunk. So that's an example where we use the anterior approach. And the left approach is here. You are actually, again, below the level of the mesocolon, transverse mesocolon, and at the level of duodenojejunal flexure, because this is one of the easiest way of actually exposing the SMA even compared to the right. Only challenge is you require a lot of retraction. You need to retract the jejunum, you need to retract the mesocolon, and that's why it's not very popular in minimal invasive. But if you see the Japanese series, most of the cases, especially in open, are done with the left approach. So where we use it in minimal invasive cases, so you can see normally the IPDA comes from the right of the SMA. This is the usual anatomy, the common trunk of the IPDA and the first jejunal. But in your cases where it comes from the left side of the SMA, as you can see here, the IPDA is coming from the left of the SMA, then it is easier to control the IPDA from the left of the SMA. So you need to retract the mesocolon. You can use various techniques. As you can see, this is an internal organ retractor, but you can just take a simple stitch also if you don't have this. But the key is don't use the robotic fourth arm for retracting the mesocolon, because using the robotic fourth arm for simple retraction, which means you are actually wasting one of the arms. So then you dissect at the level of duodenojejunal flexure, and you need to retract the jejunum towards the right. This is the inferior mesenteric vein. So you are separating it off from the inferior mesenteric vein, and that allows you to mobilize the duodenojejunal flexure. And then you can easily approach the superior mesenteric artery. You can see here, this is the superior mesenteric artery, which is nicely exposed. This is the left side of the superior mesenteric artery. And you can see in the image, the IPDA was coming from the left side. And you'll be seeing the IPDA coming in the view. So we are going underneath the SMA plexus, and you can see this is the IPDA, and you further. So this is actually the common trunk of the IPDA and the first jejunal artery. The one which is going superiorly, that is IPDA. The one which is going inferiorly, that's the first jejunal artery, and this is the common trunk. Because that's a usual anatomy. You'll often have a common trunk of the first jejunal and the IPDA. You divide the first jejunal separately so that when you are actually going to the right, this artery does not get avulsed because it can have retrograde bleeding also. And then you take the IPDA separately. So this is approach from the left, which we use selectively depending upon the anatomy of the IPDA from where it is coming from the SMA. The commonly, as I mentioned, is a combination of posterior and the right approach. Posterior means you go to the origin of the SMA above the level of the left renal vein. So that's how we start off. So if you see, very rarely you'll be able to do the complete dissection along the SMA with a single approach. Often it's at least 2 approaches, and some cases you use 3 approaches. So we start with the posterior, and then we move to the right. When you approach the SMA from the right, the key anatomy which you need to understand is before you enter the arterial plane, you will have the veins draining from the uncinate into the first jejunal trunk, the inferior pancreatic veins. You need to divide those veins. Only then you will have the window to go into the artery. So once this anatomy is understood, then the right approach becomes relatively straightforward. So that's the best approach in minimally invasive, the combination of posterior and the right. So as I showed, we are starting with the posterior approach. This is the left renal vein, and you expose the superior mesenteric artery above the left renal vein, and then you continue with the posterior approach. So we can go along the posterior approach up to the level of DJ flexure, and then what we do is we mobilize the DJ flexure from the supracholic compartment. This is the inferior mesenteric vein, which you can see, and the jejunum is shifted to the supracholic compartment. So we are not actually going into the infracholic. All the dissection is done from the supracholic compartment because that to some extent also correct the twist in the mesentery. And then this is what I was mentioning. Unless you take this pancreaticoduodenal vein and one of the jejunal branches draining into the first jejunal trunk, you will not have access to the SMA. And this is a place where you will encounter bleeding because while trying to control these veins, if you injure the first jejunal trunk, then you will have significant bleeding. So try to identify the pancreaticoduodenal vein, safely control them before you go into the SMA plane. And to have a wider exposure, we routinely take this first jejunal branch draining to the first jejunal trunk because this also allows us to take some amount of jejunal mesentery, which is part of the mesopancreas. So this is the key anatomy you need to understand to approach from the right side. Once you take this, then you will have a very good exposure to the SMA. For the sake of time, I'll just move to the key part. So you can see that once these veins are divided, you can see how much distance is now available between the uncinate and the first jejunal trunk. Till the veins are taken, they were very close. The moment they are taken, you can nicely retract, and then you can start going into the SMA plane. So this is a superior mesenteric artery, and this is a common trunk of the IPD and the jejunal, which we are taking. So this is a typical LV2 dissection, which means you are not taking the SMA plexus. you are just taking only the pancreatic plexus. So this is usually required in periampullary tumors, but once you have some any borderline or pancreatic head cancers, then you need to go into the LV3 plane. The LV3 plane means you are deeper to the SME plexus. You can see here, what is being held with the left hand instrument, that's a SMA plexus, and we are going into the adventitial plane. So that is LV3, which means you are taking the SMA plexus. In LV2, you take only the pancreatic head plexus. You don't take the SMA plexus. So that's a difference which you need to understand. And normally we do only on the right side, SMA plexus dissection. But in some borderline pancreatic tumors like this, here the tumor was in the extending up to the neck. So we have to do an extended pancreaticotomy. This patient also had a replaced right hepatic artery. Now, these are the cases where you will, because this patient also received neoadjuvant therapy. So we are going in the LV3 plane and also doing a circumferential dissection. So this is not routinely done. This is done only selectively because when you do circumferentially, then the possibility of the postoperative diarrhea is increased. But again, you might be forced to do in some patients for the purpose of oncological clearance. So you have three planes, the LV2 typically required, LV3 in pancreatic head cancers, that is usually the right half, and in advanced tumors, you might have to do this type of a circumferential clearance. So this is the SMA which was circumferentially cleared, replaced right hepatic artery, and this is the celiac trunk, which is also cleared. And then you will have this type of the triangle clearance, what Dr. Patnaik was mentioning. You can achieve that. So that's it. I think just a slide about the evidence. Artery first approach. I'm not quoting any single study. This is a summary of various publications. So it helps with early resectability assessment, especially the SME involvement. May reduce, because some studies have shown reduced bleeding, some studies no difference. But the principle is because you have early control of the artery, it will reduce venous bleeding. But the oncological benefit is uncertain because if you go into this plane after pancreatic transection, again, you will have the similar oncological benefit. The key is whether you are approaching first or last, but you need to stay on the SMA. So that's an important principle which you need to understand. But in minimally invasive, the artery first approach actually is easier than the conventional. So to conclude, the understanding various approaches to SMA improves the safety of the uncinate dissection and also can potentially improve the arterial dissection in MIPD. Thank you.
Thank you, sir. Now I request Vimlakar sir to conclude the session with the topic on Whipple's robotic Whipple's tips and tricks. Thank you.
Yeah. Good afternoon, everyone. And after seeing open Whipples by BD and laparoscopic Whipples by Palnavelu sir, the technique will be same, but in robotics it is a new thing. So how to use the various instruments, how to modify based on the condition. This is the motto of my presentation. That's why I took this topic as a just tips and tricks. Regularly, what will be the ideal patient for any minimal access Whipple's procedure is the periampullary growth with the good double duct sign or a firm pancreas without any vascular anomalies and favorable vascular anatomy. If you have, definitely that patient will be the ideal patient. In all patients, you have to go for diagnostic laparoscopy, and that is routine. Again, in Whipple's position, from the patient cart will come from the head end, and the ports are, we use 4 ports with the 2 additional ports, the 2 ports. So the 4 ports are again 4, 1, 2, 3. 2 will be camera, 1 will be left hand, 3 will be right hand, 4 will be the cardiac, and this between 2 and 3, one 5 mm suction port. And why we will place the 12 bar 15 mm port laterally? If something emergency happens, to put gauze pieces, to put bulldogs, to use stapler if you don't want to use a sure form. For those purposes, you can use 15 mm laparoscopic port in the left lateral edge. So then coming to the, sorry. So after going in, so handling the falciform is most important. Most of the times you will have hanging falciform ligament. Take a straight needle and just suture it tight outside. And the patient position, again, like phrase as I showed, for the supracolic dissection, head up, but here head up with the steep head up with the right up, usually. There the left up. And for the infracolic dissection, here you will have a little more infracolic dissection. That's why you should have a good Trendelenburg position for the infracolic. And the instruments again same, cardiac forceps in R4, and R1 will be the Maryland bipolar, and camera will be in the center R2, and monopolar curved usually in the R4. And if you want to use ligature, again you will use in R4 only. And the difference between the open Whipples and the laparoscopic Whipples is, sorry. Sorry, what's the problem? 1 minute. So the difference between open Whipples and any minimal access Whipples is, in open Whipples, first straight away you will go for the extended cauterization. But here you should enter into the lesser sac first, take down your hepatic flexure, then go for the extended cauterization. There what either monopolar with the both hands bipolar, and at times we can use the robotic ligature also. So after taking down that loop of Henle, after taking down your hepatic flexure, you will go for extended cauterization. This extended cauterization will be not only up to the seeing of left renal vein. You should see the pulsations of the aorta, and most of the times we'll try to see the origin of the SMA. And next step would be the creating tunnel of love. So in creating tunnel of love, identify the lower border, delineate the lower border slowly with the, here the trick is whether you want to use bipolar in left hand with the right hand monopolar, or you want to use both bipolars, because in the neck level, while you doing this tunnel of love, you will encounter multiple small tributaries. So that's why if you have both bipolars, it will be easy. And after that, going for the suprapancreatic portion, for that GDA, hepatic artery lymph node dissection, if you take out the hepatic artery lymph node, you will see the portal vein, you will have a good access for the suprapancreatic portion. Put one ribbon gauze and take it out. After that, there are 2 techniques. If you have any difficulty, you can transect the stomach and go ahead for the suprapancreatic dissection. And then portal venous, again, portal lymphadenectomy and GDA ligation, same thing. Either after transecting the stomach, if you want to go, it's well and good. You will have a little bit more space. Otherwise, you can go directly. If you have a steep head up, if you have a sandbag just below the lower, at the pancreatic level, I mean, behind the pancreas, if you are seeing in a thin patients, you can see well. Without transecting the stomach also, you can go. Anyway, you've taken out the hepatic artery lymph node. Then you can skeletonize the GDA, clip with the hemolax, double clip is safe, then followed by the hepatoduodenal lymphadenectomy.
Then infracolic dissection, change the position of the patient and come down, use the Kadier. As Kalai was telling, don't try to hold mesocolon with the Kadier forceps. You can hold the colon, but not the mesocolon, because the chance of injury will be very high. And here the same thing, while doing infracolic dissection, transect after the first jejunal and go close to the jejunum. Here the thing is, the SMA will be there and the jejunum, mesentery will be there and the jejunum will be there. So it should not be, if you go towards the jejunum, you may injure the jejunum and it causes spillage. Toward the mesentery, root of the mesentery due to the SMA is very high. That's why, so you should maintain an ideal space between these two things. What you want to use, whether you want to use bipolar or ligature, based on the length of the or the thickness of the mesentery. And this is in this case, you can see in one case, there was a normal patient. So where you will go for the first identify the DJJ and do DJJ dissection, transect the jejunum, and close to the jejunum you go and do completion of the infracolic dissection. But in malrotated patients, you will have a straight DJJ. So in that case, in fact, it will be very easy. Just go first transect the jejunum, then do mesojejunal dissection, and you can take that specimen towards the supracolic compartment. So the next step would be the pancreatic transection. Again, 2 steps. Why I have put two videos, the various steps various methods I wanted to show. In one video, I have tied with the ribbon gauze, but in another video, I have taken stay sutures at the lower end of the pancreas. I have transected the pancreas. For some reason, I didn't put stay suture at the upper border. Suddenly, it started bleeding. So I placed the hemostatic stitches. In another video, the benefit of first video is, if you ligate with that umbilical tape, by the end of your surgery, by the end of your whole surgery and before starting your pancreaticojejunostomy, you may have some dilatation of your pancreatic duct. That's why using that umbilical tape is also a good option that you can use for the retraction. If you put stay switches, that you can use for the retraction. Then the important step is uncinate dissection. Here, the important is first jejunal artery, IPDA, and identifying the SMA, safeguarding the SMA, not leaving the tumor and not injuring the SMA is the most important thing. Here, what to use? You can use the judicious use. Again, if you see in one video, I was using ligature with the left hand bipolar. In one video, both are bipolars, and where coming SPDA, first jejunal, SPDA, IPDA, I was using clips. Identify those structures and clip properly with the hemolock, and you can use the ligatures also. And regarding the pancreaticojejunostomy, so I wanted to show 2 techniques. So I use both the techniques, modified Heidelberg. This is first taking one layer completely interrupted stitches with the proline bar PDS. Usually I use proline. Then duct to mucosa interrupted pancreatico-jejunal anastomosis, ductal jejunal anastomosis. And if you want to place stent, there are a number of studies. There is no added advantage of stent, but still, if you want to put, you can put. Then after doing posterior duct to mucosa, then anterior duct to mucosa, then interrupted anterior layer of parenchyma to jejunal anastomosis. This is the modified Heidelberg technique. And in one more technique, modified Blumgard technique, where first I'll stay one U stitch and I'll bring the jejunum to the close to the pancreas. Now I will do interrupted pancreatico-jejunal anastomosis. After posterior 3 stitches, stent is placed and anterior pancreatico-jejunal anastomosis is done with the 5O. Usually I use 5O PDS. Full thickness pancreas and the jejunal stitches. These are the stay stitches. So this is the modified Blumgard technique. So it seals off the cut surface of the pancreas. So hepaticojejunostomy you have seen, it is most of the times interrupted, because in robotic, you can do comfortably, even if it is a small duct also, you can do comfortable with the 4 or 5 OPDS based on the situation. Then gastrojejunostomy is same, GJ with the stapler, but I want to show the feeding jejunostomy. Robotically also you can do, no need to give incision and do struggling in that small incision. So you can do comfortable feeding jejunostomy with the T-tube, and just for the removal of the specimen, you have to give one small fine steel or midline incision based on the situation, and you can come out with the specimen. This is the specimen. The very, very fast, believe me, with the minimal access web pulse, whether it is a laparoscopy or robotic, the recovery will be very fast. And doing anastomosis, pancreaticojejunostomy or hepaticojejunostomy will be so comfortable than open surgery. If you start doing, you love it. I mean, few people say that you do resection in laparoscopy and do anastomosis. I think with the robo, doing reconstruction is easy than resection. Thank you, one and all.
Thank you so much, sir. This concludes the session on CA head and uncinate. We take it forward to the CA digital pancreas, the next session. I request Dr. Birappa Nagari sir to please moderate the session. And I call upon the first speaker for the Dr. Rupesh Mandava sir to please elaborate on the pancreatic protocol CT radiology. Thank you. I request all the speakers and panelists to please come on to the stage. Dr. Birappa sir, Dr. Partha Sarthi sir, Dr. Shravan sir, Dr. Mohan Narasimhan sir, Dr. Biju sir, and Dr. Vikram sir will be joining us on the Zoom session. Thank you. Shravan sir.
Switch. Fine.
I would like to thank the Dr. Vimlakar sir and his team for this opportunity. And so I'll go to the talk. So how is it different that you need to plan a pancreatic lesion CT? So we need to take the images in 0.625 slices. Then oral neutral contrast because it can obscure the lesion. Then we give about 1 to 1.5 ml of iodine contrast, and at a rate of about 4 ml to 5 ml we give. And the sequencing needs to be told beforehand. So we need to take a late arterial phase at 35 to 40 seconds and a portal venous phase at 65 to 70 seconds. So again, reformats, I'll show you the importance as we go through the talk. So this is how CT would be. So this will be the plain CT. This is an early arterial phase. So in an early arterial phase, you see the vessels very well. When you come to a late arterial phase, the arterial enhancing lesions like pancreatic lesions or liver tumors are seen better. In the late arterial phase, the metastatic lesions are seen better. And in the, this is the late arterial, I'm sorry, portal venous phase, we see the metastatic lesions better. And in delayed phases, you see fibrotic tumors or cholangiocarcinomas. So this CT shows the importance of why lesions need to be done according to protocol. This is the plain CT. This is the late arterial phase, and this is the portal venous phase. So if we take a portal venous phase directly, there's a high chance that this lesion could have been missed. So here we're seeing this lesion here, which can be missed in the if you are taking a direct portal venous phase. So this is another image where you're seeing the arterial anatomy needs to be picked up. So if you're taking a direct portal venous phase, we might miss anatomy. So newer CTs are coming, CT and photon counting CTs. So both of these are relatively new machines, less availability as of now. But in future, we hope we are able to work with these machines, because here, if you see this image, this is a late arterial phase. This is as good as an MRI of the pancreas. So these images you do not get in regular MDCTs. So where do we use MRI? We take MRI when we need to characterize indeterminate liver lesions, or in cystic pancreatic lesions, better characterization, and in cases where we need better characterization of the liver mets. PET CT, you need to do in case of pancreatic carcinoma with metastatic disease. And dual energy CT, again, it's not really available in a lot of places. Where do we do biomarkers? Biomarkers need to be done when you're doing follow-up CTs. They're more like a guide to see whether your response is good or not. So what all are we reporting in CT? This will be the plain CT. Location This is an early arterial phase. So in an early arterial the location of the tumor, then the vascular anatomy. So in coming to the location, about 65% of the adenocarcinomas are mostly located in the head. So in the head region, so they present early. So it is an advantage in a way that the patients present early. So they're, whereas in body and tail lesions, they do not have symptoms of obstruction very soon. So they generally present late. So reporting what all do we see? The size of the tumor, involvement of critical vascular structures, invasion of the vascular structures and nearby structures like transverse mesocolon, root of mesentery, and perineural invasion, and lymph nodal involvement. So what do the criteria say? So as per the DPCG criteria, if you have no contact in an arterial lesion, with the arteries, there's no contact, it is resectable. Whereas less than 90 degrees is borderline and more than 90 degrees is irresectable. Whereas in the venous, less than 90 degrees is resectable, 90 to 270 is borderline, and more than 270 is, or occlusion is irresectable. So additionally, we need to talk about perineural invasion, invasion of the root of mesentery, and invasion of the mesocolon when we are talking about the CT imaging. So, and we also need to put a note on metastasis and nodal disease. So coming to NCCN criteria, this has widened the surgical criteria. So here again, arterial is no contact. Borderline in case of head and uncinate process lesions, if there is solid tumor contact with the common hepatic without extension to celiac artery or hepatic artery bifurcation, and abutment and no extension to the SMA or variant artery, it is still borderline. Only when it is more than 180 degrees, it becomes irresectable. Whereas in body and tail lesions, abutment to the celiac axis or encasement of celiac axis without involvement of the aorta or GDA is borderline. In venous, less than 180 without contour irregularity is resectable. More than 180, where resection is possible and reconstruction is possible, is borderline. If the reconstruction and resection is not possible, there it becomes irresectable. So what is the difference between abutment and encasement is when it is less than 180 degrees, this is abutment. Whereas when it is more than 180 degrees, it becomes encasement. Why this is significant is when we are talking about abutment, there's a 40% chance that there is vascular invasion. But when we have more than 180 degrees, there's a 80% chance that there is vascular disease, microscopic disease. So again, we were talking about reformats. Why reformats are important? See, these are the same patient. So this is a coronal reformat where you have a very small involvement of the portal vein. So this is a zoomed image of this, the same image. But when this reformat is done perpendicular to the portal vein, this is more than 90 degrees. So as per the DPCG criteria, this becomes a borderline resectable disease. Coming to vascular involvement. So when there is vascular involvement, so here you're seeing the vein which is showing this sign, which is called as a teardrop sign. Basically, when there's a tumor and there is some amount of fibrosis going on, so the vessel wall gets retracted, and this sign is called a teardrop sign, which is a sign of vascular invasion. Again, this is what we are saying about encasement and abutment. Here you're seeing the wall of the vessel is irregular. And here you're seeing the wall is irregular. Along with that, you're also seeing the tumor going into the branches of the superior mesenteric artery. Now again, this is another patient where there's complete encasement of the vessel. So again, this is an axial MIP image where you can see irregularity along the wall. So this indicates there is significant vascular disease. I'll take 2 more minutes. So coming to TNM staging. So TNM, based on the size, now it does not say whether it is resectable or not. It is just to give a size criteria. This is the 8th TNM staging. So T0, T1, T2, T3, and nodal disease. So nodal disease, all that is in green, the segment level 5, 6, 12, 13, all of these nodes will be generally resected during the Whipple surgery. Whereas if we are seeing nodes in these, they need to be biopsied to prove metastasis. Because if there's a node, if these nodes are positive, that is saying that is distant metastasis. So this was one patient where there was a nodal disease in the para-aortic region. However, this turned out to be sarcoid. So this is again a resectable disease. These nodes will go with surgery. And here there was a node which was sampled on EBUS in the supradiaphragmatic location. And this came to be a malignant. So these are different metastasis, mesenteric disease, vesical region. This is one patient where microscopic disease has been picked up with liver MRI. Perineural invasion also needs to be commented upon. Arterial anatomy, a note has to be put on the reporting whether there are any accessory hepatic arteries, because during surgery, this can cause major disasters. So these are 2 different cases with the replaced accessory right hepatic artery coming from the SMA. So this will be the final checklist. So we need to mention about all of these: location, morphology, diameter of the lesion, enhancement, CBD and PD diameter, whether there is a stent, parenchyma, all the vessels, TNM staging, and the final checklist. Again, if this depends from institute to institute, so once we sit with the radiology department, I think these checklists need to be made institute to institute. So in post neoadjuvant therapy, like what is generally said is that this is a patient in whom you are seeing resolution of disease with neoadjuvant chemotherapy. So these patients generally you can do an R0 resection. Again, this patient, what it says is if there is regression of disease or it is stable disease, you can have an R0 resection. However, if there's progressive disease, the chances of an R0 resection are less. This is my last slide. So this is one place where we do a early arterial phase. NETs, then you need to do an early arterial phase, because these lesions can be missed if you're doing a late arterial phase. Thank you.
Thank you so much, sir, for the informative slide. Especially that checklist was very informative. Thank you so much, sir. Hope you are available for the discussion part. We'll proceed to the next session on central pancreatitis. It is a Zoom-based video presentation by Dr. Mohan Narasimhan, sir. I hope sir is available.
Good afternoon. Yes. Can you hear me? My audio available?
Yes, sir. Audible.
Yeah, I'll just go to the case. It is a 22-year-old female who had upper abdominal pain for last 1 year, and the CT showed mass in the body and tail of pancreas. It's more towards the tail of pancreas. There was no vascular invasion, so we planned for a resection. And the thing was, we actually planned for distal pancreatectomy, and because it was in the CT imaging shows more on towards the tail of the pancreas. And laparoscopy, we had this 4 ports, one in the 5 mm in the epigastrium, one working left side 5 mm, on camera 10 mm and 12 mm. Actually 5 mm convert to 12 mm for staplers if required. And this is a video. Initially, just open the lesser sac to see where the lesion is.
On. Can you have the CT scan, please?
Yeah.
We would like to see the CT scan.
Yes, sir.
Yeah.
Can you see?
Yeah. We are able to see.
Yeah. This is CT is more to body and tail of pancreas. So that's why we proceeded for the section. And we had a plan of doing a distal pancreatectomy, and depending on where the tumor is, how the remnant pancreas is, then we had a backup plan to do a central pancreatectomy also. Sorry. Yeah. Then we opened up the lesser sac and to have a look at the where the tumor is. And you can see it is just in the neck of the pancreas and more toward the proximal body of the pancreas. And with this, we thought we'll dissect it, and the remnant pancreas is good enough, then we plan for a central pancreas. So we were dissecting the lower border of the pancreas, and that is a remnant pancreas tail, and creating a plane behind. And you can see that splenic vein there, and this is the smaller branches in the lower border of pancreas. And dissecting towards the neck of the pancreas, where we can see the portal vein creating a plane in the tunnel valve. And you have to be very careful here so that you don't have unnecessary bleeding there. Now we go to the superior border of the pancreas and dissect there. There we encounter a splenic artery, and we thought it is coming in the way, so we ligated it. If you can preserve it, is fine. And if you have a short gastric intact, you can safely ligate the splenic artery here.
What was the diagnosis on the table? Did you think it's in a benign or malignant?
Yeah, it's a young patient, female patient. It looks like a spin. And we just loop the neck of the pancreas, apply the stapler there with a purple cartridge. And using that, just mobilize the pancreas distally.
So you have ligated both artery and vein, splenic artery and
No,
vein.
no, just the artery. Vein we have not ligated, just a branch we have ligated, a clip there. And we are dividing the pancreas with the underbeat. And mobilize the pancreas some more. And we felt there is a lot of pancreas remaining there. And we are a group which basically view of organ preservation. And we use ICG to just check the vascularity of the remnant pancreas. Take two stays, which is one above and below. This is ICG, you can check. And so you use the ICG to check the vascularity of the spleen also, just in case the spleen is also well vascularized. So ligating splenic artery doesn't make much of difference. And just do an anterior gastrotomy. Bring in the pancreas. And using a 20 V-lock suture, we do a pancreatic gastrostomy. Continuous. One superiorly, and then take one more V-lock and do the other 180-degree anastomosis. The key point is here the taking two sutures onto the pancreatic remnant, one on the superior border, the inferior border, because most of the bleeding in the post-operative period occur in these two edges. So we always take a suture there. And that also helps in traction and bringing the pancreas into the stomach. Once you finish the pancreatic anastomosis, then close the gastrotomy wound. Now close the gastrotomy wound, continuous with same V-lock sutures. After closing the gastrostomy, we routinely do a water leak test by insufflating air into the stomach. Finishing, we'll take the specimen, put it in the retrieval bag and take the specimen out. Patient based discharge in the post-operative core, and histopathology has come as a spin. Thank you.
Thank you so much, sir. To proceed to our next talk by Parthasarathi sir on surgical management of body and tail of pancreas.
Good afternoon, everyone. At the outset, I must thank and congratulate Vimalakar and his team for organizing this GICS series and keeping the academic fervor alive, and for this very high quality meet. My job is to talk on the carcinoma of the body and tail of the pancreas, surgical management. I think we'll see enough of technical aspects in the following speakers, so I'll keep my talk restricted to the principles of surgical management. As we know, cancers in the body and tail are much less common than in the head. Only 25% of them occur in this region. And just like the head of pancreas, surgical resection remains the mainstay of treatment. But unlike the surgical treatment of the head of pancreas cancers, there has not been much consensus and evolution and improvement in the techniques and principles of managing body and tail cancers. One reason might be their low incidence. And generally, the prognosis of a cancer of the body and tail is supposed to be worse than the head. But this is not because these are bad cancers. If you match them for stage to stage and for therapy, they are almost equal to the outcomes in a head cancer. Sometimes they're even better. So this is a busy slide as telling you what is borderline resectable, what is unresectable. For a surgeon, just remember, when would you say that you cannot resect a body and tail cancer? One, when you have an unreconstructible venous occlusion. The entire portal vein is gone. You have collaterals. You don't have a anastomosable or reconstructible portal vein. Or if you have a SMA, which is encased, just like Dr. Rupesh said, if you have more than 180-degree contact of the tumor with the SMA, it is called an encasement. You cannot resect this. Or if the celiac artery has got more than 180-degree encasement along with aortic involvement. If you have only celiac artery encasement, you can still go and resect. Celiac artery with aortic involvement makes it unresectable, or an involved GDA makes it unresectable. So for a surgeon, just remember unreconstructible venous involvement, encasement of SMA, encasement of celiac plus aortic involvement. These are the times when you would not resect. Rest all would fall under borderline or upfront resectable. That is all right, but you should know when you cannot go in. Apart from that, tumor involving the common hepatic artery or other arteries which are not in the vicinity, they definitely make it unresectable. So what is the problem in the surgical resection of CA body and tail? Most of them present late, so you'll always end up having tumors. These have a very high rate of positive margins. Margin, especially the posterior margin has got a high rate of positivity. Because they present late, the nodal burden is also high. And overall, they have a poor overall survival because of all these things. Only 6 to 20 or 30% 5-year survival is there. Many times, you feel that it is not that these tumors are not resectable, but the problem is usually because you cannot resect them adequately. Because if you actually see what is in contact with the body and tail of pancreas, you don't have, apart from the vascular structures, there's nothing which you cannot resect. You have adrenal, you have retroperitoneum, you have stomach, you have spleen, all of this can come off. Compared to the head of pancreas, where you can have major structures, IVC, portal vein, supramesenteric artery, which can actually be a technical challenge, making your resection still difficult. But what is the catch in body and tail is, you can resect, but are you resecting adequately is the catch. So for a very long time, even till now, the standard surgery for cancers of body and tail has been distal pancreaticosplenectomy with a D1 lymphadenectomy. Before going into what this entails and what you should actually do, what is the basis of further improvements in surgical resection has happened, it's good to see this a quick slide about how the pancreatic body and tail drains the lymph. So if you see the left part, if you can assume the tail and the distal body, they both go towards the spleen. So the superior part goes into the gastrosplenic nodes, the inferior part of the tail and body and distal body go into the splenic nodes. To the right, the proximal part of the body drains into the gastroduodenal node, and the lower margin body drains into the infrapancreatic node. If you take this blue and red arrows, they all form one single ring. So this is usually referred to as the N1 or the D1 station of body and tail cancers. A standard distal pancreaticosplenectomy usually takes care of these rings. But what has been found is there is another layer of lymph nodes, level of lymph nodes, which are along the left side of celiac, the left side of superior mesenteric artery, and to the left of aorta. You can see these three vertical nodes. They are also equally important lymph nodes. They are usually called level 2 lymph nodes, but it's important to remember that tumors need not follow a systematic pattern of tumor level 1, level 2. They can directly go to level 2 also, which makes it more important that you address those lymph nodes also when you resect a tumor. So there has been a lot of criticism on the inadequacy of a distal pancreaticosplenectomy in effectively treating CA body and tail. One main thing is it is not a margin oriented surgery. You try to get the tumor out, but you're not really, the surgery doesn't describe any landmarks for margins as to how you should go about this resection. That's one. If you do a DPS for a pancreatic spen, if you do a DPS for a mucinous adenoma, you would do a similar operation for a pancreatic body and tail cancer if you're doing pancreaticosplenectomy. That doesn't make sense because the entire pathology is different here. The lymph node spreads are different here. The posterior margin, which is the most crucial one deciding the outcomes of these surgical resections, is not cleared at all well in a standard DPS. And if you see how a standard distal pancreaticosplenectomy is done, it is usually done retrogradely. You start from the spleen, you mobilize the spleen, lift the pancreas from left to right, the surgeon is standing on the right, and then you're pulling everything towards you and you're resecting. So the actual posterior margin, which should be in front of you while you resect, is hidden by the pancreas, and then it is ergonomically also easy to do that thing. And as by principle, this does not acknowledge or address the entire lymph node drainage basin. So these are the points because of which DPS was thought to be an inadequate surgery for a carcinoma of tail and body. So to address this, Strasbourg in 2003, he published a small series of 10 patients where he described something called RAMS, radical antegrade pancreaticosplenectomy. So what is radical? Because you will address all the lymph node stations, you will address the entire posterior margin, and you will do all of this antegradely, meaning you will cut the neck and then go from right to left, because the margin which you want to resect is always in front of you. So you can see the margin, you can lift the posterior part of pancreas because you're working from the cut end and lifting the pancreas towards the spleen. Ergonomically also it's much easier, and you're doing everything under vision. So this is a medial to lateral approach. It is tailored to the depth of infiltration. So as you dissect and you see the tumor is deeper, you can shift your plane to one plane down. So there are two types of ramps, anterior and posterior. So you can tailor it based upon the tumor infiltration. You can achieve a more radical lymph node clearance. And like I told you, you can have different levels of radicality depending upon the tumor infiltration. So this is why this operation was considered to be a much better operation than a standard DPS for CA body and tail. So this is a diagram which shows, if you see in RAMS, whether it is anterior or posterior, you always go below the anterior renal fascia. The anterior renal fascia is always removed. What differentiates anterior and posterior is, are you going to remove the adrenal or not? So in anterior RAMS, you remove the anterior renal fascia, stay on top of the renal vein, cruise along the adrenal vein, cruise along the surface of left adrenal, and then you exit to the splenic flexure of the colon. In posterior RAMS, you go down to the renal vein, ligate the left adrenal vein, lift the adrenal, go posterior to the adrenal, and then reach the splenic flexure. So that is one layer below that. A standard arrow which is above the anterenal fascia, which is supposed to be an inadequate plane. So this is the product, how it looks after an anterior rams. You can see the left gastric artery and splenic artery are ligated. It is not always necessary to ligate the LGA, but sometimes for ease of lymph node clearance, you can ligate it. All the lymph node, the left border of the supramesenteric artery is also bare. So you can see the celiac artery, the left side of aorta, and the left side of SMA are all cleared of lymph nodes. You can see the exposed left renal vein. You can see the exposed adrenal vein and the adrenal, meaning the anterenal fascia is completely removed. And this is the final product of an anterior rams. In a posterior rams, you will see all of this minus the left adrenal vein and the left adrenal. So now this gets us to the question, who will you do rams for? Now that we have told so much about rams, is rams the only standard operation for CA body and tail, or is there any role for DPS at all? Having done all of this, do we actually see that rams has increased the cure rates and survival of CA body and tail of pancreas? Because logically it should, because it has found all the lymph nodes which drain a body, and then it's addressing all of it. The radicality is also higher. Because the rams is a much more morbid operation, is the morbidity comparable, the surgical morbidity comparable between a DPS? So there have been a lot of studies trying to address this. There have been a lot of results both for and against this. The main drawback of most of the studies has been the small numbers which they have. No single center, because of the rarity of the problem, no single center can have a huge experience of comparing RAMS versus standard DPS. Many of them are pooled analysis, multi-center, and very heterogeneous groups. One meta-analysis which is quite a good volume and quite recent, which has put this thing to rest, has shown that even though RAMS has got, philosophically, it's a much more radical operation, you do not find any increased disease-free survival or overall, you do not find any improved overall survival with RAMS. You can have an improved disease-free survival. You can have an increased yield of lymph nodes, because obviously you're dissecting much more lymph nodes in this. But does it actually translate into patient survival and patient benefit? No. Then there are also studies which nowadays it's the era of minimal access surgery. So people are doing the same RAMS procedure by robotic and laparoscopic. So the question arises, is doing RAMS by laparoscopy or robotic better or worse than open? There are actually RCTs in this, and the diploma RCT is a good RCT which has compared this, and it has proven non-inferiority of robotic or laparoscopic in compared to open for RAMS. But one has to understand that what is the most important factor which has impacted the outcome of patients with CA body and tail of pancreas? It is not DPS, it is not anterior RAMS or posterior RAMS. It is the neoadjuvant therapy. So as the neoadjuvant therapy protocols keep improving, you will start getting better results. This is the single most impactful factor for improving outcomes. So the last line about the advantage of RAMS is still not written, because neoadjuvant therapy will act in junction with the surgical technique also. So with improved neoadjuvant, you might start seeing an improvement in the outcomes of RAMS. As long as RAMS is not more harmful, it is a good surgery to use whenever you have patients who have got deeper posterior infiltration in the pancreas. So take-home message is, carcinoma body and tail of pancreas is rare. It's traditionally found to have poorer outcomes. The resection has to be always margin-oriented. RAMS definitely gives a better R0 resection, better lymph node yield, but so far there is controversy and it is doubted to have unproven survival benefit. Minimally invasive performance of these procedures is safe, but it has to be restricted to high volume centers, because these are the only centers which were able to show equivalency in morbidity compared to open. Multimodality therapy in high volume centers should be the way forward in treating patients with carcinoma body and tail of pancreas. Thank you.
Thank you, sir, for also partially covering up with Biju Senadipan's sir's topic. Unfortunately, sir is not available. And I think the second half of that will also be covered by Shravan sir when he will talk about neoadjuvant. For advanced pancreatic resections, we are off to Vikram Chaudhary sir now, who will be presenting online via Zoom. Vikram Chaudhary sir, I hope you are available. Thank you.
Hi, good afternoon, everyone, and thank you, Dr. Vimblakar, for this kind invitation. You seem to have arranged a fantastic meeting there in Hyderabad. I think it is being managed seamlessly. Part of it is online, part of it is in person. And the topic given to me by my friend Vimblakar is to discuss about advanced resections in pancreatic surgery. Am I audible? Can somebody give me the feedback?
It is audible, Vikram.
Yes. Okay, good. So when we discuss about advanced pancreatic resection, it's usually either a SMA divestment or a vascular resection, which is commonly a venous resection and sometimes an arterial resection, or an extended resection, which may or may not involve a multivisceral resection. So we're talking about a multivisceral resection or extended pancreatectomy or an arterial divestment or resection and a venous resection when we discuss about advanced resections in pancreatic cancer. A venous involvement in borderline resectable pancreatic cancer can sometimes be very straightforward, where a side biting clamp can be applied, or you can clamp the SMV portal vein and splenic vein by complete isolation, and a small involvement generally at the level of a venous branch may sometimes need a longitudinal resection and a transverse closure. And these are some of the examples of type 1 closures which we have done in the past, where you see the third image on the left side of the screen. The type 1 almost looks like a type 3. So even a large defects actually, when you don't want to convert it into type 3, they can still be done by a type 1 approach, where you keep the left-sided or right-sided vein intact, just take the pathological part of the venous involvement out. And because you have kept one end of the vein intact, there will be no angulation. And so if you can plan it well, even a large potential type 3 can be converted into type 1. But generally, type 1 and type 3 are easier resections. The common, a more difficult resection, I would say, is a type 2 patch repair. Different types of patches can be used. This is usually ideal for venous involvements which are across the splenoportal confluence, where you want to preserve the splenic vein, or when the venous involvement is long length. In that case, when the type 3 is likely to be difficult, a type 2 may be a good salvage procedure rather than opting for a type 4, because we know that the type 4 probably has a higher incidence of thrombosis and a likely difficult resection. A peritoneal patch is the commonly used technique. Sometimes you can use venous grafts if you have with you at your center, but commonly a peritoneal patch or a falciform, sometimes even pericardial patch can be used. Type 3, most common, most robust, and probably the easiest of the lot. I think that lower down the zone of SME involvement is as low, the level of difficulty increases. But this is the standard type 3 section where we can see that there's a replaced artery and SMA divestment has been done. Type 4, more often than not, will be a complex venous resection. It may or may not be associated with the combined artery resection, but most of our type 4 resections are associated with artery resection. The commonest scenario you see here is a type 4 vein resection with a CH resection. So the commonest vascular resection in pancreas is a vein resection. We recently tried to combine the multicenter data from India, and we requested the large volume centers across the country to share with us their vein resection data. So we got around 400 cases, and you can see there is a significant improvement in survival in the patients who are undergoing portal vein resection in pancreatic cancer. So median survival in India has, in operated patient has gone beyond 2 years. In this particular study, the median survival in pancreatic cancer who underwent portal vein resection in India came out to be 25 months. It is at least 6 to 8 months larger or more than my previous publication for borderline resectable pancreatic cancer, which I did a few years back. In that, the patients who underwent surgery after neoadjuvant therapy had a median survival of 18 months. So there is definite improvement and jump in survival in pancreatic cancer, operated cases of pancreatic cancer in our country across the centers. I think this was done with acceptable morbidity at around 32%. And I think the 6% mortality rate in vascular resection is also an acceptable world standard. Decent 1, 3, and 5 year survival rate. So more and more venous resections are becoming standard in our country, and more centers are doing it in a proper way. And we are seeing many patients being benefited with venous resections. But when it comes to LAPC, it's a different ball game. Borderline resectable pancreatic cancer, locally advanced pancreatic cancer are slightly different spectrums. As the patient goes towards local advancement, the possibility of inoperability and the techniques which you are likely or required to use in these cases are different. So you want to choose those patients more selectively. You want to be more selective than what you are in borderline resectable pancreatic cancer. And you definitely want patients who really have a good response, whether it is a biological response in the form of normalization or reduction in the CA19-9, whether it is a tumor volume response after chemotherapy, a technical feasibility of vascular resection and reconstruction, with which you are comfortable with, because each center will have a different extent to which they would want to extend. Even we were not doing a certain arterial resections few years back or a decade back, but since last 7-8 years, our center has gone to that level. But the technical feasibility of vascular resection and reconstruction is always center specific. And patient, of course, for any vascular resection has to have a good performance status. Only if these criteria are satisfied, you will selectively consider patients of locally advanced pancreatic cancer for surgery. So again, we published our experience of extended resections. You can see that the median survival for extended resections is around 21 months compared to only venous resections, which is around 25 months. And these are the results. Most of these surgeries were done in last 7 to 8 years. And you can see that there is 6% mortality, which is consistent with previous value of vascular resections. The morbidity is slightly higher with these extended resections and is in the range of 42%. But again, there is a significant increase in the patients who undergo extended resections for locally advanced pancreatic cancer with an acceptable morbidity and mortality. And you can see that if you use the neoadjuvant therapy judiciously, if you refine your surgical technique gradually, you can do more and more complex resections and at the same time provide improved outcome to the patients, and patients may benefit with improved survival. And that has been the story about borderline resectable and locally advanced pancreatic cancer in last 20 years, that surgeons have extended their indications, they have selected their patients well, and ultimately the patients have benefited with more resections and more survival. So for LAPC, as we said, the triangle clearance, divestment, and vascular resections are the techniques which you use. I think everybody is aware of this triangle. This is a circumferential divestment for a patient who had a right replaced artery which was completely encased by the tumor along with origin of the SMA. But you can see that this patient could be done. A little bit about the technique of SMA divestment. We discuss it a lot of times. You see this patient with a long segment, 270-degree arterial involvement. The first standard step of in these patients is always, for me, is taking the control. The principles of vascular surgery don't change it just because you are doing it in pancreatic resection. It's always the proximal and distal control. So you can see that the celiac and the SMA control has been taken. So once the control is taken proximally, you go and take the control distally. Again, the availability of SMV stump at the lower end is absolutely important to confirm. And then you go on the artery. The most robust SMA first approach, I would say, is the transmesocholic approach and left posterior approach. And with this approach, once you do a level 3 arterial resection, more often than not, you can do a safe divestment. So the aim of this dissection is to find out that whether a distal SMS stump is free. You can see that the SMS stump has been looped. So you know that the venous distal stump is available. The SMA proximal and distal control has been achieved. The first jejunal artery here you can see, second jejunal artery here you can see is free. The first jejunal artery is being ligated at the origin. And now we are entering the divestment plane. And this is a combined, a sharp and a dissection in the periadventitial plane, which we always talk about. This is what we mean when we do the divestment. Now, in this particular patient, you can see that I'm dissecting in the periadventitial plane with a scissor. We already have a control on the SMA at the origin and distally, and then this first jejunal artery is being taken, and the dissection continues in this periadventitial plane gradually. Now, this is you are only likely to get 2 to 3 branches, but wherever they are, you need to be particularly meticulous in that area, because even a small arterial bleed in this region may sometimes result in a difficult resection, and it can complicate your resection. So IPDA taken at a distance from the SMA origin is different than IPDA which is taken at the origin when you are in a divestment plane, and you have to be very, very clear about what you're trying to do. And this is the end of the resection. You can see that 2 bulldogs have been applied at the proximal and distal end, and then I'm taking this difficult IPDA, which may sometimes bleed, and you may have to take a 6-0 suture there. So that's the technique of a divestment, which we usually keep on discussing about, which takes us to sometimes this may not be feasible. So these are the radiological images. When you have a circumferential SMA encasement, you know that you have to be prepared for a potential SMA resection. And sometimes when you are doing a divestment, you can have a surprise, and you should be prepared for SMA resection in all these cases of LAPC, which are around SMA. But more often than that, we can know the commonest arterial resection which is done is an Appleby. Again, it follows the same principle of controlling the celiac at the origin. In Appleby, you are resecting the celiac, so you are actually doing the divestment of the SMA, which is hemicircumferential along the anterior and the left border, and separating and trying to go to the origin of the celiac. So you're not actually dissecting the celiac, but you're dissecting the SMA off. You're only dissecting the origin of the celiac. So that's the standard of proximal control. The next commitment step would be the pancreatic neck transection. Then you will go to the, now this is the step which determines whether the resection is going to be easy or difficult. If the splenoportal confluence is easy, the surgery is likely to be easy, because the left-sided venous involvement is a tricky situation to deal with sometimes. And once you have that, you just go in the anterior to the SMA, go into the plane, dissect out everything, and then connect to your origin of the SMA dissection, and then take the celiac at the origin, confirm the arterial flow, dissect out everything, dissect out the left gastric artery, and then take the celiac, and that's how you finish an Appleby. I think I have only 8 minutes, so just let me know if I have some more time, or if I can. This was another Appleby, but I think rather than Appleby. Now, another complex resection is a CHA involvement. This is not only seen in pancreatic cancer, but some of the cholangiocarcinomas also have a CHA origin and a GDA and CHA involvement, and sometimes a portal vein involvement, which is above the splenoportal confluence. So this is typical of cholangiocarcinomas, not only pancreatic cancers, which may again need, you can see that the proximal and distal control on the hepatic artery and the left and right hepatic artery has been achieved. A complete control of the SMV and the portal vein has been taken. And once you do that, usually for a combined artery and vein resection at this area, it's the arterial reconstruction. Commonly, I use a GSV interposition for that, is what you do. And then once you have artery liver inflow with the artery, then you do the portal vein afterwards and take out the specimen and hang the specimen before that on the vein and the artery completely. So that's generally the technique for sometimes you do an extended resection. Here, I think I have already committed for the resection. The patient ultimately required a separate interposition of right and left hepatic artery onto this graft. A little desperate resection, but patient did well for around 1.5 years after surgery. And you can sometimes extend this resection. Most of the times, these kind of resections are associated with complete total pancreatectomy, because having a high-risk pancreatic stump in such resections is can be really morbid. Last but not the least, a small video of a SMA resection we are discussing about. So this was a locally advanced neuroendocrine tumor. You can see that she received chemo PRRT. There was a local advancement, artery and vein both were involved. We delayed the surgery. We treated with non-operative measures, but ultimately the patient progressed a little bit. Jaundice developed, so plan for surgery, and this is what we found. Again, the same standard steps we'll see. You will see cauterization, control of the celiac and the SMA at the origin, confirmation of the proximal stump. Here you can see that the SMA is being looped. Similarly, again, the transmesocolic or the inframesocolic or the left posterior approach, you will see the same steps. I will be repeating the same step. Here again, I will take the SMV control. I will try to find out the distal SMA stump. And when you have both proximal and distal stump, we will do some commitment steps. So vein is looped. Now you will see that the artery is looped. The second jejunal artery you can see already arising from that. So now we are sure that we have a length of SMA which is free. So either if it is a divestment or resection, but we have distal and proximal stump, so we can definitely go ahead and proceed with our irreversible steps of gastric and pancreatic transection. There was a little bit of underestimation of disease along the celiac origin, but I could dissect it off completely. And these are the final steps of resection and commitment. You see that everything is looped and being hanged. There is a proximal and distal stump ready. The celiac has been separated. You can see that the final celiac separation from the specimen. And once this ends, the specimen is now hanging only on the artery and vein. And therefore, you need to plan and sequence your resection well. It's absolutely important to plan your surgery completely before you actually execute it. It should be executed in your mind first and brain first before you do. So now here you see the specimen needed some more dissection. So I decided to put a temporary interposition shunt or even a type 4 reconstruction, you can say. I think the only precaution in this is the axis of the graft which you need to put. And once you do that, you have all the time in the world to do your artery. Because if you're doing artery and vein in sequence, it is sometimes a good idea to do the vein first, put the liver into the flow, reduce the risk of bowel, mark the angles always for the vein and artery. Once you have the angles marked, take the controls, resect, and a straightforward 6-0 or 7-0 anastomosis will take care of your artery. The vein is already in flow, so you have some time to do this resection artery, and you are less stressed. And once you do that, once this is done, this is as good as a small bowel auto transplantation. So you see that the graft has now become redundant, and you can excise that. And this type 4 resection was converted to type 3 resection. So this became a end-to-end SMA and portal end resection with pancreatic duodenectomy. So these are some of the advanced resection which I wanted to share with you. Thank you very much. If there are any questions, I would be happy to take, or maybe at the end of session. Thank you.
Thank you, Mohan. Thank you very much. We'll go to the next topic. Yeah. I think everybody is hungry. I think you need to finish it off.
Yes, actually, we have started the lunch. We have kept it working, sir, and we'll be breaking after this session. This is the last session on neoadjuvant. After the neoadjuvant will over, we'll proceed with surgery and then start the adjuvant session after.
Surgery or lunch? Surgery అంటే మళ్ళీ ఏంది lunch. You're hungry, man.
Good afternoon, everyone. At the outset, I would like to thank Dr. Vimla sir and team for giving me this opportunity. I am really surprised because house was full when I came, and just because of lunch now it's not there. So it shows the quality of sessions basically you are conducting, sir. And till now there are interesting videos, but as a medical oncologist, we just see trial designs and results. So hope I won't bore you. So we all know the pancreatic cancer is a dreaded cancer. Once patient get cancer, it's almost a death sentence. even it is an early disease.
Why did you do this?
Pancreatic cancer in whole is the 23rd
No, you have to do
India,
this one.
cancer
Read my line.
13,000, and out of 13,000, 12,000 patients die in a year. This is Globacon 2022 data.
Follow your
5
pattern.
years survival is not great even in early stages. Approximate 5 years survival is 40%. Stage 2 it is nearly 20%, and stage 3 it's 10%, and stage 4 0 5 years survival at 5 years survival for stage 4. However, only 15 to 20% of the patients present with resectable, upfront resectable disease. 40% are metastatic and 40% are borderline or locally advanced disease. This is the TNM staging, which is already discussed by Rupesh sir. However, this is not used for resectability. The resectability criteria is based on this NCCN guidelines and other guidelines. This is taken from NCCN. This was discussed by Partha sir extensively. So here we divide into resectable, borderline resectable, unresectable. Usually, as sir was saying, you should remember whether it is unresectable. But for us, whatever surgeon said, we just think that it is unresectable. We don't remember much. But to say a resectable cancer is if it is not contacting with celiac axis or superior mesenteric artery or hepatic artery, or if abutment with vein, it should be less than 180 degrees. If in unresectable cases, if it is a head and uncinate process cancer, greater than 180-degree contact with SMA or CA is unresectable. For body and tail, if it is greater than 180 degrees contact with SMA or celiac axis, or if aortic artery or gastroduodenal artery is involved, it is unresectable. And for vein, if it is greater than 180 degrees contact, along with irregularity and thrombus is present, but it should not be able to resected or reconstructed. So that these are the two. If you remember these two things, then automatically rest all are borderline resectable. So jumping into the treatment directly, for a resectable cancer, this is taken from ESMO guidelines. We have treatment guidelines depending upon the ESMO or ASCO or NCCN. This is taken from ESMO guidelines, which is simple, easy to follow. So in a resectable cancer, any patient can go for surgery directly. If after surgery, within 8 to 12 weeks, we should start him on chemotherapy. If it is early or late, the survival chances are lesser compared to starting in this period. The survival probability decreases because of morbidity if you start early, and if you start late, basically micrometastasis spread and disease can metastasize. So after surgery, if patient is having good performance status, fit enough, then FOLFOX chemotherapy, FOLFIRINOX chemotherapy is the treatment of choice. If patient is elderly, 75 years, greater than 75 years of age, ECOG PS2, and frail patients, we usually use gemcitabine along with capecitabine. That is the treatment of choice. In borderline resectable cases, if clinical trial or in borderline resectable cases and locally advanced cases, if it is not metastatic, we usually treat in same lines. If there is a clinical trial available, patient should be ideally enrolled in clinical trial, but in India, it's not possible. So we either go with FOLFIRINOX chemotherapy if patient is fit enough, again young and fit, then we go with FOLFIRINOX chemotherapy because that chemotherapy has the highest response rates of approximately 40%. And if patient is not fit enough, then we usually go for gemcitabine capecitabine chemotherapy. That chemotherapy has response rates of approximately 20%. Other than this, there is no use of giving any single agent chemotherapy like gemcitabine alone or 5-fluorouracil alone, because the resection rates after this chemotherapy, giving single agent chemotherapy, is less than 5%. It won't help. So if patient is medically fit, at least 2 to 4 months of chemotherapy, induction chemotherapy, if patient is medically fit on imaging assessment, there is stable disease or response on CN19, then all patients should be surgically explored definitely. Because after giving chemotherapy, the CT or PET CT is not will not assess properly the amount of response it has. So even if it is a stable, that is because to chemotherapy, whatever we have given, there will be
desmoplastic
reaction and fibrosis. So the imaging might not be adequate to assess actual response. So all
Hi, Vimlakar, we are running behind schedule.
and
Is it?
response should ideally go for surgical exploration. This will help.
Yeah.
The R0 resections are
नहीं अभी तो
high
किसी
even if
और
it
का
is
चल
stable disease. So surgical exploration should be done with R0 resection as the target. And once the R0 after surgery, again within 8 to 12 weeks, we need to give adjuvant chemotherapy depending upon the
ठीक है तो
amount of chemotherapy
मेरे को
which
फोन
was
करना मैं
given
तभी ज्वाइन
earlier.
करता हाँ
In total, the chemotherapy duration should be around 6 months. If it is around 6 months, total chemotherapy, it definitely helps in progression-free survival and overall survival of the patient. So if there is no response, or if it is just a stable disease even after surgical exploration, then we just continue the chemotherapy and make the patient palliative and go for next lines of therapy. The same goes with locally advanced and metastatic disease also. So this is NCCN guidelines. It is same as ESMO guidelines, but the major difference is even in resectable disease, they consider some high risk factors, particularly patients who are having equivocal and intermediate image findings, large primary tumors, large regional lymph nodes, excessive weight loss, excessive pain, and markedly elevated CA99. If there are these factors, you should consider for going into neoadjuvant chemotherapy. For example, here you see an image of preoperative CA19 levels and resectability and survival. So as the CA19 level increases, the probability of surgical resectability decreases and the survival also decreases. So what is the advantages and disadvantages of giving neoadjuvant therapy in resectable pancreatic cancer? Basically, you assess the sensitivity of the tumor, you understand the biology of the disease, and we are giving a systemic treatment immediately to avoid micrometastatic disease, and patient might be benefiting from surgical intervention, which helps in R0 resection. But the disadvantages are patient is obviously sometimes he might be losing the window for the curative resection, and for any patient who requires neoadjuvant chemotherapy, there should be definitely biopsy, and if there is a jaundice, definitely they should get stenting either through biliary stenting or ERCP if needed. So these are the major advantages and disadvantages. For any borderline pancreatic cancer I was discussing, we give neoadjuvant chemotherapy as I already pointed out, to understand the biology, to prevent micrometastatic disease, to increase the margins negative resection, improves disease-free survival and overall survival. But again, special considerations, you need tissue biopsy, jaundice to drainage to prevent jaundice, and we need to do germline testing and somatic testing to assess the actionable targeted mutations. So coming to the actual topic, which which are chemotherapy regimens in the neoadjuvant setting. Basically, okay, I will rush up. There are few regimens in resectable cancer, few regimens in the borderline pancreatic cancer. This is the trial PROPANC 1 in borderline and resectable pancreatic cancer, where patients are randomized to gemcitabine radiotherapy versus surgery initially. And in gemcitabine radiotherapy arm, they were after surgery, they were again given 4 cycles of gemcitabine. After surgery, for second arm, 6 cycles of gemcitabine was given. So there was significant, clinically significant, numerically significant median overall survival improvement, 16 months versus 14 months. And there is high increase in R0 resections, 70% versus 40% for the chemoradiotherapy arm. However, after 4 years of follow-up, 5 years of follow-up, it showed that patient who had borderline resectable disease and who had received neoadjuvant chemoradiotherapy had better survival compared to that of borderline resectable upfront surgery. So initially this established chemoradiotherapy followed by surgery in borderline pancreatic cancers. This is a SWOG trial which compared, and it is in resectable cancers, which compared modified FOLFIRINOX and gemcitabine nab-paclitaxel followed by surgery and again adjuvant therapy. These both regimens can be used. This trial proved that both regimens can be used in neoadjuvant setting for better response and resections. So this is again JSAP Japanese trial, where patients are randomized to gemcitabine plus S1 versus surgery, immediate surgery. In gemcitabine plus S1 arm, 2 cycles were given, followed by surgery, and then again 6 months of S1 was given. In this trial, it showed that patients who are having neoadjuvant chemotherapy, followed by surgery, followed by chemotherapy again, had better overall survival. In the range of median survival was 36 months in this arm compared to that of immediate surgery, followed by adjuvant chemotherapy had only 26 months. So this is next. These are the 3 trials which actually established neoadjuvant chemotherapy in the resectable cancers for high risk disease. Next, we see. I'll say about. I will tell you at least 2 trials. Then we'll skip to final slides. So pre-OPANC trials. I will just tell you the these regimens. Basically, we can use modified FOLFIRINOX in the neoadjuvant setting for borderline pancreatic cancers, or gemcitabine plus gemcitabine with radiotherapy, followed by surgery, followed by adjuvant therapy to complete 6 months of therapy. So this is the pre-OPANC trial, which compared FOLFIRINOX versus gemcitabine with radiotherapy. It did not show any difference of overall survival among both the groups. And next is this SPAC5 trial, where 4 regimens are used: GemCape, FOLFIRINOX, and chemoradiotherapy along with gemcitabine. Again, compared to upfront surgery, again it showed that if you use neoadjuvant chemotherapy in some form, the overall survivals are much better compared to that of immediate surgery in the borderline pancreatic cancers. So this is the new trial which recently published. In this trial, basically PAXG was evaluated, where all efficacious drugs like cisplatin, gemcitabine, nab-paclitaxel, and capecitabine are used in upfront neoadjuvant settings, along compared with modified FOLFIRINOX, and it definitely showed much better event-free survival and overall survival compared to that of modified FOLFIRINOX. So these are the regimens which I have discussed, and just take home points. In a resectable cancer, induction chemotherapy is not a standard protocol, but if high risk factors are present, we can consider them. In borderline pancreatic cancer, definitely induction chemotherapy followed by surgery, followed by adjuvant therapy is also important to improve disease-free survival and overall survival. And same goes with locally advanced pancreatic cancers. Thank you.
Thank you so much, sir, for consenting about neoadjuvant options. I'll request.
No more speakers, no?
No more speakers.
Okay.
So
with the permission of the Vimlakar, we'll break for the lunch. No more questions. Any questions?
We'll just gather for a felicitation, sir, group photo. As I think most of us have already had their lunch, we'll just break for a 15-minute lunch session and then continue with our section by 2:45. Thank you.
Hello.
Hi.
When is my presentation?
Actually, I'm also the presenter.
Oh, sorry,
I
sir.
think.
Even I am waiting, sir. So whenever, so you are also waiting.
Yeah, yeah. Mine was scheduled at 3:30.
So you have mine is 2:40. So it is, sir, early. Mine is. So it. I think it should be another 1 hour before you'll have your presentation.
It is running late.
But we can't see that presentations. No, others presentation.
I think we'll have to open YouTube to see the presentation.
YouTube, no? Chalo,
It is
ठीक
being
ठीक.
streamed live. Yeah.
Hello. Hello.
Zoom check करो. Sir join हो क्या? Challenge करने बोल के.
I have joined.
Sir, hello.
Yes,
Sir, are you online, sir?
I'm online, but I can't hear any audio from there.
Just a second, sir.
I have joined and there is some Dr. Bharat Vaswani there.
Yes, sir. Sir, he is for the next session, sir. After your talk.
So I'm
we are
ready to
adding
share
you,
my
sir.
screen.
Yes, sir. Just a second, sir.
Yeah, but no audio. I don't know what is wrong.
Just a second, sir. Mic क्या है?
Check on.
Yeah, now I hear some audio.
Hi, sir. Good afternoon.
Yes, can you hear me? Hello?
Hi, sir.
Yes, now I can hear you.
Sir, unmute, sir.
Unmute? I have unmuted myself. I can hear you. Can you hear me? Hello?
Hello.
Hello?
Yeah, sir. You're audible.
Can you hear me?
Yes, sir. Yes, sir.
Lovely.
Yes, sir. I'm Dr. Vimlak Reddy, sir. Here, Dr. Shastri, sir, Birappa, sir, and Pratap Reddy, sir, are there, sir. You can go proceed, sir.
I can proceed with my lecture.
Yes, sir. Yes, sir.
How many people are attending today?
230, sir.
All over the country or all over the state?
Only state, sir.
Fantastic. Congratulations to you.
Thank
And such a pleasure to be with all of you today afternoon. Are you able to see my screen?
Yes, sir.
Okay. So thank you so much for offering me a chance to participate in this teaching program. The brief given to me is aftermath of a Whipple, and I will try to share with you my experience. So let's start right away. The measure of a surgeon is not only in avoiding complications, but in recognizing and rescuing patients when they occur. This is an important fact which we should be keeping in mind. Please remember that mastery is acquired through deliberate reflection on thousands of cases, not just our technical skill. Now, the journey to this so-called mastery, I won't even use the word mastery, is that you begin as a novice, then you become competent, and after competent, I think you continue your journey till you end your career in an effort to be a master. So the novice will follow the rules rigidly and will consider complications as failures. The competent person is going to recognize certain patterns and knows what to do in standard complications. And the master would be one who will anticipate that problems are going to happen and then turn a potential crisis or a real crisis into a success. So these are some things which we have learned from Michael Gladwell and from so many experts around the world, that there is a certain cognitive framework for it. 10,000 plus hours creates intuitive awareness of subtle danger signs. And we pre-play scenarios. Any of the master surgeons would pre-play scenarios that if this is to happen, how will I respond and what will be my response to that? I think that is something very important for us to know. And it's constantly important to keep on asking meta recognition, what am I missing? As I talk to you today afternoon, I have a patient on post-operative day 8, Whipple, in my private ward, 74-year-old lady. Abdomen is soft. She shifted out of the ICU. Count has gone up. She has a chyle leak. So all these issues are constantly thinking as to what are the multiple areas. Albumin is 2.8. All these things tell you that you have to constantly keep on asking yourself, what are you missing, despite thousands of cases that are being managed. So there is something known as intraoperative mastery, which you will try to avoid and handle situations well in the operation theater so that your aftermath of a Whipple is easy. I will go quickly because this is not important, but very important so that your aftermath can be managed better. You cannot fix what you cannot see. So whether it's bleeding, whether it's lack of exposure, whether it is poor assistant, if you're not able to see well, you will not be able to do a good operation. And operating in a bloody field is going to create more problems than solve. At such times, direct pressure, increase the incision, improve the light, make suction is okay, and then you will be able to solve even a complex problem. But usually the problem is not complex. We end up making it into a complex problem. So try to avoid that, that if something goes wrong, just put a pack there and wait, take a deep breath. Make sure your anesthetist nurse, everybody is on board with you, and then you try to tackle it. The other thing is a very important thing. Pride will kill patients. The best surgeons know when to call for help, and the good ones and the better ones are going to call earlier. Do not consider it as a defeat and do not fight with your ego that something has gone wrong. Every personality is different, every patient is different, every ICU and every OT complex is different. So you should know when to call for help. And after creating a mess, calling for help is not maturity. Calling for help early is real maturity. Even if 5 other colleagues tell you that you are very timid and you should have done this, why did you call somebody for help? That is not surgical maturity. We have analyzed our own 50 major complications. And whenever one consultant has involved another's experienced or a senior consultant early, then you are going to reduce the chances of things going wrong, even in the immediate post-operative period and in the long-term post-operative period. The other thing is you should also know how to avoid complications when trying to overdo things. Sometimes the bravest decision is to close. You must know that there are certain boundaries within which you can do an operation and there are certain boundaries which you should not cross. So a master will recognize unwinnable situations. Maybe you will try a lot, but then you will say this is not winnable and back out. Living to operate another day beats dying on principle. Remember this. So if there is going to be a potentially hell of a bleeding for which you are not going to be able to control it, if you discover unexpected disease more than your scans or your multidisciplinary tumor board has told you, or if the patient deterioration is something which is not good despite maximal support initially, you should think of actually closing patients like this, because you will never win a game like this. The other bit is the 1 minute pause. Just take a step back. Do not try to immediately react to anything. Survey the whole field, get the whole team together, and choose deliberately what you want to do. So 60 seconds of thinking saves 60 minutes of bad surgery that can follow. So please take care of that. Portal vein injury. Immediately, the key is, if your mobilization is good, apply direct pressure with your gauze pieces. Ask anesthesia to make sure that they are okay with volume status and IV access. Call for vascular instruments if not available. In my OT, vascular instruments are always ready because pancreatic surgery is vascular surgery. And hopefully, in a difficult case, you have already got proximal and distal control. But in case you don't have it, then don't try to dive into it and do something without getting proximal and distal control, even in the event of a bleed. 2 fingers more than vascular instruments will control your bleed, and then you need to vocalize and get your second and third assistant to do something steadily so that the bleeding is not occurring, the anesthetist is with you, and you get the proximal and distal control. Vast majority of portal vein superior mesenteric injuries can be easily repaired with a single suture of 5-0 or 6-0 running suture of round body proline. Usually a 17 millimeter needle, but sometimes even a 13 millimeter needle would be okay. The repair options, I won't go into details. That's not the brief of my talk. But you can do a primary repair, a patch repair, or a segmental repair. If you get a hepatic artery or an SMA injury, please understand it's different from a venous injury. Higher pressure system, more difficult control. Quality of blood vessels can be very different with the kind of diabetes and fatty livers that we have in our country. Many of the younger patients also can have very bad quality arteries. Remember one thing, the chance to repair an artery is only once, unlike a vein. Because there is very less tolerance for stenosis after a repair. So either you are experienced in arterial anastomosis or arterial repair, or just get proximal and distal control and call somebody who is doing this day in and day out, for whom it would be a much easier, more refined job than for you. These are not the times for you to learn how to repair an artery. These are the times where you just get an expert to repair an artery. So think about all these issues. I won't go into details because my talk is aftermath of a Whipple. Massive intraoperative hemorrhage. This is what I told you already. I won't repeat it. Pack, communicate, identify source, and then definitive control. And never operate or never put clamps in a blind, bleeding, operable or bleeding field. Now, you also have situations, and all these prepare you for the aftermath of Whipple. And so I tell you this: dense adhesions, inflamed tissues, and unable to identify anatomy are the difficult dissection scenarios. And each of these situations require you to respond. I won't say react, respond differently. So please pace, as they say in cricket, you pace your innings, you please pace your operation, identify your strengths and weaknesses of your own self as well as your team, and understand that individual patient, and then decide how you want to deal with these difficult dissection scenarios. Now, this is the main topic which you want me to pay attention to, and this is where I will focus on vigilance first and rescue later. With an experience of over 2,600 Whipple resections in the last 2 decades, I must have managed about 500 major and minor complications And we have got some data which is coming out and going to get published very soon. So the operation begins after you leave the operating room. So vigilance in the post-operative management defines ultimate success. If you are not seeing the patient twice a day for the first 5 days, you are making a big mistake. However easy, simple, or well done the operation might have been. So there is no protocol here. This must be instinct from experience that see the patient twice a day for the first 5 days. The other thing is, when you should not wait for the obvious signs to come. Tachycardia, leukocytosis, tender abdomen, silent abdomen, and guarding is already very, very, very late. Please understand that. These are all the straightforward signs for any one of you to tell you that this is a silent abdomen with peritonitis, with sepsis. Too late. So masters don't wait for obvious signs. They sense these subtle signs even before they try to confirm anything via the lab or via the scans. So what are the subtle signs that I look for? Patient is looking different, but the vitals are okay. So you are uncomfortable in your belly. Drain output character changes, not necessarily the volume. The volume can change, but drain character changes. The nurses say that, yeah, the patient pulse, blood pressure is okay, but patient is not eating well, patient is not active, patient is lying down. I don't feel good, sir. Do listen to the nurses. Do not treat the reports. And remember, if the patient has a baseline which is different from tachycardia, then treat even a minor tachycardia beyond postoperative day 2 very seriously. Don't say must be some little hydration issue. Anesthesia did not give enough pain control. Patient had just finished a walk and so the tachycardia was there. These are the very patients you watch before you land in trouble. So you must have an early warning system. What has 1,800 operations taught us? You will get grade B fistulas and you will also get grade C fistulas. And if you get grade C fistulas, you're going to get a fair bit of mortality also. In my earlier 5 years, the mortality for grade C fistulas, and I'm talking from the period 2002 to 2007 or 8, it was even more higher. Now we are able to salvage and rescue and perhaps anticipate grade C fistulas much earlier and treat them early. So the key learning is that outcomes improve with experience, not necessarily from avoiding fistulas, but also we are able to manage them better, provided you suspect them all the time. A sentinel bleed is never a bleed. It is an announcement of a catastrophe. So please, when the patient is stable and in the ward and there is a sentinel bleed, you act on a war footing immediately, not expecting and hoping that nothing will happen. The important predictors of post-pancreatectomy hemorrhage is if there is a leak like biliary leak or a post-operative acute pancreatitis, the ISGPS. I led this paper and this concept, and you can see this in the Annals of Surgery in 2022 when we published post-operative acute pancreatitis or post-resection acute pancreatitis as a part of an ISGPS consensus. And also infection. These are the 3 things which are very well known to give rise to post-pancreatectomy hemorrhage. Now, post-pancreatectomy hemorrhage, we classically do it by terms of timing. Early is within post-op day 3 and late is after post-op day 3. Early, surgeon must take the ownership first. Do not blame coagulation profile, fluctuations in blood pressure, etc., and look here and there for excuses. Acknowledge that if something has bled in the first 3 days, it is your failure and only your responsibility. So technical issue can be either at anastomosis or a vascular issue. So look at it carefully, both intraluminally and extraluminally. After day 3, if you're going to get a bleed, start thinking about a post-operative pancreatic fistula. But it doesn't have to be only a GDA which is affected by this fistula. You can get number of other sites. I have published on this long ago in 2006 in digestive surgery with my colleague Moritz Venter. And we have cited with a picture what are the various sites from where you can get a post-operative bleeding, and you must have a mental checklist, especially the operating surgeon. And that's where I said intraoperative attention to detail is important. Is it a pancreatica magna? Is it a small branch which is a superior pancreaticoduodenal or inferior pancreaticoduodenal artery? What was the takeoff of the SPDA? Was it in close relationship to the GDA? Was the right gastric artery taken well? Was the cystic artery taken well? Was the gallbladder removed carefully from the liver? Any of these sites, how was the jejunum mesentery mobilized? How was the jejunal mesentery vascular control achieved when you divided the DJ flexure and brought out the jejunum into the supracolic compartment? How was the suturing at the inferior and superior border of the pancreas? How did I divide the pancreatic neck? Was there bleeding in the pancreatic neck, which I have underrun adequately before starting pancreatic anastomosis? Did I do a gastrojejunostomy well? Think about all these things, which is a careful checklist when you have a bleeding which is late after postoperative day 3. Act by angiography, clinically resuscitating patients well, even before they go into any terrible shock. And if required, you have to operate as well on occasions. Now, what is the management? Hemodynamically stable, CT angio, and then interventional radiology, SOS embolization. Unstable or purely intraluminal bleed, you can do endoscopy, and occasionally the cause may be just an erosive gastritis. You can manage it with endoscopy. But if the bleeding is sustained and it's early, then you should not hesitate to even go back again, identify the source, and try to get source control of the POPF as well. And if required, do a disconnection of the leaking pancreatic anastomosis, or worse, completion pancreatectomy. In my experience, in the vast majority of cases, you don't need a completion pancreatectomy. You can disconnect the pancreaticojejunostomy and do an infant feeding tube like a virsangostomy and bring it out, and you will be able to come out of that difficult abdominal situation and inflamed situation, and hopefully the patient won't bleed. Remember that the mortality of post-pancreatectomy hemorrhage with re-exploration can approach up to 50%. Delayed gastric emptying. Counterintuitive wisdom is that the complication that tests the patience, not your skill. We all know that you should resort to early jejunostomy feeds while waiting, resolves them faster. While waiting, resolves faster than aggressive prokinetics. So if you feel that there is a problem with DGE, support the patient, talk to them, aggressively feed them with jejunostomy feeds, give some time, and you will get there. Our data from 312 delayed gastric emptying cases, all grades, median resolution 16 days, early feeds via nasojejunal tube did shorten the duration by about 4 days. Prokinetics, sometimes they work, sometimes they don't. We all try them. Patient needs to be given confidence, and we need to give them education about various timelines that will enable them to have less anxiety and their compliance improves, and then hopefully DG is handled by you well. Bile leak, if there is a doubt, you can check the bilirubin levels in the drain. If it's frankly bile stained output, then the recognition is obvious. And also remember, you may not have an actual bile leak, but you may have a pancreatic leak, which is also mixed with bile. So effectively, it becomes a pancreatic and a biliary leak. Majority will resolve with adequate drainage. Uncommonly, you have to do PTBD, but you may have to resort to that. And even more uncommon than PTBD is to actually do a stenting. In the vast majority of cases that we have done a PTBD, it's just the internal external stent, which has ensured that the bile goes into the efferent limb of the loop of jejunum, and then the leaks heal. General guideline, dilated thick wall vascular bile ducts, you may consider a continuous running suture while doing a hepaticojejunostomy. But the minute the bile duct is not very large, or the minute the bile duct is a little bit thin, it is more prudent to do interrupted suture anastomosis to avoid the problems of a bile leak in a major surgery like Whipple. Intra-abdominal collections can often be POPFs, which will unmask themselves or will be uncovered by us later on, or they can be real intra-abdominal collections. Whenever you get persistent fever despite antibiotics, even go look for the 5 millimeter and 10 millimeter collection that can be bad enough to give you trouble afterwards. Look at procalcitonin and CRP and also the standard WBC count. Look at how the patient feels as regards appetite. Palpate the abdomen every day. And of course, if you have clinical deterioration without a clear cause, you have to remember that there is some collection somewhere. And then in such patients, keep a very low threshold for CT scan. Today's patient, which I spoke to you at the beginning of the lecture, I have seen the patient today morning. I've asked to keep a low threshold and we have done a CT scan and I'll follow up with her in the evening and we will respond accordingly for the fact that her WBC count is on the higher side, despite a soft abdomen, despite drain being already out, but she had a chyle leak. So you need to watch these patients more closely. Sepsis after pancreatic surgery, the commonest sources are infected pancreatic fluid collections. Secondary to infected pancreatic collections, usually you can get pneumonia. Get the Foley's catheter out early. Do not go for necklines as far as possible. 70 to 80% of my Whipple resections will not get a neckline, if not 90%. Only those who might require IV access for a longer period of time for any reason, or those vascular resections which require a lot of transfusions, etc., will get a major IV line like a neckline. Otherwise, we would just manage with a peripheral line. Foley's catheter, I told you, and more obese, the more bulkier the patients, higher is the chance of wound infection. Also, biliary sepsis is a major problem for wound infection. A large number of patients we treat with ERCP and stent done, and the organisms either in the bile or in the stent are often multi-drug resistant. So you have to be handling these situations carefully with source control, appropriate antibiotics, and supportive care. Failure to rescue is something which is unacceptable for HPB surgeons and the specialty that we have chosen. Death after complications often results not from the complication itself, but from failure to recognize and manage it appropriately. Never forget that. So structured daily rounds, not just by one surgeon, but by the entire team at different times, will also keep on adding more information, which will enable us to salvage things which can potentially be devastating. You must clearly, between the entire surgical and intensive care team and the nursing team, have a clear protocol in place for early escalation, whether it's investigations or treatment or alerting other specialties when you have a challenge in a patient. And early involvement of the ICU, and I would add interventional radiology, is also important when things are not going wrong. These are all the critical concepts which can contribute to the concept of failure to rescue. Old publication of me and my colleague Parul Shukla, who is now in New York, but this was published in the New Zealand ANZ Journal of Surgery, I think in 2008 or 9. But these are the areas where we would go in early for surgery, again for complications after Whipples. And broadly, this has stood the test of time. Peritonitis with hemodynamic compromise, a good wash will help. Uncontrolled sepsis and hemorrhage, despite one or at the most two interventional radiology attempts, you must go in and don't sit. You pass one pigtail, then wait for 3 days, then you pass another pigtail, then you wait for another 3-4 days. You're losing valuable time. So whatever you do, do it one time and act early. Bowel obstruction, do not wait for long. Something has gone wrong. And if there is a wound dehiscence, you need to address it well rather than trying to conserve it. Wound dehiscence, majority of the cases means the problem is not just in the wound, the problem is inside the abdomen, and then you want to wash it out. So complications don't kill per se. Failure to rescue does kill. The difference between good and great centers is not complication rates, it is the rescue rates. Remember that you work in a team. So you need to build a rescue system. What do experienced high volume centers do differently? It is the systems that trump any individual talent or heroics. Protocols will be such that they will create a safety net for all and that will catch the patients before they fall. Essential components, I referred to it partly. Daily multidisciplinary rounds with intensive care, interventional radiology, infectious diseases to be done. Structured assessment protocols for early detection and also predefined escalation protocols. And we require round-the-clock access to interventional radiology, like I may be needing one today afternoon on a Sunday while working. So this is what I mean by the T-MOD pancreatoduodenectomy framework. One should learn from every death. Timing, when did death occur relative to the operation? Mechanism, what was the pathophysiologic cause? Opportunity, where were the potential intervention points? And disease, how did the underlying disease actually contribute to the problem? Systematic analysis of 37 mortalities identified 8 preventable deaths and changed protocols. And I speak on a background of more than 20 years of experience with Whipple resection in perhaps the highest volumes. This is also aftermath of Whipple, let me tell you, communicating bad news, and it's best to be honest. None of the patients' families or members expect perfection, but they do expect sincerity, hard work, honesty, effort, and our presence. So don't hide from complications. You should walk towards your complications and handle the patient and their relatives. And the template is very simple. You objectively state what has happened, explain what you are doing about it or going to do about it, set some type of time expectations or timelines. You may not have the clear answers, but explain and say so, and then be there daily, morning and evening, even if you feel uncomfortable, even if you feel you can't do much. So you should predict that. And so you have the fistula risk score validation. We have looked at over 800 cases for that. And the negligible risk is when a FRS is 0 to 2, 1.4% risk of grade B and grade C fistula. But when the risk is 7 to 10, FRS is 7 to 10, then the risk goes to 64%. So you must also know when to tailor your surveillance intensity. A high-risk patient is looked after differently versus a low-risk patient, both in terms of ICU stay, drains, stay in the hospital, and other factors, including antibiotics, and sometimes things like octreotide or pasireotide. So remember what has changed. Same operation, different surgeon. Technique has barely evolved. Judgment has transformed. So the master's advantage is not just in skills, it's in the head. So pattern recognition is important before crisis develops. Earlier intervention with fewer heroics are needed. You select your patients better and counsel them better, and have a team which is consistent and dedicated for smoother coordination in terms of repetition and following certain protocols well. So this is where I can tell you that you cannot fix what you cannot see. Pride will kill your patients more than help you. Sometimes the brave decision is to close. The operation begins after you leave the OR. Sentinel bleed is never a sentinel one. Complications don't kill. Failure to rescue does kill patients. Trust your nurses and the people working with you far more than just laboratory details. It's not your talent, but it's your ritual and your systems that will separate you and make you a safer surgeon than most others. Do not trust radiology reports on the printouts. See the radiology yourself on the console, not some radiology plates. Do discuss everything in multidisciplinary rounds with everyone. Maintain your complication database with a root cause analysis. And then we are able to teach ourselves and our trainees as to why and not just the how. So always make sure that you document everything in every patient without knowing why you are documenting data. And I can tell you that even after an experience of more than 2000 ripples, I continue to still learn new something or the other every month. So mastery is not a destination, it's a commitment to continuous improvement. So it's not the complications you encounter that define your surgical career. It is what you learn from each one of them. So every complication is a teacher for you if you are willing to be a student, and start your complication database today so that you document the patterns, not just the events. The events are only 4: bleeding, DGE, fistula, delayed gastric emptying, hemorrhage. Those are events, but document patterns, learn deliberately and improve systematically. So the journey from good to great begins with always a single reflection. This was the time at the Tata Memorial for me, post my fellowship in Heidelberg for 20 years. I continued there till December 2025. I've already begun a new career in Glen Eagles Hospital and Bridge Candy Hospital and Shrikande Clinic. I've already ended up doing 14 more pancreatic resections. Amir Pare, my new younger consultant, comes up with this TMOD framework, which we have just got published in Annals of Surgery in January. You all should study this carefully. It's just out in print, which talks about our 58 deaths from a study population of 1,727 Whipples. So the mortality rate was 3.4, and it's always about TMOD. And you can see that there is a delay in some of those rescue situations where we could have prevented perhaps 1/3 of these cases. Of course, this is in hindsight, and this is an analysis for us to learn and do better going ahead. This was my 25 years as a young consultant, then as the head of GI and as the head of surgical oncology. And then it's taken me all over the world thanks to this great institution and the great department that I had. And now I take over with new roles thanks to Mr. Ratan Tata and the Tata Cancer Care Group. But thank you so much for this invitation and look forward to question and answers. Thank you. Is somebody there?
Yeah, here, Shastri here.
Hello, sir.
Well, that is Dr. Shailesh Srikande for you and his word of wisdom. To call Shailesh a stalwart is almost an understatement. He is almost an authority who has redefined the pancreatic surgery, particularly Whipple. He is a relentless academician, and you have just witnessed how it reflects in such a succinct summary of his own personal experience of the aftermath of Whipple. Shailesh, we have really enjoyed your keynote address and wish you all the best in your new innings.
Thank you so much, sir. I'm sorry I can't meet you in person, but we will meet soon. And it was a pleasure to interact on this Sunday afternoon and to talk to you. Very grateful for your patience and time.
Dr. Shailesh, Dr. Pratap Reddy.
Hi, sir.
Yeah. So in Whipples, without a proper pancreatic duct to do a duct to mucosa anastomosis, you must have done the simple dunking technique of pancreaticojejunostomy.
Yes, you want my comment to that, sir?
No. What are the results compared to duct to mucosa?
So I think I've, in this large experience of more than 2000, I must have just done a dunking procedure 4 or 5 times where the pancreas was sclerotic and hard, and we did not find the duct. But I can tell you that in a number of patients, one thing that I have done is to take a break after the resection, then to revise the margin with a knife to the left, and then to use an operating loop, And in a number of cases, when a duct is apparently not seen before, we have found it. So the number of times that I have done a dunking procedure is literally 4 or 5 times. And that is usually a sclerotic pancreas where it's not a problem to be able to dunk it inside. So that's my experience of the dunking procedure for pancreaticojejunostomy. Earlier on, I have assisted and known a number of dunking procedures for pancreaticogastrostomy. And there I have more experience, not as an independent surgeon, but as a senior fellow. There were some advantages of the pancreaticogastrostomy, but also a number of disadvantages. So I have preferred to stick to the pancreaticojejunostomy in a ductal mucosa fashion.
My second question is, how many pancreatic type C fistulas you have personally operated and what are the results and what have you done?
So I think type C pancreatic fistulas, the vast majority of the cases, I have done disconnection of the pancreatic anastomosis by safeguarding the bile duct anastomosis. So one thing I do intraoperatively is to always keep a sufficient limb of the jejunum between the pancreas and the bile duct, so that God forbid if something goes wrong, I'm able to go near the caudate lobe or lesser curvature of the stomach, pick up that limb of the jejunum, disconnect it with a stapler, and then with finger dissection, disconnect the pancreaticojejunostomy, resect that redundant segment of jejunum, and then prepare an infant feeding tube and bring it out as a virsangostomy. Of course, that infant feeding tube, you need to make a few side holes very meticulously and then fix the tube both as it exits the pancreas and also as it exits the peritoneal cavity at the level of the peritoneum, and a third layer of sutures will be at the level of the skin. So vast majority of times, washout and abdominal drains. Very severe situation, disconnect of a pancreaticojejunostomy, experience of 2 completion pancreatectomies in 20 years, and you will have about 30% patients who will still not do well due to sepsis, etc., and we will lose them with POPFC. But 70% of them, we would be able to even salvage a POPFC, but the key would be to go in early rather than go in late. So I always had one discussion with my intensivist and anesthetist that scan may be looking okay, but patient is not okay. And the philosophy has been the patient will withstand even a negative laparotomy just now if required, but afterwards the patient will not withstand it. So if you are having doubts about the quality of your anastomosis or the doubt about the quality of the CT scan or the collection reported on the CT scan vis-a-vis how the patient is doing clinically, there have been times where I've opened the patient on clinical suspicion more than objective data. And again, when I have done that, again 80 to 90% of the times that clinical suspicion or hunch has actually helped us and helped the patient to withstand that insult of a relaparotomy and get better. The problem comes when patient keeps on giving us hope that he or she is getting better. The reports are telling you that things are better. But if this kind of story continues after week 3, my threshold is very low for early resurgery, because operating at the very end of a grade C fistula is like diagnosing pregnancy with postpartum hemorrhage. It's too late. We do all that and then they all die. So that's too late. So that's what I've tried to do while dealing with POPF grade C, sir.
Dr. Sailesh, Dr. Birappa here.
Hi, sir.
Hi, sir. Really, we enjoyed your keynote address. And I have a small doubt. As you said, the sentinel bleed is definitely not a sentinel.
Yeah.
So the moment we see some blood in the drain, we have done angiogram, conventional CT, but not able to find out exactly the site of a bleed.
Yes.
In spite of having a watch of the patient vitals and everything.
Yes.
Hits and stops. So
Yes.
did you have any such kind of
Yes, yes, we will have. So if there has been a substantial sentinel bleed to the point that we have had to consider giving transfusion, sometimes we have also done one thing, that if it is starting and stopping, when we have done the angiography in an optimized patient, we have even left the sheath inside for 12 to 24 hours and shifted the patient to the recovery, so that we have a low threshold to do a repeat angiography, say within 6 hours, because it's like catching the thief while the thief is actually stealing. It's a dynamic process of the bleeding. If the bleeding has stopped at that time, you may not find it. But the bigger thing that I would aim for in these situations, sir, is to accept that there are so many raw areas which can bleed. But for these raw areas to bleed, even a 5 cc undrained collection or an infected collection, which may not be looking frankly infected. There is no air pocket. It's not looking dirty pus on CT scan. That's obvious. But you might still have some collections in relationship to the superior mesenteric vein, superior mesenteric artery, in relationship to the common hepatic artery, gastroduodenal artery. In those areas, I try to look for these small collections, because usually the radiologist also says, no, it is nothing, post-operative change, abdomen is soft, patient is in the ward, patient had passed stool on the 4th day, was feeling hungry on the 3rd day, etc. And the count is 9,000 has become 12,000 today, but patient is okay. He had one episode of fever. These are the types of patients where we have to start suspecting that something is brewing which has caused the bleed. So is there a small collection? Now, if they are not able to see, and if you still don't find, these are the very patients, sir. I'm not saying in all cases, but keep a low threshold for exploration and a thorough wash. If nothing is found, you will at least have a thorough wash given to clear all the microorganisms and the bacteria and the undrained collections, and then you have a better chance of dealing with it. But usually a sentinel bleed, if it's in association with a POPF, you will always find some cause of the sentinel bleed in the first, second, or third attempt, which might explain what is going wrong, especially if it is arterial, which is what I'm discussing actually.
Thank you.
Thank you.
So thank you so much, sir. Thanks for the time you've given. Sorry for the delay, actually. Thank you so much on behalf of Team Vimlakar, Kim Sunshine, and Telangana Association of Surgical Gastroenterologists.
Thank you. Thank you very much. All the best. Enjoy the rest of the program. Thank you for inviting me. Bye-bye.
Thank you, sir, for a beautiful talk. Now we proceed with the next session, which is neuroendocrine tumor. For the first session in it, Dr. Chetan Kantaria, sir, will talk about insulinoma. Thank you.
What? Sharon? Sharon. एक मिनट You are screen sharing. Yeah, what do you want to share? Where is your PPT? Excellent. Where is your PPT? This functional net? This?
Yeah, Vimlakar, I'm sharing. Yeah. Hello.
Hello. Yes,
Hello.
sir.
Yeah.
You're
My
audible.
screen is visible?
Yes, sir. Visible. You're audible.
Okay. So, respected seniors and colleagues, the topic of my today's talk is on insulinoma, a functional neuroendocrine tumor. So, insulinoma is the most frequently encountered neuroendocrine tumor, accounting for around 2% of pancreatic neoplasms. Its annual incidence is reported to be 1 to 2 per 100,000 population. It originates in beta cells of Langerhans and is usually located at the cephalic and the corporeal portions of the pancreas. In 90% of cases, it is benign and isolated. And in around 5 to 10% of cases, it may be in multiple locations and it is usually malignant. It is associated with genetic syndromes, mainly MEN type 1. As far as its symptoms is concerned, it is basically because of the manifestation of hypoglycemia, which results from the endogenous hyperinsulinemia. It usually occurs on an empty stomach or following exercise, though at times it can occur independent of food intake or even postprandial. Initially, the symptoms are intermittent, but as the natural history progresses, it becomes more frequent and persistent. Because of the non-specificity of these symptoms, there is usually a delay in diagnosis, and at times it is as late as up to 5 years in 20% of cases. One important thing to be noted is that the severity of symptoms does not correlate with the tumor size. Now, clinically, one makes a diagnosis of insulinoma based on Whipple's trial, that is low blood glucose, occurrence of neuroglycopenic signs, and resolutions of symptoms, the administration of glucose. An elevated level of C-peptide. The fasting blood glucose level is the gold standard because fasting provokes clinical symptoms, which usually takes up to 72 hours. Its sensitivity is as high as 89 and specificity is 100. So it's not unusual to get a low plasma glucose less than around 2.2 millimoles or a high levels of insulin more than 6 international units per liter, more than 50 moles per liter, or C peptides more than Yeah. Now, is it visible? Hello?
Yes, sir.
Okay. So as a surgeons, once the diagnosis of insulinoma is made, we are more interested in knowing where it is located within the pancreas. So the various diagnostic techniques which one can make use of is contrast enhanced ultrasonography, endoscopic ultrasonography, CT scan, MRI, and gadolinium scan. So this chart depicts its sensitivity and specificity of each investigation. To talk of each of them in brief, EUS is the most accurate diagnostic tool for it detects tumor as small as 5 millimeters. Its detection rate is 94%, and when combined with CT scan, it reaches to 100%. It not only localizes the tumor, but it also determines its relationship with the duct and the vascular structures. It analyzes the edges in lymph node and also facilitates biopsy and cytology. US reduces the need to do a blind distal pancreatectomy by about 25%. Its disadvantage is that it's invasive and highly operator dependent, and it has a poor sensitivity for caudal pancreatic tumors. Next is CUS. It is cheap, non-invasive, with sensitivity of around 90% and specificity of 86%. It can be also used intraoperatively, and when combined with digital palpation, it gives you 95% sensitivity. CT scan is the first line of imaging which we all use. It not only helps in localizing, but it also tells us the relationship with the adjacent structures, and it also evaluates the metastasis. Usually you see a hypervascular lesion which displays more enhancement than the normal pancreatic parenchyma on arterial and capillary phase. Having said that, it can also have an atypical imaging appearance in 25% of patients, such as isoattenuating lesions in the post-contrast CT scan. So this is a representative CT scan showing the insulinoma. MRI is done when atypical features are present on CT scan. The classical appearance on T1 weighted imaging is hyperintense lesion, and in T2 weighted lesion, you see an hyperintense lesion. The typically insulinoma also tends to be more hypervascular with stronger enhancement than normal parenchyma on arterial and venous phase on a contrast enhanced MRI. So these are the representative images showing the localization of insulinoma on MRI. Next is the 18F F-DOPA PET-CT image. This by itself has a very limited value. And this is because the uptake by the whole pancreatic gland is uniformly the same. However, on addition of carbidopa, what happens is that this injection of carbidopa leads to low residual pancreatic activity, preserving the tumoral uptake, whereby the tumor gets enhanced and is easily localized, helps in localization. So this is a representative image of F-DOPA PET-CT imaging. Now coming to treatment. The goal of the treatment is twofold. That is to control the hormone secretion, and second is to remove the tumor. The aim of medical treatment is to control the symptoms and to control the tumoral growth. And medical treatment is indicated in patients awaiting surgery, or patients for some reason who are not eligible for surgery, or in patients with malignant metastatic presentations. So medical treatment comprises of dietary measures, injection glucose and diazoxide, which is the primary line of treatment. It is a non-diuretic benzothiazide analog, which acts directly on Langerhans beta cells, inhibiting insulin secretion and stimulating glycogenolysis. It helps in controlling symptoms in almost 50 to 60% of cases. In patients, analogs such as octreotide is commonly used. So this forms a treatment where the diazoxide is not effective, or in patients who are not fit for surgery, because it also has an anti-proliferative effect. Besides this, one can use verapamil, beta blockers, phenytoin, and glucocorticoids. Coming to surgery, it is the cornerstone of curative treatment. For a patient with benign single superficial tumor less than 2 centimeters and not adherent to pancreatic duct, tumor enucleation with preservation of pancreatic parenchyma is the treatment of choice. Whereas for locally advanced tumors, where malignancy is suspected, or where there is contact with pancreatic duct, bile duct, or any vessels, then pancreatic excision in form of either pancreaticoduodenectomy, central pancreatectomy, or total pancreatectomy can be done depending upon the location of tumor. Once the surgery is performed, it is recommended that a thorough follow-up should be done, begins within 3 months of the surgery and is continued every 6 to 12 months for at least 7 years. As far as the excess of surgery is concerned, minimal excess surgery is the gold standard, with Gagner et al. Advocating laparoscopic surgery way back in 1996. He reported a resection success rate of around 100%, with a cure rate ranging from 77 to 100%, with overall survival of 95% at 5 years and 88% at 10 years. However, minimal excess surgery has its limitation, and it should not be done when the preoperative localization of the lesion has not been done, or in patients presenting with malignancy or MEN type 1 presentation. So this is a laparoscopic image where you see the insulinoma, and here you see it being enucleated by a blunt dissection. Besides this, nowadays, US guided RF ablation is done. It is reported to be safe and effective. It enables selective and precise ablation of insulinomas. It minimizes damage to surrounding tissues, and it avoids post-operative complications, which is associated with pancreatic surgery. It can be done in lesions less than 2 centimeter, solitary and benign lesions with no associated genetic syndromes, and there should be 1 millimeters distance of the lesion from the main pancreatic duct. So to summarize, the management of insulinoma requires a multidisciplinary approach, including the surgeons, the endocrinologists, the interventional radiologists, and surgery is the gold standard. The aim of the surgery should be to remove the tumor and to preserve the surrounding pancreatic tissue as far as possible to maintain the normal endocrine function, and success of the surgery depends upon the accurate preoperative localization of the tumor. Thank you very much. This is our hospital. We are celebrating its 100 years. We completed 100 years on 22nd January. Thank you very much.
Thank you so much, sir. To continue the discussion on functional neuroendocrine tumor ahead, I would request Manoj sir to come over and discuss about Zollinger-Ellison syndrome and VIPoma. Thank you, Chetan sir.
Thank you.
Good afternoon, everyone. I'm Dr. Manoj Kumar, consultant surgical gastroenterologist and robotic surgeon from Medicover Hospitals, Hyatt City. I heartfully thank Dr. Vimalakar Reddy sir for giving me this opportunity. Today, my topic would be on Zollinger-Ellison syndrome and VIPoma. Going into the Zollinger-Ellison syndrome, it was first described in 1955. The characteristic of this syndrome is gastric ulcer, gastroesophageal reflux disease, and chronic diarrhea that is responsive to PPIs. It is caused by gastrinoma, a neuroendocrine tumor that secretes gastrin. Usually located in the gastrinoma triangle, that is Passaro's triangle. In 90% of lesions will be in this triangle only. So this is bordered by the junction of cystic duct CBD, and junction of second and third part of the duodenum, and junction of the head and body of the pancreas. So other locations include lymph nodes, stomach, mesentery, etc. More common in women with no age predilection, actually. And 60 to 90% of them are malignant, and 80% of gastrinomas are sporadic. 20% of them are associated with MEN1 syndrome, which is characterized by parathyroid tumors in 90% of cases, pancreatic tumors in 70%, and pituitary tumors in 35%. Coming to the pathophysiology, this gastrinoma secretes gastrin that stimulates the parietal cells to produce more acid, which causes symptoms of GERD, that is heartburn, esophagitis, and reflux. And also it causes ulcer, probably bleeding and perforation. The second thing is excessive acid causes inactivation of pancreatic enzymes that leads to impaired digestion, and also it damages the small bowel mucosa, which affects the fat transport, resulting in fatty diarrhea. So fasting hypergastremia results in increased basal acid output 4 to 10 times, 4 to 6 times increase in parietal cells and ECL cells, and uncontrolled proliferation of ECL cells may cause carcinoid tumor. And excess acid, as I told you before, can result in fatty diarrhea. Coming to the symptoms, most common symptom is abdominal pain. Other symptoms we have described already. And diarrhea is the predominant symptom in 9 to 20% of patients. And the characteristic of this diarrhea is it's low volume, it's less than 1 liter per day, high frequency, fatty diarrhea, and it responds to PPI. And because of the widespread use of PPI, complications of peptic ulcer disease such as perforation, bleeding, and peptic strictures are not common these days. Coming to the diagnosis, gold standard is fasting serum gastrin along with the gastric pH. We should discontinue PPAs for 1 week. Fasting serum gastrin greater than 10 times the upper limit with gastric pH of less than 2 is diagnostic. Physiological hypergastremia can occur in other conditions such as chronic atrophic gastritis, H. pylori infection, PPI use, and renal failure. If fasting serum gastrin is less than 10 times, then further testing is needed, that is secretin stimulation test. In a normal individual, secretin decreases the secretion of gastrin, whereas in a gastrinoma, secretin stimulates the secretin receptors on the gastrinoma and cause paradoxical increase in the gastrin levels. So increase in serum gastrin after secretin injection of greater than 120 picograms per ml or basal acid output increase greater than 15 milliequivalents per hour is diagnostics of gastrinoma. Coming to the imaging, it was elaborated by the previous speaker. So I quickly go through this. CCT sensitivity for tumor greater than 2 centimeters is 80 to 100%, more sensitive for hepatic mets than primary. MRI is second line, used only in patients with iodine allergy or renal impairment or better delineation of hepatic mets. US has a diagnostic accuracy of 90% and can detect tumors as small as 2 to 3 millimeters. And the gold standard is SRS scintigraphy. There are two types, indium labeled arterioscan with SPECT CT or 68 gallium labeled DOTA PET. DOTA PET is the gold standard investigation right now for pancreatic neuroendocrine tumors. PET CT has a limited role. It is usually useful in high-grade tumors and poorly differentiated neuroendocrine tumors that are not functional. So this is the algorithm how to evaluate a case of gastrinoma. This was described early. So coming to the treatment, the initial treatment would be control of acid hypersecretion. As we all know, PPAs are the mainstay of treatment. Once or twice a daily dosing is enough. Complicated cases, you can use twice daily dose. H2 receptor antagonists, higher doses are required with more frequent dosing with increased dosage yearly. They are fallen out of favor nowadays. And one should be wary of long-term effects of PPA therapy, includes nutrient malabsorption, gastric carcinoids, bone fractures, PPA-induced nephritis, pneumonias, hypomagnesemia, and enteric infections. Coming to the surgery, it's the only cure in patients with Zollinger-Ellison syndrome. Immediate post-operative cure can be seen in 50 to 60%, long-term cure rates of 35 to 40%. Critical surgical steps involves exploration of abdomen, especially the gastroma triangle, White Cocker's maneuver, duodenectomy with duodenal transillumination to identify small lesions. And small tumors in duodenum can be enucleated. And multiple tumors in duodenum, we need to do pancreas preserving duodenal resection. Small lesions in the pancreas away from the pancreatic duct, you can enucleate them. Lesions close to pancreatic duct are greater than 2 centimeters in the pancreatic duct, we need pancreatoduodenectomy. And intraoperative ultrasound is indispensable in identification of lesions intraop. Routine lymphadenectomy should be done as these lesions have 45 to 60% of lymph node involvement at the time of diagnosis. Surgery in patients with ZDS and MEN1 syndrome is controversial. Some advocate surgery, some advocate wait and watch approach, and advocating surgery only in patients with lesions greater than 2 centimeters. But recent ENS guidelines say any operation in MEN1 associated duodenal ZDS should include exploration of duodenum via duodenectomy with excision of duodenal and resection of duodenum with systemic lymphadenectomy. The higher chance of cure when performing a pancreatoduodenectomy should be discussed with patients in terms of risk and benefit. So coming to the treatment in patients with metastatic disease, cytoreductive surgery, when 90% of visible tumor can be resected, only 50% of metastatic ZDS are eligible for this treatment. Chemotherapy involves treatment with streptozotocin, 5-fluorouracil, or temozolomide. Liver-directed therapies are used for the tumors less than 5 centimeters in size. which includes chemoembolization, radioembolization with yttrium-90 microspheres, and radiofrequency ablation. Biotherapies that are somatostatin analogs, octreotide and lanreotide, their efficacy is proven in improving progression-free survival in PROMID and CLARINET trials. And targeted therapies, everolimus and sunitinib, they are first-line treatment in well-differentiated unresectable PNETs according to NCCN guidelines. Liver transplant is an option which is rarely done. The most recent therapy for metastatic disease is peptide radioreceptor therapy, where yttrium-90 labeled or lutetium-177 labeled somatostatin analogs are used. Partial response is seen in greater than 40% of patients. And this has been studied in NETR-1 trial, which showed improved progression-free survival, improved quality of life, and decrease in tumor size. This treatment was FDA approved in 2018. Side effects are myelosuppression and nephrotoxicity. So these are the ENETS guidelines on management of metastatic PNETs. So if you see the first one, that is gastrinoma, first line treatment will be high dose PPA therapy. Second line would be somatostatin analogs. Third line would be peptide radioreceptor therapy, and fourth line will be chemotherapy or targeted therapy with sunitinib or everolimus. Coming to my second topic, that is lipoma. It's also known as Werner-Morrison syndrome. It's caused by excessive secretion of vasoactive intestinal peptide, also known as WHA syndrome or pancreatic cholera, because it causes profuse watery diarrhea, hypokalemia, achlorhydria, and shock. Usually seen in fourth decade, more common in females, 95% are solitary, majority are intrapancreatic. Body and tail, you can see 75% of lesions, and head, 25% of lesions. Other locations can also be seen. So coming to the pathogenesis, vasoactive intestinal peptide adheres to the receptors on the intestinal epithelial cells, activating adenate cyclate pathway, initiate excretion and suppresses reabsorption of sodium, chloride, potassium, water in small intestine, resulting in profound secretory diarrhea. Clinical presentation, we described it already. One thing to remember, it causes severe watery diarrhea with excessive, more than 3 liters fluid will be gone and without steatorrhea. In contrast to osmotic diarrhea, this persists while fasting. The other thing that can be seen, hypokalemic, non-ion gap, metabolic acidosis, hypochlorhydria, flushing, hyperglycemia, and hypercalcemia. Characteristic for the diagnosis is secretory diarrhea greater than 700 ml per day with the serum VIP level greater than 200 picograms per ml. Imaging has been described already. Dota-NAC PET is most sensitive. Initial medical management will be correction of dehydration, electrolyte abnormalities, and restoration of acid balance. Surgery, management of metastatic disease, just like other PNETs which have been described already. This is the algorithm for treatment of lipoma, localized disease less than 2 centimeters, enucleation with lymph node dissection, greater than 2 centimeters, pancreatidoidectomy or distal pancreatectomy, metastatic disease, surgery, if possible, a debulking surgery, radiation therapy, PRRT. Medical treatment involves somatostatin analogs, chemotherapy, and symptom-directed therapy includes hydration, somatostatin analogs, glucose control. And liver-directed therapy includes surgical resection, ablation, liver transarterial chemoembolization, or rarely liver transplantation. So again, coming to the management of metastatic lipoma according to ENETS guidelines, first-line therapy would be hydration, somatostatin analogs, steroids. Second line treatment would be peptide radioreceptor therapy. Third line treatment would be chemotherapy or targeted therapy with sunitinib or everolimus. Thank you so much.
Thank you, sir. Especially that last slide was very concise. Thank you. Next, Dr. Bharat Vaswani, sir, will join us on Zoom on a session on metastatic neuroendocrine tumor, a medical oncology perspective. Bharat Vaswani, sir.
Yeah. Am I audible?
Hello. Yes, sir.
Yeah, 2 minutes. I'll just. Am I audible?
Yes, sir. Please continue, sir.
And my slides are visible now?
Yes, sir.
So let me thank Vimlakar for a kind invitation. Sorry, I could not be there. I'm in my outstation OP. But I'll take 8 to 10 minutes to tell you a basic thing. What is the role of medical oncologists in the management of pancreatic neuroendocrine tumor, specifically in metastatic pancreatic neuroendocrine tumor? So any similarity between the two? These both patients were suffering from neuroendocrine tumor pancreas. If you remember, Steve Jobs survived for 8 years. our dear Irfan Khan survived for less than 3 years. And that tells you the varied nature of this pancreatic neuroendocrine tumor. Now, when you see a pancreatic mass with a liver mets, if it is adenocarcinoma, your survival is 6 months or around the same. But if you are lucky enough to have a neuroendocrine tumor, majority of the patient, the survival is more than 5 years. And that brings us to the question that histopathology is the most important thing, which tells you in the planning of the treatment. Now, I'll answer a few questions that will be easier for everyone to. The most important thing a medical oncologist see for deciding further treatment when we see the pancreatic neuroendocrine tumor, specifically non-functional. So the most important thing that we see is what is the grade of the tumor. Is it a well-differentiated neuroendocrine tumor or is it a poorly differentiated neuroendocrine carcinoma? Please remember, when you say carcinoma word, it means it is like a small cell cancer with a very high MIB. Now, well differentiated, this is most important for all surgeons. Is it a grade 1 with a MIB of less than 3% or a grade 2, 2 to 20 or grade 3 more than 20? Now, as I will be telling you, in a stage 4 metastatic neuroendocrine tumor, I have to see this before I decide because this gives us a fair idea about what is the best treatment and what will be the outcome. So why is pancreatic neuroendocrine tumor, you have to treat it differently from all the other neuroendocrine tumor, including the gastrointestinal, what we say ileal or a lung. The overall prognosis is bad. So they are more aggressive. They have a worse prognosis as compared to stage by phase as far as gastrointestinal. They are more likely to present with distant mets. This is the most important thing. And for a medical point of view, if I get a patient with pancreatic neuroendocrine tumor, my first inclination is to give chemo earlier. I'll tell you there is different chemo in neuroendocrine as we give it in carcinoma. Here there is a drug called sunitinib which has a greater role. And when we talk about the classical treatment that we give in pancreatic neuroendocrine, that is sandostatin or lenalidomide, they work less. So on day 1, if I see a pancreatic tumor with some sort of a met, I start on an octreotide and I add on one more treatment. That is the gist of today's presentation. How do I decide what drug to be given? Depends upon 3 things. What is the tumor burden? If I see a single pancreatic, a single liver met with a MIB of less than 2, I can very well give a simple sandostatin or may add on something. On the other hand, if I see a liver mets or multiple mets which are there, it is better to add on some agent which works fast. Now, for all purposes, we see Ki67 of less than 2, more than 2. But for pancreas, please remember, you see 10% is what we say as a golden rule, as a thing that I'll tell you that about 10%, the options becomes unlimited. You should not use your molecularly targeted about 10, and you should think of giving the newest form of treatment, which is called as peptide receptor radionucleotide therapy or lutetium-177. And last but not the least, how fast the cancer is progressing. Remember, I told you pancreas are fast growing tumor. So what are the treatment options? So it is like who will win this T20 World Cup? We have 4 options. Somatostatin analog that I told. Second, chemotherapy, equally important. Third, which you have to know about it, is a molecularly targeted therapy. 4 agent, everolimus, sunitinib, cabozantinib, and lenvatinib. And last but not the least, the newest form of treatment, which you have to think of it now in earlier lines in a grade 2 and or 3 temper, is lutetium-177 or a peptide receptor radionucleotide therapy. So what do the guidelines say? On a day 1 tomorrow, a surgeon sees a pancreatic neuroendocrine tumor which has a liver or any other mets. The first step is get a biopsy and get the grade done. Grade 1, grade 2, grade 3 or a carcinoma. Now the step 2 is the Ki67 less than 10 or more than 10. Up to 2 somatostatin, 2 to 8, you have a doubt. More than 10, think of giving a chemo or a lutetium therapy. So these 2 things are very important for you to plan your further management. So in general, chemo to be preferred over oral multi-targeted kinase inhibition in those with a tumor of Ki67 more than 10, a fast-growing tumor, or a tumor with a high tumor burden. So let me start with a scenario. You need to answer me at the end of me what should be the best option. A well-differentiated pancreatic NET in a middle age, in an old age person with an extensive liver mets, not amenable to surgery, no excess of hormones, so a non-functional tumor, but a MIB of 20%. What should be the option, and how should I discuss with the patient? So the first option that I told was a somatostatin LAR, 2 pivotal study. Now see the peculiarity, the response rate is only 2%. So when you think of stabilizing your disease, a patient who is not fit, maybe he may not tolerate chemo or may not, this is a drug which may stabilize but may not give you responses. The important thing is time to treatment progression is around 1 to 1.5 years. So here you have to make the patient understand this disease will get stabilized by this drug. It will not reduce. So you should be patient, and probably this should be preferred in a low burden with a low Ki67 of less than 2%. The second option, chemotherapy. So the gold standard of chemo in neuroendocrine is CAP-10. I repeat, capecitabine and temozolomide. When you see a carcinoma, that is a high grade more than 55, you give carboito. So capecitabine and temozolomide. Now, what is the difference of chemo with pancreatic against other? Pancreatic neuroendocrine response better than non-pancreatic neuroendocrine. So when you think of giving a response to a patient, a high burden disease, some difference or some deterioration in quality, think of giving this simple tablets. So chemotherapy works better in pancreatic NETs than other things. Now the gold standard, simple tablet, capecitabine and temozolomide. See the response rate, 70%, 2% there, a progression-free survival close to 18 months. And if you see the phase 2, this was a randomized study which was published in ESCO, where they give chemo versus capecitabine and temozolomide in pancreatic NET, E2211 study. What this study suggested that in a phase 33% response rate, more importantly, nearly 2 years of progression-free survival, and the overall survival not reached at the end of 4 years. So in my practice, if I see any tumor which is a high burden, I start on standostatin and I add on this CAP-10. Remember, this is a good drug, oral tablet, so you need not have to come to hospital. And impressive responses, impressive progression-free, impressive overall. So for a surgeon, you don't have to think twice. If you see metastatic, put a standostatin and put this on tablet. I have not shown, we have given this in 3 neoadjuvant setting. And Prasad Garu can, and the tumor has regressed and we operated and did a Whipple. So this is something that we are using in a neoadjuvant form also in a grade 2 and grade 3 pancreatic tumor. So better response rate and impressive progression-free survival. My third player is oral tablet which are molecularly targeted. Now, neuroendocrine tumors, why these tablets are given? Because they have an abnormality in this mTOR pathway. They have an abnormality or an overexpression of vascular endothelial factor, and these are the way where these drugs work. So think of this drug, an easier drug again. The first study, Radiant 3, specifically of pancreatic neuroendocrine tumor. See, again, their responses are only 2%. The disease control rate is 81%. So again, when you think of stabilizing your cancer without much expecting a response, this is a go-to drug. For a patient who is far away, you are not worried about, you can't come again and again. This is a good drug. So it stabilizes disease in majority of the patient. Again, a sunitinib drug, the same. The partial response of 9%, stabilization of disease is 68%. So again, an alternative, a chemo or a tablet. So it again stabilizes disease in the majority of the patient. The million-dollar question for anyone, can I give this tablet first and then if they progress, give a chemo? So that was answered by this sequential study called as SECTOR study. These were patients who had already taken a somatostatin analog without any drug, Evero followed by chemo or chemo followed by everolimus. Equal progression-free survival of 23 months, but the most important thing was a 30% response rate when you give chemo versus everolimus had only 11% response rate. So response rate better for chemo than everolimus. So chemo as a first line along with standostatin LAR for achieving a good response for those where you want to take out as a shrinkage as a possibility. And I think so the priority should be what is the comorbidities. A patient who is sick may not be fit for chemo. Safely put him on everolimus, start a standostatin. The patient may do well for few years, definitely. The last, and this is something the take-home message for all the surgeons. Now you should think of giving this lutetium therapy, which is available in majority of the centers in Hyderabad earlier. I'll be telling you the fantastic data that came in the first line. If you are affordable, give actinium, which costs 8 to 10 lakhs a session, which is alpha emitter. But if for India, a poor patient, a lakh a cost for one session, lutetium made in Baba Atomic Center. From Germany, it is 2 to 2.5 lakhs. The basic principle is these somatostatin analog are attached to a radioactive receptor. I put an arrow. They bind to its ligand on cell, get internalized, and this beta emitter, that is lutetium, are released. And so what we call as a targeted therapy. See the fantastic response in median disease control of 83, objective response, the best you can get, 58%, a progression-free survival as close as 3 years, and an overall survival exceeding 5 years. Should I give it in every patient? So that is answered by this phase 3 first line data. So no previous treatment taken, first time de novo in your clinic. Please remember the MIP has to be more than 10%. So our patient had 20%. Give a lutetium along with a octreotide. Something that we are giving is we stabilize octreotide and add on a lutetium given for 4 sessions. Now when you see the response, now see the fantastic. A median PFS of 22.8 months, overall response rate of 43%, disease control rate of close to 90%. So when I give this drug, 9 of the 10 times I'm sure that this drug will work for as long as 2 years. In a dose with a high MIB, you know, if a high proliferation is there, they multiply faster. So giving a lutetium gives you the best response among all the things. Now, does it work in grade 2, grade 3 neuroendocrine tumor? Yes. The data remains impressive. In fact, in grade 2, the PFS is close to 2.5 years. PFS means they don't progress for 3 years just by giving this lutetium. There is a better global health care, the better symptom control. So on any day, if my patient is affordable, has a high, I discuss in first line, see the data people. Most of the patients receive lutetium in the first line now. What I am looking, the last part, 1 minute more. What is I am looking in the future for pancreatic neuroendocrine tumor? So new tablets, some role of immuno, and beyond this group, there are so many things that I could have discussed. The first drug is lenvatinib, a simple drug that we use in lot of cancers. Response rate of 40%. If you see the disease control rate of 88%. So these are very impressive data. A progression-free survival of 14 months, not as good as PRRT, but equally impressive. The advantage is simple tablet, take at home, come in 2 or 3 months for monitoring. And the most important drug, cabozantinib. These, if your patient fails on everolimus, what is the next step? He doesn't want to take this PRRT. So a phase 3 data for those who have pregnancy on the previous TKIs. See again, the progression-free survival of close to 1 year. The response rate of 18% with a very high disease control rate of close to 70 to 80%. Overall survival reaching 4 years. Please remember, these were those patients who progressed and now with this drug are again able to control. So the data is exciting. No talk of oncology will be completed without talking immuno. But unfortunately, immuno doesn't have much role. You need hot tumors and neuroendocrine tumors are not hot. So a basic response of 6%, disease control rate of 58%. But I think so in future, probably with lenvatinib, that will be something. You need to make your tumor hot for immune cell to get stimulated. So immunotherapy, less role, better options are available to us. So coming back to the case, well differentiated with pancreatic with a very high MIB, inoperable. We started our patient on injection octreotide along with lutetium. So far, we have completed 4 doses. It is 1.5 years. The patient has a stabilization of the disease. We do give monthly octreotide and do a chromogranin and 6 monthly gallium scan. Patient is doing well, asymptomatic, and patient is happy. We are happy. So if I have to summarize, what is a medical oncologist's role? 4 drugs I have told you. Multiple systemic therapy options are available to treat the advanced neuroendocrine tumor. 1 SSA, serotonin analog, targeted therapy, Evero, Len, Suni, Cabo, chemo, Captam, and PRRT. Patient disease and treatment goal should influence treatment choice. You should know what you are dealing with. The most important thing is we are not the main person. Surgeons are the main person who will decide. And I always say the best team wins the battle. So it is a multidisciplinary approach. And last but not the least, there are now exciting data about two drugs we should start thinking and should start giving it in your treatment armamentarium. The first is, if you see a high grade more than 10 mg, think of giving lutetium earlier than later. And if the patient has failed the cabinet or cabozantinib, this is a exciting data coming in those who have become refractory. But again, this is just the start. Future studies to identify the efficacy of novel agent. There is CAR data going on, predictors of treatment response and optimal sequencing. This is what we need, because please remember, if you have the maximum survival, you should have to sequence all your drugs well. And I end my talk with my favorite slide from Socrates. The secret of change is to focus all your energy, not on fighting the old, but on building the new. I again thank my dear friend and brother Vimlakar sir for the kind invitation. I back to people. If any question, I'll be happily answer.
Thank you, sir, and thank you for a beautiful talk. We take the discussion further on to cystic neoplasms of pancreas. I invite Dr. Ravi Teja to please elaborate about radiology. Hope sir keeps it crisp and short. Thank you. I also request Vimlakar sir to please come on dais and felicitate Manoj sir. Sorry. Thank you so much, sir. Off to Ravi Teja, sir.
Good evening, everyone. I'm Dr. Ravi Teja. Today, I'm going to discuss about the imaging features of cystic neoplasms of pancreas. The imaging modalities available to us are ultrasound, CT, MRI, PET-CT, ERCP, and endoscopic ultrasonography. Ultrasound is the first line of diagnostic modality, but however, it has low sensitivity and specificity. CT is the main workhorse. It is a robotics technique, gold standard in local staging of pancreatic carcinoma. The main CT protocol includes plain imaging, the arterial phase, which is 25 to 40 seconds, and portal phase at around 60 to 80 seconds. MRI is used mainly as a problem-solving technique, gold standard in evaluation of cystic tumors of the pancreas. Again, the MRI protocol includes the T1 images, the T2 images, and T1 post-contrast images. This is the last image is the MRCP image, which is a highly weighted T2 image showing well delineated pancreatic and biliary ducts, and also show small cystic lesions. The cystic neoplasm represent a wide spectrum of histopathology from purely benign to overtly malignant lesions. Overall, the malignancy is very low. The classification includes pseudocysts, common cystic neoplasms like IPMN, serous cystic neoplasm, mucinous cystic neoplasm, and uncommon cystic neoplasms like SPEN, that is solid pseudopapillary epithelial neoplasms, and sometimes adenocarcinoma and neuroendocrine tumors may show cystic degeneration. The morphology can be either unilocular, oligolocular, multilocular, with either smooth margins with multiple internal septations or lobulated outer margins. The diagnosis of cystic neoplasm should be considered when there is no history of pancreatitis or trauma, in which case the pseudocyst will be the primary diagnosis. The morphological characteristics of cystic neoplasm are thick irregular rim, septations, solid components, dilated pancreatic duct of greater than 3 mm, and calcifications. If fluid is aspirated from a cystic lesion and an amylase level is less than 250 units per liter, it excludes the diagnosis of a pseudocyst. These cystic neoplasms have an age and gender predilection, predominantly occur in women. The SPEN usually occurs in lower reproductive age group. The mucinous cystic lesions usually occur in a perimenopausal age group, and the serous cystic neoplasms usually in later ages. Coming to serous cystic neoplasm, these are usually benign tumors, usually incidentally discovered. They may grow up to larger size, have a tendency to increase in size and cause symptoms. They may be microcystic or macrocystic, but the typical features are microcystic honeycomb cysts with central scar and calcifications, and have a lobulated surface. they have no communication. There is no communication of cyst with the pancreatic duct. This is a CECT image showing a typical image of serous cystic neoplasm with lobulated structure and thin internal septations. And on the right side, show central scar with calcifications. This is a macrocystic type of lesion, serous cystic lesion, showing larger macrocyst with thin internal septations, but has a lobulated surface. These kind of lesions are difficult to differentiate from mucinous neoplasms. However, in this case, it has a thin wall and has a lobulated surface, which clinches the diagnosis of, has a more probable chance of serous lesion. This is a typical case of serous cystic neoplasm, has multiple honeycomb cysts with central scar and calcifications. Coming to mucinous cystic neoplasms, these neoplasms have a malignant potential and see at the median age of 40 to 50 years. They are typically macrocystic with thick wall septations and show peripheral calcifications. They are predominantly seen in the tail. Typically, they are multilocular, macrocystic. Occasionally, they can appear as unilocular cysts. Differentiation from benign and malignant is difficult, but some features show malignant behavior, that is irregular thick wall thickening, mural nodules, papillary projections, and peripheral calcifications. This is a CECT image showing multilocular cystic lesion, non-enhancing with thin enhancing septations seen in the tail of pancreas. This is another case of mucinous cystic neoplasm. It is showing a non-enhancing central unilocular cyst with thick peripheral enhancing fibrous wall. This is one more case of invasive kind of mucinous cystic neoplasm showing macrocystic multilobulated structure with central enhancing nodule, and it is invading into the splenic parenchyma. Coming to IPMN, these can be main duct type or branching type, or sometimes they can be seen as a mixed pattern. These are mucin-producing tumors within the main pancreatic duct or branch duct, predominantly seen in the pancreatic head. These cystic lesions communicate with pancreatic duct, and these are best seen on MRCP. Can be multifocal. Main duct type are usually symptomatic and show low-grade pancreatitis. In cases of malignancy, jaundice can be expected. Branch duct type are usually asymptomatic and incidentally detected. These neoplasms are predominantly seen in the head. The signs of malignancy include pancreatic duct of greater than 8 mm, solid nodule within the duct, mass around the pancreatic duct, enlarged choledochal duct. On the left side, we can see an MRI image showing multiple lobulated T2 hyperintense cysts, which are communicating with the main pancreatic duct, and the main pancreatic duct is dilated. Their corresponding CT image shows dilated main pancreatic duct with central enhancing mural nodules. This is another case of main pancreatic duct IPMN showing a large lesion which is causing compression and communication, and there is dilatation of the pancreatic duct. This is another case showing dilated wavy appearance and lobulated main pancreatic duct, and multiple small grape-like cysts are seen within the pancreatic parenchyma, which is communicating in turn with the side branches and main pancreatic duct. SPEN, this is not very common tumor seen in a younger age group. These are solid and cystic neoplasm and show hemangioma-like enhancement and sometimes intratumor hemorrhage. This is a case of large SPEN showing central hemorrhagic components, peripheral enhancing components, and peripheral calcifications. On the right side, we can see there is a rupture of the cyst with the bleed extending into the retroperitoneal space. Another case of SPEN showing peripheral and enhancing wall and central cystic component. This is one more case of SPEN showing T1 and T2 hyperintense areas with peripheral thick enhancing rim. These lesions are predominantly seen in tail. This table summarizes the features of serous and mucinous neoplasms. Serous neoplasms are benign. Mucinous neoplasms can have malignant potential. Serous neoplasms are usually occur in elderly age group. They are lobulated, microcystic, show central scar with calcifications. Mucinous neoplasms occur in around 40 to 50 years of age. They are macrocystic, can be uni or multilocular, and usually have peripheral calcifications, usually occur in tail and body. IPMN usually doesn't have a gender predilection. These occur in elderly age group. In main duct type, the main pancreatic duct is dilated with protruding papilla of water. In side branch, there are multiple small grape-like cysts with communication to pancreatic duct. Neuroendocrine tumors can be functional or non-functional. These sometimes can show cystic degeneration. This is a case of different adenocarcinoma with peripheral solid enhancing mass and large central cystic component. This is another case of neuroendocrine tumor showing peripheral arterial phase hyperenhancement with central non-enhancing cystic component. So what do we report? Usually we report the presence of a solid mass or absence of a solid mass, presence of enhancing mural nodule with its measurement, width of the pancreatic duct, size of the cyst in largest possible diameter, presence of pancreatitis or absence of pancreatitis. These are the European guidelines for surgical resection. The absolute indications are presence of a solid mass or an enhancing mural nodule of greater than 5 mm, main pancreatic duct of greater than 10 mm, and the cystic lesion of greater than 4 centimeters. These are my references. Thank you. I thank Dr. Vimalakar sir and his team for this opportunity.
Thank you, sir, for a beautiful atlas of pancreatic radiology. I request Vimalakar sir to please give the memento. In the meanwhile, we prepare Amarchand sir's talk on SPEN. Sorry, mucinous cystic neoplasm.
Good evening. I thank Vimalakar for giving this opportunity. Today's topic is mucinous cystic neoplasm. Any patient, female patient more than 40 years of age, single cystic lesion in the tail of pancreas, most commonly it is a mucinous cystic neoplasm. So mostly in 5th decade, body and tail, single cyst with no communication of PD, with the mural nodules and septa, enhancing septa. Most commonly it's a mucinous cystic neoplasm, almost 95% of the time. The malignant potential of MCN depends upon the size and complexity. There are a number of numerous guidelines, Sendai, Fukara, AGA guidelines, international guidelines, and recently the Tokyo guidelines are there. I think you can go to the internet. Mainly decision making is clinical, radiological, and patient factors. There are only 3 investigations: CT, MRI, US. For surgeon point of view, most of the time the CT is done primarily. What the surgeon needs is to see whether there's a parenchymal, mural, or central calcifications, or any pseudocyst with the pancreas, or any vascular involvement is there, or is any recurrence is there, and just see what is the suspicion of any recurrence. You can see the CT scans. For MRI, it is the best investigation because it is a gold standard investigation for the cystic neoplasm. It tells you about the communication of the MPD, septations, mural nodules, any multifocal cyst like an branch type PMN. And for follow-up, is less radiation is there. If suppose you have still doubt up with MRI and CT, then you go for an US. And US is not definitely necessary for all the patients. If you have a doubt, then do it. It is only to see the exact type of cystic neoplasm and for follow-up, and whether differentiate between the mucinous or non-mucinous. And you can do it with an either cyst fluid analysis or a cytology also it can be useful. These are the few of the biomarkers. In case of cystic neoplasm of mucinous, there is an cystic fluid shows an KRAS and GNAS mutation will be there. Because cystic neoplasm has got an ovarian stroma, definitely there will be an ER/PR will be positive. So this is whenever you see an solitary cystic lesion in the tail of the pancreas in 4th and 5th decade, see for the high risk features. If more than 4 centimeters, mural nodules, septations, symptoms, raised C and intestine, most of the times the patient end up in surgery. Suppose if the diagnosis is not still clear, if you done a CT scan, do an MRI. If still MRI is doubtful, then you can do for US. See the cyst fluid analysis. If the mucin is there, then definitely is a mucinous cystic neoplasm. The other DD is that branch type IPMN. Suppose the patient is fit enough and patient can be taken for a surgery. So there are multiple guidelines are there. So some guidelines tells you reset for all the patients of a mucinous cystic neoplasm. But generally, any patient with cystic neoplasm more than 4 centimeters of size with high risk features, operate the patient. For a surgeon, what you need is in a CT scan is either the patient is size of the criteria, whether it needs surgery or just a patient for follow-up, or see the location of tumor, the body and tail, whether you can preserve the spleen or not, whether is any vascular involvement is there or not, what is the extent of resection you want to you can do it, whether the size of the cyst, whether you can do in lab, open or robotic, depends upon the feasibility. This is a case where you can see an cyst with a septa, enhancing septa, and there are also mural nodules in the body and tail of the pancreas. Definitely is an cystic neoplasm, mucinous cystic neoplasm. So we done a laparoscopic distal pancreatic splenectomy. There's other cases there. There's a single cyst on CT scan, but on MRI can show there's some thicken in the capsule, and it shows a mural nodule. And we have done an distal pancreatic splenectomy laparoscopically. This is a small video of the surgical procedure. So this is the MRI, which shows some thickening and mural nodules, but CT scan does not show anything at all. So MRI is the gold standard for an cystic neoplasm of pancreas. Now we enter the lesser sac. Divide the omentum. You follow the Aspen technique. See the lower border of the pancreas, go to the neck of the pancreas, and then see the upper border, and then go to the tail. Now you can see the cyst. Yeah, just there is a small reactionary adhesions are there. Once the lower border is done, we go to the upper border and see the. Then we lift completely the pancreas through and through. Once you lift, you can easily see the splenic artery and vein. This is an Gerardo's fascia. So once you finish the dissection, you can loop it up. Once you loop it up, you turn the pancreas to the upper side. Then you can see the splenic artery. So dissect the splenic artery, loop it up, and clip it and divide it. For a vascular, you can use staplers, but staplers mostly we do only with the pancreatic parenchyma and the vein included. Artery we divide it separately. So this is a splenic artery. So divide the splenic artery, and then you can put an vascular staplers, either white staplers or purple staplers, depends upon the thickness of the pancreas. This is a white cartridge. So do a graded compression, 20 seconds compression, released 20-second compression, and then fire it. At least you'll have a decrease in the amount of hemostasis. You feel that the pancreas is very thin, you can do a vascular staplers white, or you can do a purple staplers. And then do an splenectomy also. So in this picture, you can see there is an involvement of the splenic vein. So that is the reason why you have not done an splenic preserving. The next patient where there's an cystic lesion in the tail of the pancreas. So CT scan is done. It shows only a plain cyst. There is no any septa. And MRI is done, but they have given a report as there is some septations are there. There is some septations are there. We are sent this case for an US because CT scan and MRI is inconclusive. But US problem is that the cyst is a little bit in the lower side, and attempting a cyst during an US, there's a bleeding was there, so they didn't complete the procedure. So option is that the patient is symptomatic, middle-aged, 30 years female. We have planned to do an surgery for her. The diagnosis is according to the CT scan report, it is an either pseudocyst or is mucinous cystic neoplasm, because they are given a report of septa also. So patient is also apprehensive, and there's a middle-aged female, and the only thing is that septa is present, enhancing septa on MRI. So we are given option of surgery. So patient was willing for the surgery, and we opted for splenic preserving distal pancreatectomy. Okay, the cyst is adhesions are removed all around. So in case of diagnosis doubt, always if you don't know the diagnosis, whether it is an mucinous or pseudocyst, because patient does not give a history of any pancreatitis, so it is better always to operate the patient. The stomach is lifted up to have a better exposure of the pancreas. So here again the pancreas is lifted up through and through. Here the splenic artery is separated above, so there is no need of any ligation of the splenic artery. It is well away with the tumor. This is a posterior dissection is done. So there is a splenic vein. You can see the upper border of the pancreas where this separated the splenic artery. So loop the pancreas, put the tape, and then you can here, I think here after staplers, white staplers were used because the pancreas is very thin. By a graded compression, we have divided the pancreas. So when in doubt whether it is an mucinous or pseudocyst, patient does not given history of any pancreatitis, always better to operate the patient. So it is a splenic preserving pancreatectomy. So if there is no invasive tumor, no need of any further surveillance. If there is an invasive tumor, it is clinically behaves like a pancreatic adenocarcinoma. If there is less than 3 cm cyst, asymptomatic, always follow it up. Thank you.
Thank you, sir. Thank you for this crisp talk. Next is a Zoom-based session on SPEN by Dr. Saket sir from AIIMS Patna. In the meanwhile, I request Vimlakar sir and Amar sir to please join the stage for the memento. Saket sir, Saket sir. Can you please unmute yourself, sir? Please unmute yourself, sir.
Hello. Hello.
Sir, you are audible now, and you are
Can you see?
your screen? I cannot see, sir. Can you please share your screen?
Okay.
Presentation, I think you'll have to open.
Yeah. Share screen and
New share.
so I'm getting 3 options: Chrome tab, window, or entire screen.
Entire screen, sir, and you can put your presentation.
1 second.
PowerPoint, sir.
Yeah. Can you see my PowerPoint?
Not yet, sir.
1 second. But I have shared it. Mm,
So below there is an option to share.
yeah, I have clicked that option, new share. It says the entire screen has to be shared. So I have, okay, got it. So is my PPT visible to you?
Yes, sir. Now it's visible, sir.
Okay. And I'm clearly audible?
Yes, sir.
Yeah. So at the outset, I would like to thank my friend Vimlaka for this invitation and opportunity to present this topic, SPEN. So this will be a short talk, and I'll start with a case which we managed a few years back. A 25-year-old lady who presented to us with pain abdomen, upper part, for 2 months, and she also had a feeling of a lump in that area. And when we examined, we found a 10x10 well circumscribed non-tender lump in the upper abdomen. She had an ultrasound report from some other center, which was suggesting a mass arising from the pancreas. So we got all the investigations, including tumor markers like CA99 and CA, but all the investigations were within normal range. Then we got a CT scan abdomen. As you can see in this image, it was a well circumscribed encapsulated mass, heterogeneous area with solid cystic lesions and arising from the body of the pancreas without any significant lymphadenopathy. So based on the typical symptom and typical age of the patient, including the imaging, we came to the conclusion that this patient is suffering with SPEN. So because the tumor was very large, so we decided to do an upfront open surgery. So when the lesser sac was opened, we saw the tumor which was arising from the body of the pancreas. So easily it was not adhered to any structure or was not invading to any other viscera. So easily we could find a plane all around the tumor, and we could loop the proximal and distal part of the pancreas. And then a spleen preserving central pancreatectomy was done. The distal stump was anastomosed to the stomach. PG was done. The patient did well in the post-operative period, and she was discharged on post-operative day 7. So this was the histopathology, which showed solid areas alternating with pseudopapillary formations. And immunohistochemistry was positive for viamentin, progesterone receptors, and beta-catenin. So this is a typical way in which the patient present and they are managed. So coming to some background, this is a rare pancreatic neoplasm which account for less than 2 to 3% of all pancreatic tumors. It mainly affects females in a tune of 2 to 14 times more as compared to men. And the median age or mean age of presentation is young age. Usually the series, according to series, ranging from 25 years to 29 years. Mostly young females, they present with SPEN, and it mainly affects the body and tail of the pancreas. And an interesting observation has been noted in few studies that the younger patient, they tend to have SPEN in the head of the pancreas. Coming to the clinical presentation, with the wide application of imaging modalities, most of the patients are now diagnosed incidentally, and in last few years, the incidence of SPEN has increased dramatically just because of the evolved imaging and wide application of imaging modalities. But when the tumor attains a certain size, like more than 4 centimeter or 5 centimeter, it tend to get symptoms. It tend to produce symptoms, mostly non-specific abdominal pain, abdominal mass, nausea, or uncommonly weight loss. And rarely patient may also present with jaundice or fever. In some instances, patient can have acute presentation because of tumor rupture or because of hemorrhage inside the tumor. And because these tumors are indolent and slow growing, they usually attain a large size at the time of presentation, usually 7 to 8 centimeter when they present first time. So most of these tumors, they are located in the body and tail of the pancreas. 2/3 of tumors, they are in the body tail, whereas 1/3, they affect the head and neck of the pancreas. Whereas in less than 1% of cases, they can exist beyond or away from the pancreas also, mostly in the retroperitoneum, liver, mesentery, or bowel. But that scenario is very rare. Coming to the tumor biology, the exact cellular origin of this tumor remains unclear. It is proposed that it arises from the pluripotent pancreatic cells or genital ridge. And the most common mutation or the diagnostic hallmark is the beta-catenin mutation, whereas KRAS, P53, and DPCA4, which are a marker of adenocarcinoma, they remain unaffected or unaltered in these tumors. Diagnostic modalities have already been discussed by Dr. Ravi. So mainly it is suspected based on the ultrasound because it is most commonly done. And when the suspicion is there, then we confirm it with the CT scan or MRI. US FNA is reserved for some selected cases, and role of PET is evolving. It is still not the part of standard protocol, but there are instances where the PET is used to stage the tumor and also to differentiate between malignant and benign varieties. So coming to the CT images, so it is well encapsulated, mixed solid cystic architecture with areas of hemorrhage or necrosis, and wall may reveal calcification in some cases, and the ductal dilatation is very rare because it lacks invasion. Indication for MRI or MRCP is it provides superior soft tissue characterization, and it detects hemorrhage better, and it also gives a relationship of the tumor with the main pancreatic duct, and it thus helps in the planning of the management. So coming to the differential diagnosis, any cystic neoplasm of the pancreas comes in the differential diagnosis, may it be mucinous cystic neoplasm or serous cystic neoplasm or branch chain IPMN, branch duct IPMN, or cystic pancreatic NET, cyst adenocarcinomas, or sometimes GIST also. So coming to the pathology, grossly they appear tan or yellow in color, well circumscribed, capsulated, and with pseudocystic degeneration. Histologically, we find polygonal epithelial cells arranged in disc cohesive pattern with pseudopapillae formation. IHC is very important to come to the diagnosis. Beta-catenin positivity is the hallmark. These tumors usually have very low mitotic activity and low Ki67 proliferation index because these are slow-growing tumors. And IHC for viamentin, keratin, NSE, CD10, and progesterone are positive. Coming to the management aspect of this pen. So complete surgical resection is the gold standard. Any extended lymphadenectomy is not routinely performed until unless we find enlarged lymph node indicated of metastasis in the CT scan or MRI. Most commonly done procedures are distal pancreatectomy when the tumor is located in the body or tail of the pancreas, pancreaticoduodenectomy where it is located in the head. Central pancreatectomy is feasible in some cases where we can preserve some part of the pancreatic parenchyma. And enucleation where it is away from the main pancreatic duct and it is mostly exophytic type. In those tumors, enucleation can also be tried. Coming to the oncological outcomes, it is a the prognosis is very, very good. Overall survival is in a tune of 98 to 99%. A recurrence rate is, it varies according to series, ranging from 3 to 15%, depending on the duration of the follow-up. Coming to the advanced and recurrent diseases, it is an indolent tumor with 97% 5-year survival. Local invasion or metastasis does not, they do not preclude resection. Metastasis can also be resected. And if there is recurrence, the recurrence can also be resected and it is shown to increase or improve the survival. In those cases where the resection is not feasible or the metastasis is widespread, in those cases, hormonal therapy can be applied because most of these tumors, about 75%, they have progesterone and estrogen receptors. So tamoxifen, if given, reduces the size of the tumor and its burden also. RFA and TACE can be used to address metastasis in the liver in the difficult location, or if the patient is not medically fit to undergo surgery or liver resection. Systemic chemotherapy, the role is very, very limited with very limited evidence. Most of these are in the form of case reports where people have tried giving gemcitabine or cisplatin-based chemotherapy. And radiation therapy is considered for palliative control of the tumor growth. Coming to the prognostic factors, so there are a few poor prognostic factors like incomplete resection, large tumor size, tumor rupture or male sex, positive lymph nodes, and lymphovascular invasion. So if the poor risk factors are there, so you have to follow up these patients for the long term, maybe up to 10 years to detect any recurrence in the early phase. So coming to our experience, in the last 5 years, we have come across 14 cases of SPEN, and all these patients were females with an average age of 24 years. The main or universal symptom was pain abdomen, and lump was felt in 4 patients. The location of tumor was in the head of pancreas in 6 patients, and in 8 patients, it was either in the body or tail of the pancreas. We could do surgery in 13 out of 14 cases. 5 cases were operated by laparoscopy, whereas 8 patients underwent open surgery. Distal pancreatectomy was done in 6 cases. PD was done in 5 cases. Central pancreatectomy was done in 1 case, and enucleation in 1 case. So these are a few publications from our department, and these are open access articles. So those who are interested can go and read our experience, these papers. Thank you.
Thank you, sir. Thank you so much for brief talk on SPEN. To complete the session on cystic neoplasms, I call upon Mattu Srinivas sir to give the talk on IPMN. Thank you.
Thank you.
Good evening. First, I'd like to thank Dr. Vimlakar for inviting me for this meeting. So I've been asked to talk about IPMN and the surgical strategies, particular reference to total pancreatectomy. So I'll go through the introduction very briefly. So we do know that IPMN is basically an abnormal papillary growth of the pancreatic ductal epithelium. These produce mucin, which leads to clogging of these ducts and cyst formation. And then studies have shown that there is a series of mutations which happens over the natural history of these cysts, which leads to dysplasia and then invasive carcinoma. Now, the morphological classification of IPMN is important because it helps us in it dictates treatment. So the commonest is side branch IPMN, branch duct IPMN, which is seen in 80% of all IPMNs. The main duct type is the most important one because that has the highest risk of malignancy. Whereas in patients who have both branch duct and main duct involvement, it's called a mixed type, which could be because the main duct is blocked by the mucin, or it could be because the main duct itself has a neoplastic change. Now, the pathology is important because, again, it guides treatment. So pathology can be based on the degree of dysplasia. So it can be low-grade dysplasia, high-grade dysplasia, or carcinoma in situ, or it can be an invasive carcinoma. There are recent studies which have shown that the type of pathology of these tumors also is important. So it can be gastric, intestinal, or pancreatobiliary, and sequentially the extent of malignancy increases from gastric to pancreatobiliary. Like I said, the importance of this classification is because it tells you whether to intervene or not, and it also tells you what kind of surgery to do. Now, there are controversies in management of IPMN because, first of all, it's not uncommon. And now with more and more patients or healthy individuals having scans, they are likely to be picked up more often. The overall incidence has been supposed to be around 2%, but it's very, very uncommon in younger patients, whereas in patients over 60 years of age, it can be up to 2 to 3%. Again, these tumors, like I said, most of them are branch duct type, and the series of progression varies. So some of them can progress quickly, some of them might be quite indolent. The third important thing is obviously that they're all in elderly patients. So you have a 60-year-old or a 70-year-old with what looks like a branch duct IPMN. And the question is it something that you would like to operate on for a potential risk of malignancy as against the risk of surgery itself? So it's a difficult balance between fear of missing out on a tumor as compared to over-treating these lesions. And there have been many guidelines. In fact, it said that there have been more guidelines than actual evidence for IPMN management. And while the IEP guidelines have been a bit more aggressive in terms of treating these lesions, the American guidelines have been more selective in terms of offering surgery. So if you there have been studies which have compared the outcomes in patients who are treated along the American guidelines and the European guidelines, and the studies show that there is a 7 to 10% chance that you would miss a malignancy if you follow the American guidelines. Now, is 7% important? It might be important for a 40-year-old or a 50-year-old patient, but it's probably not so relevant for a 70-year-old patient. And these tumors are mainly seen in the 60s to 70-year-old patients. So they're not like mucinous cystic neoplasms or SPENs, which are in a much younger patients where you have a long follow-up for these patients. So treatment should not be based just on the tumor itself, but also based on the patient itself. Now, this is the latest guidelines, Kyoto guidelines, which were published last year. So some of my recommendations are based on these guidelines. Now, there are two different types of risk factors that are used to determine treatment for IPMNs. There's something called the high-risk stigmata, and you have the worrisome features. So the high-risk stigmata, there are 4 of them, and you can see if any of these 4 are present, then surgery is indicated, because these patients have a high risk of invasive malignancy or high-grade dysplasia or carcinoma in situ. In fact, studies have shown that 20 to 30% of these patients will have an invasive malignancy. Now, the worrisome features can be clinical or imaging. What these tell us is that there's an increased risk, but they do not directly mandate surgery. But these factors mean that these patients need to be observed more carefully. You need to have a more closer surveillance. Now, the important thing to note here is that the risk is additive, which means if you have 2 worrisome features, the risk is much higher than having a single worrisome feature. Similarly, if you have 3 worrisome features, that's more than 2. So the number of these features, as they increase, the risk increases. So that your tendency to go for surgery would be more. Similarly, in patients who do not have any of these features, when they are on surveillance, the recommendation, I won't go into detailed surveillance because it's going to take a long time, but the recommendation is that if there is any change in these features, then that would be an indication of surgery. The third is that these patients have a baseline risk. So if the patient has a family member who's already had pancreatic cancer, the risk of developing a cancer in IPM in these patients is higher. So again, that also has to be taken into account when you decide about the treatment options for these patients. Now, in terms of what kind of surgery to do, the most common surgery that's done is a partial pancreatectomy. That can be a Whipple's procedure for a lesion in the head or neck of pancreas, or it can be a distal pancreatectomy for tumors in the body or tail of pancreas. There are more and more reports of using central pancreatectomy as a parenchymal preserving surgery in patients who have tumors in the body of the pancreas. Now, if you have patients who have high-grade dysplasia or actually invasive carcinoma, then you would want to do a standard pancreatectomy with a lymphadenectomy. And the protocol is that we should do intraoperative frozen sections to make sure that we are not missing out any high-grade dysplastic lesions in the remnant pancreas, because if that is there, then you need to extend the resection further so that we get clear margins. Now, the point here is that everything does not need to be resected. So if your margin shows low-grade dysplasia, then they can still be managed with follow-up because the risk of malignancy is still low. Now, what is the indication for total pancreatectomy? So what is the clear indications would be a patient who's got a diffuse main duct IPM, an IPM with a main duct which is 10 to 12 millimeters all along the pancreas with multiple nodules. That is a different indication for total pancreatectomy. Or if you have multiple branch duct IPMNs with high risk factors across the pancreas, again, that's an indication for total pancreatectomy. Or if you have extensive areas of high-grade dysplasia, again, that is an indication. But there are some soft features also. So if you have a young patient who's got several high-risk factors, you would probably want to do a total pancreatectomy for them so that, or if they have a family history of pancreatic cancer, then probably doing a total pancreatectomy might be better for these patients to ease the post-operative surveillance. Again, patients where, who are already diabetic, where probably the additional risk of diabetes is not that significant, that might be something that, we might want to consider. But again, what we need to balance with that is that total pancreatectomy is an easy operation technically, but it's a very difficult surgery in terms of post-operative management. These patients can have very high swings in metabolic parameters in the post-operative period. In fact, I remember many years ago, we did a total pancreatectomy and the patient had very difficult to manage blood sugars, had severe lactic acidosis, and actually patient didn't make it. So total pancreatectomy is not a straightforward operation. It's not just a bigger partial pancreatectomy. It actually comes with a package of a lot of metabolic derangements in the postoperative period. Obviously, these patients will have brittle diabetes, which means they'll have both very high blood sugars, they can have very low blood sugars, and that makes it very difficult to manage these patients in the postoperative period and in the long term. And obviously, there is the problem with exocrine dysfunction and malnutrition in patients who have total pancreatectomy. So the role of total pancreatectomy is very limited in these patients and needs to be assessed very carefully, not just based on the disease itself, but also based on the patient factors. This is just to look at the frequency of surgeries that are done for IPMN. And this is a paper from North America published last year. And as you can see, total pancreatectomy was used only in 4.4% of patients. That's less than 5% of patients who underwent surgery for IPMN actually underwent total pancreatectomy. And most of them were managed with a PD or a distal pancreatectomy. So, I mean, in terms of when you have a patient who's going to surgery for IPMN, what you need to understand is that your operative procedure might vary based on what you find on table. So, because you're going to send these frozen sections, you might start off with the distal pancreatectomy. You might actually do a more extensive distal pancreatectomy than expected, or you might, if you start off with the Whipples, and then you might have to do a total pancreatectomy. So the patient needs to be aware that first of all, the final surgical procedure will have to be decided on table. They also need to understand that it might not completely cure. So we might leave areas of low-grade dysplasia behind, which means these patients need to be on lifelong surveillance, because that is important to pick up new lesions. And that, you know, the resection might need a total pancreatectomy with its associated metabolic derangements and complications. Just a little note that, you know, these patients need lifelong surveillance once they have a cancer in IPMN after on surgery, because these patients have a 10% incidence of recurrent lesions, and more interestingly, these patients are also at a higher risk for extra pancreatic tumors. Near 20% of patients who have an IPMN resected have been found to have extra pancreatic tumors. So these patients do need long-term surveillance to pick up these tumors and treat them at an early stage. So I'll finish. Surgery is indicated for patients with high-grade dysplasia, carcinoma in situ, or invasive cancer, or patients who actually progress even though they don't have high-risk features on surveillance. The type of surgery not only depends on the extent of disease, but also on patient factors. Total pancreatectomy is very rarely performed. It's only about 5% in a large database. And these patients, even after resection, would need long-term surveillance, not just for recurrence in the remnant pancreas, but also for extra pancreatic tumors. Thank you.
Thank you so much, sir, for this talk on IPMN. I would also request you to please moderate us through the last session on pancreatic transplant. We have the next session by Namesh Mehta, sir, who will talk about total pancreatectomy in the present era. In the meanwhile, we'll have the small felicitation of Srinivas, sir, at the moment. Namesh, sir? Namesh, sir, are you available? So.
Yeah. Are you able to see my screen? I'm just trying to get my screen.
Yes, sir, we are able to see you, but we are yet to see
Oh,
you.
I'm not able to see my screen. Now there it is. Now it has come up.
Yes, sir. Mr. Srinivas sir is here, sir, who will be moderating us through the session on pancreatic transplant.
Yeah. Not working. Are you able to see that? No. Are you able to see the slides?
Yes, Dr. Namesh.
Yeah. Hi, Metu. How are you?
I'm good, good. How are you?
I'm good. I'm good. So, first of all, thanks, Vimlakar, for providing this opportunity to speak to you. Again, greetings from Jaipur. Total pancreatectomy, a bit has already been touched upon by my previous speaker, but if you look at the history, it was initially performed for pancreatic adenocarcinoma way back in 1943 and 44. And in both these patients, obviously the outcome wasn't very successful. So in today's scenario, the indications of pancreatectomy probably are still smaller, but we need to revisit them, understand them, and then proceed with it. So there are some benign cases where you may think of doing a total pancreatectomy, like chronic or a recurrent acute pancreatitis. This is only after you have exhausted all the other options. Some of the cases of hereditary pancreatitis may also qualify for total pancreatectomy, but again, you need to weigh them in comparison to the morbidity which you will be giving by doing a total pancreatectomy. The pre-malignant conditions, I think Dr. Metto has already spoken to you about IPMN. So if it is a high stigmata disease and if it is probably multifocal or diffuse, and only in those cases we reserve total pancreatectomy. Otherwise, you go ahead with doing only a partial pancreatic or duodenectomy. In hereditary or a familial pancreatic cancer or high-risk syndrome, again, a prophylactic total pancreatectomy may be considered again after a prolonged discussion with the patient and the family. The tumors in which you may go ahead and do a total pancreatectomy is PDAC, that is pancreatic ductal adenocarcinoma, neuroendocrine tumors, ampullary or periampullary cancers, if they are widespread, synchronous metastasis, and a completion pancreatectomy if the margins are positive or you develop complications after a Whipple's procedure. So what are the contraindications? There are some absolute contraindications. If there are distant metastasis or a locally unresectable disease, then obviously a TP should not be considered. Severe comorbidities or a poor performance status, again, in these patients, total pancreatectomy is not justifiable. Presence of portal hypertension and portal vein thrombosis will make the surgery much more difficult, increase the risk of morbidity and mortality. And if the patient has got cirrhosis or even fibrosis or steatohepatitis, these patients are unlikely to tolerate a total pancreatectomy. There are certain relative contraindications like pre-existing diabetes or a brittle diabetes already pre-existing, a prior LPJ done or a venous bypass operation has been done, or there is a severe visceral hyperalgesia or psychosocial maladaptation. In these cases, performing a TP may be actually detrimental. So a careful selection in a multidisciplinary team setting is very much crucial. Patient should be ready to commit to a lifelong situation of insulin dependence and injections, and also to replace the exocrine function of pancreas. They need to continue taking enzyme replacement therapy. So in chronic or recurrent acute pancreatitis, this patient should be considered only if their pain is disabling, if it has not responded to all the other modalities of pain management. In cases of hereditary or genetic pancreatitis and familial cancer syndrome, this is reserved for in those patients who have got diffuse pre-malignant changes. Only then a TP should be considered. Most of the time, total pancreatectomy is always associated with an adjunct surgery is islet autotransplantation, especially in the benign disease, because you will be able to inject the beta cells back in and they may reduce the brittle diabetes, though that the insulin requirement will still be there, but it may reduce the fluctuations in the glucose level. So the indications have expanded with better perioperative support and pain management algorithms. IPMN, I think it's already been spoken at length in the previous lecture, but I would just like to mention that only if the lesion is diffuse or if the lesion is multifocal IPMN, only in those cases total pancreatectomy has some role. Otherwise, doing only a pancreatic or duodenectomy is usually sufficient enough to tackle them. And you also need to follow them up regularly to rule out. If you have done a partial pancreatectomy, you need to follow them up to check if the remnant is clear. And on the follow-up period, if you do find that there is a doubtful pre-malignant or a malignant lesion which has developed, obviously your treatment will be justified, surgical indication will be justified based on that. Coming to the malignant reasons for total pancreatectomy, in pancreatic ductal adenocarcinoma, again, it is reserved for locally advanced, where the margin, you have not been able to get a good negative margin on the pancreas, and you keep on removing it. And so practically or technically, this is a diffuse tumor. Specifically, even after a neoadjuvant therapy has already been tried and it still remains locally advanced, in these cases, total pancreatectomy is probably helpful, but again, there is with an increased risk of morbidity and mortality. In neuroendocrine and ampullary or periampullary tumors, again, it is reserved only for those patients who have a multifocal or a diffuse involvement, where a partial resection is not justifiable. In cases with synchronous metastasis with isolated pancreatic involvement, this is an indication which really needs to be put in the MDT, and only in highly selected patients you may go ahead and do a total pancreatectomy. Doing a TP in a high risk individual, again, needs to be considered. It is controversial and it needs a significant amount of counseling and a clearance from the MDT before proceeding for a total pancreatectomy. So the operative steps, I think most of my surgical colleagues would know that. It includes exploration and mobilization initially, followed by vascular control, which is very, very important. You need to take control of the SMV and the portal vein before you actually start immobilizing the pancreas, and thereby to reduce the chances of intraoperative hemorrhage. Once the resection has been performed, reconstruction is usually done with a hepaticojejunostomy and followed by a gastrojejunostomy. So the surgical complexity here, again, if there is an associated vascular resection to be performed with total pancreatectomy, in these cases, the morbidity will increase significantly. If there is an associated viscera which needs to be resected, again, here, this would indicate an aggressive tumor biology, and in these cases, the outcome may be poorer, and then you again need to revisit whether you need to go ahead with a total pancreatectomy or you need to just subject them to a palliative chemotherapy. If you are doing a total pancreatectomy in association with either the multivisceral resection or a vascular, both these cases would increase the operative time and the perioperative morbidity and mortality as well. Now, with the advent of insulin pump technology, most of these patients have got a better recovery and better management of the HbA1c levels, and they are able to have a better long-term metabolic control. Just a few words about minimally invasive approach. Now, a lot of people have already been using minimally invasive approach of lap and robotic total pancreatectomy. This allows a better R-block resection with precise dissection because of the dexterity, specifically in the robot, with a reduced blood loss, lesser hospital stay, and the same oncological outcome. So the morbidity which was there in an open pancreatectomy has reduced significantly with the advent of minimally invasive approaches. Now, again, total pancreatectomy, which is added with an islet cell autotransplantation, mainly reserved for the benign cases or a chronic pancreatitis or a recurrent acute pancreatitis. In these cases, islet cells are isolated and then infused into the liver, thereby allowing the glycemic control comparatively better than without islet cell autotransplantation. There are some groups which have performed a duodenum preserving and a spleen preserving total pancreatectomy, but again, that is only in a select group of patients, which requires a good multidisciplinary team discussion before you offer them a duodenum preserving or a spleen preserving total pancreatectomy. Coming to the complications, again, the early complication rate is significantly higher, but 1/3 of the patients are likely to develop some form of major morbidity, which is bleeding, sepsis, delayed gastric emptying, gastroparesis, and gastric venous congestion. And the 90-day mortality still remains at between 3 to 7%, with a readmission rate as high as 17%. The long-term sequelae is dependent on the exocrine and the endocrine insufficiency, because of which the patients may develop steatorrhea and malnutrition. And because of insulin insufficiency, they will definitely develop brittle diabetes and the fluctuating level of glucose, which can increase the risk of hypoglycemia and thereby which can prove fatal as well. There can be metabolic complications like osteoporosis and hepatic steatosis as well post a total pancreatectomy. There are various studies, and some which have been included in these references, where they have performed a total pancreatectomy with a median survival. Some have given a survival of 5 years of 12%, but the benign disease, if it is performed in an appropriate indication, they have a higher 1 year, 3 year, and 5 years survival, which is 84, 82, and about roughly 80%. Minimally invasive approach, as we discussed, reduces the major morbidity and the hospital stay, thereby improving the outcomes. So the quality of life, again, various studies have already been done on the quality of life after total pancreatectomy, where it shows that there is significant decline in the physical and the emotional roles. However, there is some bit of a negative impact and multiple domains. The patients may have a lot of future worries about travel. They may be dependent on others who need to be aware. The family needs to be aware about total pancreatectomy can lead to a significant changes in the glycemic control. And that is where their independent travel for these patients may be hampered. They can also have moderate to severe symptoms of altered bowel habits and satisfaction with healthcare. Most of these patients will require a minimum of 3 months or more to adapt to their new glycemic levels, to understand the levels of insulin required. They will also need a longer time to regain their nutrition. And in some of these cases, the psychological impact is significantly higher. So the risk factors which can affect the survival after a total pancreatectomy is a higher blood glucose fasting level of more than 155, the albumin, pre-albumin level much low, and obviously if they develop a significant Clevin-Dindo grade 3 or more complications in the immediate post-op period, they will have a higher risk of higher chances of mortality post total pancreatectomy. The recurrence-free survival usually worsens if the preoperative fasting blood sugar was more than 110, or if these patients have got venous invasion, and if their postoperative HbA1c levels continues to stay more than 7%. So the overall survival in this study, which was published, declined with a higher postoperative HbA1c level of more than 7 and the albumin level of less than 3.5. And the survival curves showed a poorer recurrence-free and overall survival in those patients with HbA1c of more than 7. Some of the special scenarios where you end up doing an emergency total pancreatectomy, again, this will have a higher complication rate and a poorer 5-year survival. A primary total pancreatectomy with a subtotal islet cell autotransplantation is likely to have a better metabolic outcome, with 1/3 of these patients losing out the insulin dependence, and they'll become insulin independent. And 2/3 of these patients will try to develop a partial graft function and will try to maintain a mean HbA1c level between 6.1 to ±1. So 2-stage completion TP is also reserved for those patients in whom previous pancreatic resection and the complications were much higher. But again, doing it in two stages will increase the morbidity and delay your recovery timeline. thereby again increasing the risk of morbidity and mortality in these post-op centers. So total pancreatectomy should be done in a carefully selected patients and in high volume center which are clearly used to managing these type of patients. In a major consensus meeting done and which is eventually published, where 22 centers had participated, some guidelines and key recommendations had come out, where the total pancreatectomy was reserved for select patients after multidisciplinary evaluation. In IPMN setting, only those patients were subjected to total pancreatectomy if they have a high risk stigmata, and minimally invasive TP would reduce the morbidity and mortality. And the Delphi consensus suggested that a structured training is required in terms of patient selection, and there's definite area of need for research in minimally invasive pancreatic surgery for total pancreatectomy. Use of insulin is again a need in these patients who have undergone total pancreatectomy to maintain their glycemic control. And there are various newer modalities are coming in which will help regularly monitor the blood glucose level with a closed loop system, thereby reducing the chances of hypoglycemia. And the advent of PERT therapy to address the exocrine insufficiency. Probably there is some change in the post-operative management and in terms of recovery in these patients who undergo a total pancreatectomy. So there are various studies which has published. Most of these have got a very good 5-year survival. Most of them have been performed in, as I said, benign indications with a good 5-year survival. And most important criteria rather than survival in these patients is, are they able to develop an insulin independence, which is seen in about 1/3 of the patients, and the decline in the use of the narcotics because of the pain. So in many series, the decline has happened in about 70 to 80% of these patients, where their daily use of analgesic or narcotic has reduced significantly. One of the another paper which was recently published again on the evaluation over last 2 decades of these patients, where they analyzed what was the long-term outcome and the requirement of narcotics and endocrine function. So at 5 years, there were about 73% patients who were independent of narcotics, and 3/4 at the end of 10 years, with a long-term survival of 62%, which is significantly nice and good. And an endocrine function, if you look at them, the insulin independence in the initial 5 years was seen in about 1/4 of the population. Over the subsequent 5 years periods, that is at the end of 10 years, it reduced to only about 10% of the 10 to 11% of the individual who are actually insulin independent. Rest of them required significant monitoring of their glucose level and insulin infusion to maintain their HbA1c level. Quality of life compared to their baseline, again 80 to 85% continued to have a better quality of life even at the end of 10 years after total pancreatectomy. So the global benchmark published based on the expert consensus, which was published in the British Journal of Surgery last year, where the 6-month mortality has to be less than about 6.8%, major morbidity less than 44%. Patients should not be having delayed gastric emptying, again, more than 40% of these cases. Reduced risk of post-operative hemorrhage to less than 26%. And most of these patients had an intra-hospital stay of about 18 days. Significant lifestyle changes need to be followed after undergoing a total pancreatectomy, which includes a high protein and a moderate carbohydrate with a low fat diet and frequent small meals, which definitely includes enzyme supplementation, avoiding alcohol and tobacco, and continue regular exercises to maintain.
Please conclude the session, sir.
Sure. So there's nothing much. Just to come to the summary, Total pancreatectomy remains a rare but an essential option for diffuse pancreatic disease and select malignancies. Meticulous patient selection and multidisciplinary care, and specifically performed in high volume center, will reduce the morbidity and mortality. Minimally invasive techniques have now rapidly evolved, thereby reducing the chances of morbidity. Islet cell transplantation is definitely improving our quality of life in these patients. However, future research should focus on personalized therapy, early detection of high-risk lesion, and integration of immunotherapy with neoadjuvant strategies with surgical innovation. With that, I would like to invite all of you for the annual IHPBA meeting happening in Jaipur in 2026. The registration is still open, and we do have a lot of workshops scheduled for this. You may disseminate this information amongst your students who wish to join for any of these workshops. Registration is open for the same. Thank you very much.
Thank you so much, sir. We look forward to meet you at Jaipur. Extremely sorry that I had to ask you to sum up because we
No, that's absolutely fine. Don't worry. I understand you are running late and behind the schedule. So
thank you so much, sir.
Good luck.
Anyone, sir? We'll go to the next session. Suresh Raghavaya, sir, will talk about pancreatic transplant, which will be followed by Rohit Dama sir's talk, who will conclude the session for today with islet cell transplantation. Thank you. Suresh, sir, over.
Good evening, everyone. I hope you can see the screen. Hello? Am I audible?
Hello?
Hello?
Yes, sir. You're audible, sir. Please continue.
Yeah, hi. Good evening, everyone. So today, and thank you, Team Imlaka, for this opportunity. Just like this talk, a pancreas transplant is absolutely the last thing we need to be considering for treatment of any diabetic-related complications. Because right now the insulin therapy has really become so nice, and you have the sophisticated machinery available to actually manage sugars, and the pancreas transplant is absolutely the last thing we should be considering. But having said that, it definitely has a place in order to increase not only the quality of life of the patient, but also the quantity of life. And Dr. Naimish was just talking about how a total pancreatectomy really screws up the patient's life, quality of life. And I think a pancreas transplant can definitely come to a rescue in such patients. So I have no disclosures related to the presentation, and I have used a few images, but I've taken explicit consent from the patient to actually use these images. So just a regular case scenario, a 32-year-old female patient who has a known case of diabetes for 20 years, what we call as type 1 diabetes or insulin deficiency diabetes. Now, as a result of her diabetes, she develops kidney failure and ends up being on dialysis for 4 years. So she has come to us for transplant evaluation. So what are the options we have? So most doctors right now, most surgeons or most teams in India right now would counsel them for a kidney transplant only. Okay, because it's a living donor. They usually come to us with a living donor because the patient is relatively young. Either the mother or father comes forward to donate. But we are going to look at why this patient would benefit with the pancreas transplant. So if at all you look at these curves, so the topmost curve is the long-term survival of the kidney allograft with patients without diabetes. So let's say they've had FSGS, they've had a UTI or any other septic reasons for kidney failure, and you can look at the kidney, more than 90% of the kidneys survive for more than 14 years of life. Whereas if the patient is a diabetic and you give them a kidney transplant alone, what happens over here? So if there is a living donor kidney, in about 60% of the kidneys survive till about 14 years. Whereas if you give them a cadaveric kidney, almost 50% have already failed within about 14 years. Now, why is there such a difference between a living donor and a cadaveric kidney? Because living donors, we opt for really healthy donors, whereas cadavers, we also end up taking marginal donors, and that is why if you look at the long-term survival of the cadaveric kidney allograft really is not that great. But now what happens if you add on a pancreas for these patients? You can look at that the long-term survival of the kidney allograft really matches that of those with non-diabetic renal disease. Now, what these two asterisk marks mean over here? It means that these statistical significance is not met. Meaning, what have you done over here? You converted a diabetic patient into a non-diabetic patient with a pancreas transplant. And so what happens? All the diabetic related renal damage which happens to the kidney allograft is mitigated. And that is why the longevity of the kidney allograft really doubles. And we should be comparing a cadaveric kidney with a cadaveric SPK, because most SPKs, or rather all SPKs, are from cadaveric donors. Now, once the kidney survives for such a long time, it has a direct effect on the longevity of the patient as well. So if you look at patient survival in type 1 diabetics, obviously dialysis patients do extremely poorly, whereas if you get a cadaveric kidney or a deceased donor kidney, you do have a survival advantage. A living donor kidney transplant does offer a good survival advantage for these patients, but the maximum survival advantage or the longevity survival is actually from the simultaneous pancreas kidney patients. Now, why does this happen? Because once you give them a successful pancreas transplant, the number of diabetic complications which the patient would have developed during their lifetime usually arrest, and in some cases reverse as well. And that's why they get a huge survival advantage. Now, what are the types of pancreas transplants we can do? There are three types of pancreas transplants described. One is a simultaneous pancreas and kidney transplant, which is by far the most common pancreas transplant done, mostly for type 1 diabetic patients, young patients who come with kidney failure. So you work them up, a single cadaveric donor, you do both the kidney and pancreas transplant at the same time. They do extremely well. Now, your pancreas after kidney transplant, this is chosen in some patients who have a living donor for the kidney and who do not want to be on dialysis. So for them, what would happen? We would do the living donor kidney transplant, and once that has been successful in about 3 months' time, we follow it up with the cadaveric pancreas, and this helps them a lot. And very rarely we do a pancreas transplant alone, and this is for diabetic patients who have non-renal complications of diabetes. So it could be potentially a software engineer or a driver who's having vision-threatening retinopathy, or who's had 2 or 3 life-threatening diabetic ketoacidosis episodes and requiring hospitalization. So anybody, or infertility, for that matter, even diabetic infertility becomes an indication for pancreas transplant. So now when we come to the operation per se, we retrieve the pancreas with the C-loop of the duodenum with the stapled ends of the large and small bowel mesentery. The vascular pedicle is from the superior mesenteric artery and the splenic artery, and the outflow is to the portal venous stump. We kind of bench and we implant, which I'll share a video with you. So this is exactly what a retrieved pancreas looks like. So those are the stapled end of the duodenum and the gastric we saw over there. This is the stapled end of the small bowel mesentery, and that's the stapled end of the large bowel mesentery. Now, if you turn it around, you see the superior mesenteric artery stump over there. You see the splenic artery stump over there, which has been tagged. You see the ligated common bile duct, and you can see the portal vein stump, which has been divided. Now, the first step we do is a splenectomy. We tie all the splenic vessels, double tie the artery and remove the spleen. Then we shorten the C-loop of the duodenum, because we always get a lot of intestine to be on the safer side. On the benching, what do? We shorten the C-loop of the duodenum. And I always bury the staple line. Now, although many people say that if you're using a triple line stapler, you really don't need to bury. But it's just my practice to kind of bury the ends of the staple line. Then we go ahead and transfix the ends of the mesentery as well, because the superior mesenteric artery is there, and which we have cut short distally, and that always bleeds. Now, this is the Y graft. It is basically the common iliac artery, the internal iliac artery, and the external iliac artery, which we retrieve from the cadaver. Now we go ahead and anastomose to the arterial stump. So I generally do the internal iliac artery stump to the splenic artery, and the external iliac artery stump to the superior mesenteric artery. So we put in, we make sure everything is okay. We test our anastomosis. You can see that there's no bleeding. Now, when it comes to the patient, we generally do a midline laparotomy. Then we do a very generous cattle brush maneuver. until we expose the common iliac artery and the lower end of the inferior vena cava. Now, why do we do this? It's a diabetic patient, so their arteries are always atherosclerotic. And for the venous drainage, I generally put it onto the lower end of the vena cava as seen over here. So once that exposure is done, we get the allograft into place, we size up the portal vein, put a side biting clamp onto the vena cava and make sure we do the cavotomy. Now the cavotomy should neither be too narrow or too wide. If it is too narrow, you will end up with portal vein stenosis, outflow obstruction. Whereas if you do it too wide, the portal vein gets stretched and it will also cause an obstruction. Once the venotomy and vena cava anastomosis is done, we do an iototomy onto a supple area of the common iliac artery. We cut short the Y of the Y graft stem and we anastomose the artery. So once that is done, we release the portal vein. Irrespective of how well you think you've done the benching, there will always be bleeding process. And then once we make sure the anastomosis is not bleeding, we revascularize the pancreas and you can see that the pancreas immediately pinks up. You again get a lot of hemostasis. Hemostasis is very, very paramount over here. Why? Because we are going to anticoagulate this patient post-op. So you can see that the pancreas exocrine secretions have started to fill up already. So we do a duodenotomy onto the C loop of the duodenum, get nice hemostasis, because I've had one of my patients actually bleed from this anastomosis. So again, check for hemostasis, make sure it is totally dry. Then take a loop of jejunum, which falls naturally onto the duodenum, and go ahead and complete a double layered anastomosis. So you can see that the anastomosis posterior layer is being done over here. Then we do the anastomosis over here, and that's the anterior layer being completed over there. And we go and close it up with a double layer, nice anastomosis. Normally, initially I used to do a rule loop, but with experience, we just do a regular continuity loop. Then we put in a nice drain and close the patient, and that generally ends the pancreas transplant operation. Now, why is it not offered to everybody? Because it comes with a lot of risk. The most important risk is graft thrombosis. Now, why does this happen? Because in situ, the portal vein is a high flow vessel because the entire mesenteric circulation is flowing through the portal vein. But once you take out the pancreas allograft, the entire mesenteric circulation is gone. So you have a large bore vessel carrying very less blood, and that puts the patient at risk for portal vein thrombosis. Now, how do we mitigate that? We actually therapeutically anticoagulate the patient immediate post-op, and that leads to hemorrhage. And pancreatitis, wound infections, pancreatic abscesses, duodenal stump leakages, all of these are part and parcel of pancreas transplant. And also the patient is going to be on immunosuppression lifelong, which will obviously lead to some infections. But we have done well so far. This is my personal experience. I've done about 60 pancreas transplants, 25 in India, including 24 simultaneous pancreas and kidney transplants, and Karnataka's first pancreas after kidney transplant. I've had my share of complications, the most common being laparotomy and lavage for duodenal stump leaks and pancreatic abscesses. We've had 2 portal vein thrombosis, one which necessitated removal of the pancreas allograft and one which was salvaged purely by anticoagulation. We've had 1 anastomotic bleed from the duodenojejunectomy which needed angioembolization. 1 patient developed renal failure due to recurrent FSGS 1 year after transplant, but the pancreas continues to do well. Now, 1 patient died of severe allograft pancreatitis and MDR Klebsiella, which was donor derived. And unfortunately, even the liver recipient and the other kidney recipient also died because of the same thing. COVID kind of was bad, where 2 patients have died because of severe COVID, and 1 had a massive pulmonary embolism 2 years after transplant. She was a vasculopath, and she survived 2 years. But they do extremely well. So this was my first patient, Shekhar Milani, in the center over there. And this photo is 2 years later. So you can see that the nutritional status really improves of the patients. They do extremely well because whatever was not, they could not eat before transplant, they go ahead and eat right now. Got a little bit of press for that. And this is all of them right now. This is Mahjabeen, who's a dentist. This is Hyaji, who is a Japanese translator. Praveen, who's a chemical engineer. And this patient is 8 years post-transplant. Mahjabeen, 8 years, where she's insulin-free right now. And this is one of my favorite photo. Again, this is you can see the difference in this photo is hardly 6 to 8 months. And you can see that the nutritional status of both the patient and doctor improved. But this is my favorite photo. So even people who do not know what she's eating, this is Death by Chocolate in Corner House. This is the last thing you find on the menu, which is chocolate cake, chocolate ice cream, and chocolate syrup. And if you have a successful pancreas transplant, a type 1 diabetic patient would actually be able to eat this without, being worried about her sugars. And she also ended up being India's first patient to give birth after a dual organ transplant. And this was our first pancreas after kidney patient. She was an international patient. We did an ABO incompatible kidney transplant where the mother donated the kidney. And 6 months after the ABO incompatible kidney transplants, once the kidney was doing well, we went ahead and did the pancreas after kidney transplant and this one. So this is my lovely team, which makes it all possible. And so in summary, I think all diabetic patients, especially type 1 diabetic patients with complications, should be considered for a pancreas transplant, especially diabetic renal failure patients for a simultaneous kidney pancreas patient, for a simultaneous pancreas and kidney transplant, because they do extremely well, not only in terms of longevity of the kidney graft, but the quality of life which the patient affords is really, really good. And I would like to sign off by saying that, all of these transplants would not be possible if at all it was not for organ donors. I would really request all of you to please sign up to be an organ donor, please. Thank you, and I'll be very happy to take any questions.
Thank you, Dr. Suresh. This is Srinivas, Mittu.
Hi, Mittu. Good evening. Nice to talk to you.
Excellent talk as always.
Thank you so much.
Just one wanted your opinion on. I mean, there is now a trend. I mean, I'm a firm believer in pancreas transplant in some in a diabetic who needs kidney transplant. I think it really changes their quality of life.
Yes.
What is your opinion on the usage of SPK for type 2 diabetes with kidney failure? I know
So absolutely worthwhile procedure. So in the US, actually, if you look at the long-term functioning between type 1 and type 2 diabetes, there is absolutely no difference between type 1 and type 2 diabetes if you look at the outcomes of the insulin-free survival per se. But the problem with type 2s is they are kind of morbid patients, in the sense they have insulin resistance, first of all. So what happens is they are a bigger vasculopathes than the type 1s. Type 1s, you're catching them early. Whereas type 2 people are a little bit obese, their arteries are atherosclerotic, and they have a lot of comorbidities usually. Peripheral vascular disease will be there, the heart will not be too good, So now the thing with pancreas transplants is you have to be ready for complications. There is a risk of relaparotomy multiple times. The first patient which I showed, we actually relapsed her 4 times after the transplant. Now, if you're young, you will absolutely sustain those 4 relaparotomies. Whereas if you're a type 2 diabetes and unfortunately end up getting a complication, so what happens is you might not survive the complication of the diabetes. But having said that, if it's a lean type 2 diabetic, there's absolutely no reason why we should not be offering pancreas transplants to type 2 diabetics as well. But I have still not yet taken the leap towards transplanting type 2 diabetics.
Thank you. Thank you. Any questions from the audience? This is a very interesting topic, not usually seen by GI surgeons and HPP surgeons. So any questions for Dr. Suresh? They want to know the cost of the procedure, Suresh.
So cost of the procedure, see, the thing is, I would say it would add on about 4 lakhs extra to the kidney transplant. So whatever the pricing your hospital is, so we generally price our kidney transplants at about 8 lakhs, to tell you the truth. So a pancreas transplant would add on about 4 lakhs more. And this is, I think, because of generosity of the hospital again, because it's a single operation, all it needs is extra few consumables. Other than that, absolutely nothing. It's a single operation, same amount of immunosuppression as we would do for a kidney transplant. There's absolutely nothing extra other than for a few lab investigations like amylase and lipase. So if the transplant goes off very well, so the hospital stay is actually the same as a kidney transplant. So I would say it is not really that much more or maybe I would say double the cost of a kidney transplant. I would say between 12 to 16 lakhs is what I would say for a simultaneous kidney and pancreas transplant. But if it's only a pancreas alone transplant, I think you could price it just as a regular kidney transplant.
Immunosuppression is same for both, sir?
Absolutely the same, sir. There's absolutely no change in the immunosuppression whether we're doing kidney or kidney pancreas together.
Okay. Thank you. Thank you, sir. Thank you so much for accepting our request.
My pleasure, Dr. Vimlakar. Thank you so much for having me on.
Thank you, sir. For the last talk of the day, I request Rohit Dama sir to grace the dais for the talk on islet cell transplantation.
So thank you, Dr. Vimlakar and team, for this opportunity. I'll be speaking on behalf of Sir, who was unfortunately not able to make it. It's about diabetes. So we all know with the advent of insulin, how diabetes is being controlled. But a lot of patients, in spite of insulin, can develop life-threatening complications and episodes of hypoglycemia. So those are the real cause of concerns. So advent of insulin was around 1920 and pancreatic transplant in around 1960. Following that, like we've progressed from open to lab to robotic, things have progressed and there is islet cell transplant available since 70s. There have been studies going on. And of late, because of the less donor pool being very less, there is a stem cell derived transplant also coming. So pancreas and islet cell transplant, there are no large RCTs which says which is better. We saw an excellent demonstration of a pancreas transplant, but those are definitely morbid procedures, and probably all patients are not lucky enough to get the donor pancreas, or they are not even fit for undergoing such major surgeries. So the idea remains resolution of hypoglycemic episodes, and that from 2010 onwards, they have shown some studies which showed good results with the islet cell transplant. So we already saw this about pancreas transplant simultaneous. It has its own problems with rejection. As I was saying, the donor pool is very limited, and a lot of donors they get rejected because of some strict criteria, the age, the alcohol, the pancreatic fat percentage, high BMIs. So it comes to that if patient is having a high BMI, they are often not candidates for islet cell transplant. And that's primarily because the amount of islets that they require is very high. It is based on the weight, it's per kg. And patients who are not fit for major surgeries because of some cardiopulmonary or old age, these patients turn out to be better candidates for islet cell transplant. So this is about islet cell transplant. We have both autologous and allogenic option. Autologous means the same patient undergoes surgery, either a total or a distal, for various reasons, obviously benign ones, where because of the pain, they are undergoing this procedure. So the remaining pancreas or retrieved pancreas is then treated and the same cells are transfused into the portal vein. So that's about autologous. Allogenic is like a donor where several donors, it can be a single cadaver or a multiple cadavers, and same procedure is then these patients are the one who need immunosuppression. So coming to islet allotransplantation. So these are human islets which are isolated from cadavers, and then after process, they are injected under radiological guidance by ultrasound. The portal vein is punctured and intra-portal vein, these are infused. And then they lodge into the liver and start working. So glucose stability is imparted within about weeks after these transplants, but insulin independence may take few months. So the reality is that 10% of the total islet mass, if we can obtain, then that can cause normoglycemia after partial pancreatectomy. So total islet cells are around 1 to 2 million in a average individual, out of which if 2 lakh islets also, if you can process and give it back, then these patients can achieve normoglycemia. Cost is obviously a constraint in this, and in allo, you need multiple donors sometimes. As I said, high BMI also remains a problem because probably then you need more islet cells for a higher weight patient. This is what had changed the scenario in islet transplant, and where first time without steroids, using the other immunosuppressants they had started. And following that, many modification for the immunosuppression, giving average results. Problems we saw, like in pancreas transplant, there can be bleeding, thrombosis, infusion-related infection, but the major problem used to remain the cytotoxic antibodies. So basically, because of the immune system fighting was the problem, and that gradually led to the islet function being deteriorating over time. So there came the role for autogenic islet cell transplant. So this is basically the same. The patient himself donates the pancreas, and usually these are chronic pancreatitis patients who had a bad quality of life because of the pain. And after multiple therapies, if these problems continue, that is where these patients undergo partial or total resection, and auto transplantation is then considered. So this is first time we got the approval in 2015, and we won't run this video, but basically the process is about a distal pancreatectomy and then the collagen perfusion and isolation of these cells, purification and re-injection into the portal vein. So before we were doing distal pancreatectomy is open. Now it is still spleen preserving distal pancreatectomy, which is then processed to get the islet cells. So these are the recent ones where only spleen preserving distal pancreatectomy. Islet yield after isolation for transplant is generally good, and 90% of these cells were seen viable and ready for infusion into the portal vein. This is ultrasound guided islet cell infusion into the portal vein. And so they then lodge into the liver. So then we had reported this case series. We had actually screened 14 patients, but 4 of them underwent this procedure. And this was the first case series reported from India, where after distal pancreatectomy, all these chronic pancreatitis patients underwent autologous transplantation. These were the details of those patients. But in summary, it was a safe and feasible procedure. Most of these patients were pain-free, and they resulted in significant improvement in glycemic control. 1 patient out of the 4 developed diabetes at the end of 1 year. And Global Islet Cell Club we could join. So as I said, this was about autologous. Allogenic, still the problem remains immunosuppression. So there was this development in this nature where they told that if you can develop a membrane which will safeguard these islets from the immune system, probably you can get rid of type 1 diabetes. So the whole idea was to get a membrane which is permeable both to oxygen, nutrients, and hormones, whereas the immune cells do not penetrate it. So if that we can develop something like that, then probably the islet cells will remain active for a much longer time. So for that, we had done this study where we did distal pancreatectomy in non-human primates. Basically, these were monkeys. And this is how they underwent distal pancreatectomy, isolation, implanted, and they were observed, and sugar levels were seen for a year. So what we developed was a theracide, which was like a membrane which will prevent entry of the immune cells. And this therasite loaded with the islets along with that membrane can be implanted subcutaneously. So these were implanted at multiple places in this. And this is where the implant was in the hand. And these patients monitored for their sugar, and at 6 months, 8 months, they retrieved those therasites and looked at how viable the islet cells were. So sugar was very well maintained after implantation in these animals. And after retrieval of therasites, we could see that the good number of islet cells was still alive. And that was basically because this membrane or this therasite used to prevent the entry of immune cells. And we concluded that without immunosuppression, these transplant islet cells can be kept viable. In our study, it was for about 15 months. They can be easy to apply. Subcutaneous islet transplantation can be done. And this therasite is a biocompatible and has engraftment potential. So this is the publication done where without immunosuppression, we could subcutaneously install these therasites. And this could be the future where, for humans also we can insert something like that. This is a small therasite which is subcutaneously put. Similarly, there are trials which are going on where endoscopically they create a tunnel and you can implant these therasites. And this is all without immunosuppression. So summarizing, the vascularized pancreas transplant, as we wonderfully saw now, it's the most effective treatment for type 1 diabetes. It has its own problems with immunosuppression. Whole idea is to improve the quality of life and see that these patients remain at least not hypoglycemic. They may not be insulin independent, but even if we can avoid hypoglycemia in these patients, that's a big boon. So islet cell transplant should decrease surgical complications and achieve tolerance, which may, and this is with these membranes, we can even eliminate immunosuppression. Thank you. Any questions? You can.
Mittu sir, to please conclude.
Thank you, Dr.
Thank you, sir.
An interesting talk. I mean, I just wanted to add a couple of comments. So 2010, they published the Edmonton Protocol, and there was a lot of interest in islet transplantation. In fact, my PhD was on islet transplantation, and there was a lot of excitement actually. In the UK, every center wanted to do islet transplantation, but the problem is I mean, they published the long-term 20-year results last year.
Okay.
And less than 5% of these patients actually are insulin independent at 20 years. And each patient needs at least 2 to 3 donor pancreases. So that is a big problem actually. And like you said, I think the only way islet transplantation can be clinically viable is by using immunoisolated islets. And I think there's a lot of work now in genetically engineered porcine islets which get immunoisolated, and they are hopefully that will be the future. But again, the problem is diabetes. The glycemic control techniques have become so good now with artificial pancreas that we really don't know what are the benefits and disadvantages of each of these procedures. But thank you. That was a very interesting talk.
Thank you.
Thank you, sir. I request Vimlakar sir to please hand over memento to Dama sir.
Yeah. Thank you. First of all, I want to thank all respected faculty and delegates who have spent all their precious Sunday. And I want to especially thank Kim Sunshine Hospitals for giving me this opportunity and to conduct and showcase and to connect with the people. especially our marketing team led by Mr. Santosh, Moin, and Ajay. And apart from that, if I will fail if I'm not acknowledging my team, especially Team Imlaker's efforts. In that, as you all know, Dr. Gaurang is the main force behind me for this type of academic programs, and he is supported by Dr. Raju, Dr. Jayant, Dr. Gaurang, Dr. Pawan, Dr. Dinesh, and Dr. Manisha Gopal, and Anurag. So all my team are putting their 100% efforts, and in that the main pillars are Mr. Teja and Giri, who supports them in all the ways, not only academically, in all the ways they support. And I thank all my team members also. So I thank all of you for coming and spending whole day. I know that we have promised to end by 4 o'clock, but I know I can't help it. Nobody can help it. So it will go like that. But anyway, till end, around 40 to 50 people are there. I'm happy for that. Total today, 230 registrations have come. 230 people have attended. 600 registrations have come, but 230 have attended. And in that, I think around at least 75 to 80% of the time, almost 200 people are there. I'm very happy for that. Obviously, after 4 o'clock, I can't hold anyone. So I'm very happy and grateful for all these things. Thank you, and thank you so much on behalf of Team Imlaker, Kim Sunshine Hospitals. Thank you.
పోడియం మీద కొట్టండి.